Perfect, sounds good. So I'll go ahead and get started. All right, so good morning. On behalf of the organizers, welcome to the second annual West Coast Vascular and Interventional Symposium. My name is Navjeet Dulet. I'm a resident at the University of Arizona and lead organizer for this symposium. We're very excited for the content that we have planned over the next 2 days. Today, we will be starting with core curriculum about VIR interventions, including patient presentations and follow-up, discussing the importance of critical care in VIR, addressing healthcare disparities as a trainee, and we'll be ending with multiple panel discussions and a vendor session, demonstration session, which we'll hope you will enjoy. This evening, we will have an angio club and meet and greet, and we hope to see you there. Tomorrow, we'll have additional content on international vascular interventional radiology, succeeding as a medical student, pursuing VIR, and finishing the day with a private practice panel. We hope you enjoy our planned content. We are hoping for this event to be as interactive as possible, and so please feel free to ask questions in the chat or Q&A section, and we as the organizers or the panelists will answer them. I would like to also thank all of the organizers and presenters for taking the time out of their Saturday and Sunday to join us and helping to make this event a success. I would like to introduce our first speaker, Dr. Joji Vaticancherry. Dr. Vaticancherry is a program director at Kaiser Permanente, Los Angeles, where he has built a model clinical VIR practice. He is a mentor for countless medical students, residents, and attendings, and he was instrumental in shaping the West Coast Vascular and Interventional Symposium. He will be providing an introduction to vascular and interventional radiology. Dr. Vaticancherry, I invite you to share your slides at this time.
All right, hey, appreciate the kind words. Really excited about kind of getting this ball rolling. So this is the courtesy of Christy Patel, kind of some of the West Coast VI swag. I'm Joji Vaticancherry, so let's initiate the conversation. So I want to just talk about the future of surgery now. And basically it was founded, as you said, in 2020. It's a patient-centered, surgically minded, and we really want to have broader outreach than we've historically done. We're a new specialty, pre-meds and early med students. And so please ask a lot of questions. No questions too big or certainly too small. And I constantly ask questions, and that's how I learn. So what are we? We're a minimally invasive specialty, okay? We're surgically driven, precision, okay, and targeted therapy. And that's what really medicine's shifting towards, is a targeted therapy. And we're technologically advanced. We're in the forefront of technology, and that's really what innovation technologies really brought us to the forefront. So how did this happen? Okay, in the field of radiology, there's this gentleman, Dr. Seldinger, a Swedish radiologist who figured out this very simple concept. And it's just like fire and the wheel. They're very unique and simple concepts that transform humans' existence, right? So he figured out a way without cutting the skin to get a needle into a vessel, put a wire through this hollow needle, and then put a catheter. And with that catheter, with that technique, he's able to image the whole body because the blood vessels are a highway. And from anywhere in the body, from the wrist, from the foot, from the hip, arteries or veins, I can go anywhere in the human body from the tip of the brain to the tip of the toe. But really the world of medicine, that was just to take pictures and kind of diagnose things. When did things change? In January 16, 1964, the youngest chair of a radiology department, Charles Theodore Goiter, had a patient who was referred to him before the interventional surgeons did any type of surgery, but they were just kind of diagnosticians. This 82-year-old lady had bad heart failure who had gangrene of her toes and was only offered an amputation because her heart was too ill to do anything more than that. Absolutely said, I'd rather die than get amputated. So this Dr. Goiter was asked, can you do anything? And in fact, he did. He opened up this very focal stenosis / occlusion of the superficial femoral artery in the mid-thigh. And with that, she healed her leg and lived 3 years more with her legs, both her legs, was able to walk on her legs, and ultimately died of her bad heart failure. And really, the world has never been the same, and it will continue to evolve. And this is, again, the great Charles Goiter. And this is Melvin Junkins, his first fellow, who figured out a way to do coronary angiography. Look at the heart vessels making these shaped catheters, which are still used to this day from transfemoral route. Joseph Roche figured out, hey, let me use this highway to stop bleeding in the human body. So he stopped a gastroepithelial bleed using an autologous blood clot back in the 1970s. Grunzig is a coronary angiographer who did the first angioplasty of the heart to stop a heart attack. Colapinto figured out a way to shunt in the liver from a band-aid in the neck. He could do liver surgery. And this great Julio Palmas developed a metal stent to keep things open. So where do we sit in the medical universe? The beauty of, one of the challenges of medicine now is become so subspecialized and super specialized. And so you only focus on one thing. So you've really taken that 20 potential person and shifted them to a very focused individual. Whereas interventional surgery, we work in the GI, every organ in the human body we're working in, which is pretty exciting from the head to the toe. And so it's really the Renaissance physician of the modern era, right? And I think that's what's really compelling, exciting. So what are the tools that we use? We use kind of needles, wires, catheters, tiny little catheters that are called microcatheters that get us to the tips of the toe and to the tips of the brain to pull out clot or treat tumors at a very almost a cellular level, which is pretty exciting. And different like balloons to open up vessels, different rotor-rooters, lasers, very advanced technology that every day something new pops up just based on the innovation of the population of engineers and physicians that are in the specialty. And then these are some of the needles that we use. Different shape wires, different types of wires, different densities of wires. They're like 0.008 of an inch, the width of some of the wires that we use. So very fine work and very tiny vasculature. We also use different shape catheters to get us throughout the human body, which is very exciting. And these tiny microcatheters that keep on evolving to get us further and further into the areas that we're trying to treat. We also use different kind of devices to pull out foreign bodies. And this is just an example of a snare that we use. And then different types of stents to prop things open. So a little metal scaffold, once we open up the blockage and rotor root, we now pop it up with a metal stent to kind of scaffold it. This is just an example of the balloons that we use to crack open blood vessels in the brain, in the neck, in the heart, in the legs, in the kidney arteries, and et cetera, everywhere else. So very exciting stuff. But we also, modify grafts, and we have advanced technology where we have these prototype grafts that are developed initially by the great Michael Dake for the thoracic aorta, or the Juan Parodies of the world. And now we're able to fix the heart, the aorta from the valve all the way to the toes. We're able to open up the circulation or fix the aneurysms using this very advanced technology. And again, we can remove blood clot and stop bleeding. It's pretty exciting stuff. And I was just talking to Dr. Rana Day earlier about some of the great stuff she's using, including the AngioVac device to pull out clot. And, there's a whole slew of different devices to remove clot. Some of this is no longer existing, like the Trellis device, but the Nari, FlowTriever, ClotTriever, AngioJet, Penumbra are all devices that are now enable us to, in the last decade, that have transformed the world of clot removal from anywhere in the human body. And what do we do? It's vascular, non-vascular kind of non-vascular procedures include interventional endoscopy, which you'll probably hear about today, where you're putting tiny scopes, which used to be the realm of GI or other doctors. Now interventionalists like us are using it. So that's why the word radiology no longer really makes as much sense, because endoscopy doesn't require X-ray, right? So it really is just interventional surgery. This modern era of interventional is just a surgical field. Very exciting. All right, we can ablate tumors, we can kill tumors, and we use this beautiful highway where we can get to the cellular level. That's a very complex network of trees and branches to do the work we do. So it's very, very exciting that we were able to do this, and technologies enable us to push it further and further. So what other things do? We remove clot, right? Clotting can be life-threatening. If you have a clot in the brain, it's a stroke. They can't walk, they can't talk, they can't eat, they can't speak. Blood clots in the lungs or the heart that can travel from the legs. And it happens, not infrequently. It's called DVT or pulmonary embolus. We can capture that clot. We can remove that clot. We can put filters, metal filters, to prevent the clot from going to the heart. Okay, we deal with varicose veins or superficial veins that are bothersome to patients, and we fix blockages in blood vessels from the head to the toe. We also fix aneurysms, which is a bulge or ballooning of an artery that happens to some people as they get older or smoking related, and we can fix that with a metal stent from inside without cracking their chest, putting them on bypass, or cracking their whole belly where they're no longer the same person. We can basically send these patients home the same day with a Band-Aid or two. Pretty impressive. Okay, and this has all happened during my career, which is pretty exciting. And we prevent limb loss. And, I'm really passionate about CLI fighting because a lot of these patients are underserved population. They're a vulnerable population, and they often are not given the option of seeing a vascular interventionalist who can revascularize their legs and prevent an amputation. So I think that is an important thing that we as all kind of interventional surgeons need to step up to the plate and provide that care. Women's health, it's exciting. I didn't think I'd be doing this when I graduated medical school, but it's very rewarding, and always excited to be able to help these patients who have severe symptoms. I just saw a AP teacher of biology who's in her 40s, who's had a couple of kids, and she's just miserable from her excessive bleeding in her periods, and she wants this procedure done yesterday, and I'm very excited to be able to help her. We can also help patients who are not able to have kids by opening up the fallopian tubes, and so it's a fertility preserving procedure. So things like that we can also do. I know there's some people here, including Rocky Ahuja, has done a lot of stroke therapy, and on the conference call, you can kind of comment on the exciting thing of the fourth leading cause of death. You only need to treat 2 or 3 people to make a difference. Tremendous amount of difference that we can accomplish by doing this. The other thing that we can do is stent the carotid arteries to prevent strokes. We can fix aneurysms in the brain that are bleeding, and unfortunately, many of us may have had a loved one. In fact, I have, who passed away from an intracranial aneurysm at an early age. And if this can be globally done, the impact factor would be great. And I think this is another reason why interventional surgery has to be propagated, not just here, but internationally. So we do a lot of emergencies. In fact, when I'm on call, this is basically what I'm dealing with: infections, clotting, and bleeding. All right. So it's a 24/7 important service that we're providing. We're stopping life-threatening bleeding. My colleague did an 8-year-old last week on Wednesday night at midnight till 7 a.m. who was having a bleeding tumor that they couldn't stop in the OR. So it's a big deal, right? So he was able to save that life of an 8-year-old kid. I can't imagine if that happened to my kid. Coughing up blood, bleeding from the intestines, after giving birth and bleeding out. I mean, I've been lucky enough to get called at 2 a.m. to fix those patients and salvage their lives. Things I still will remember until the day I die. Trauma, from traumatic injuries. Now look at where our role is in medicine and in the population at large. How much COVID-19 did we see? I'm sure the people in New York City saw a ton of it, and so have we. Putting in catheters and doing dialysis work and PD catheters on patients with COVID, stopping bleeding and intestinal bleeding, removing blood clots in the lungs or the brain on these patients. Okay, so look at in all the cancer work that we do outside of COVID-19. We're a huge cancer population of treatment that we do. Interventional oncology. We do a lot of vascular conditions: peripheral arterial disease, renal disease, chronic mesenteric ischemia of the intestines. So we fix a lot of these problems. Stroke, the number 4 killer before COVID-19, also our specialty is heavily invested. We see a lot of diabetics and a lot of dialysis patients. So that's part of our milieu. So you can see our influence in healthcare is very high. This is just an example of an aneurysm repair that I did years ago, but this is my colleague, my newest colleague, Dr. Consagra, did 3 aneurysms electively, so that they don't come to this point where they rupture and burst and bleed out. Luckily, we were able to salvage her. She was an ill patient. We were able to salvage her by blocking off the internal iliac artery, using a gas to take pictures, and deploying a graft. And this is our follow-up scan where the white is the blood, and this is where the blood was, and the aneurysm is no longer there. And the beauty of this is with these percutaneous techniques, this is the incision site, which is smaller than my thumb. Pretty exciting. Now, we also, one of the things about our specialties, we're always innovating, right? And that's the exciting thing. So today, I've already learned so much from just talking to Dr. Renan today about what she's done with the angiovac. I've learned from Dr. Park, who was on the thing, from his kind of webinar on RF ablation, and been able to provide that care. So we innovate all the time, and we discuss. We're a close-knit community who's always excited about learning from one another. This is a patient who was referred to me for a second opinion because he's going to undergo open surgery. He had a renal transplant. He really didn't want to give that up. And it is para-SMA aneurysm. And this is kind of before modifying grafts. This is, quite a while ago, before, maybe 8 years ago or so. And I wanted to preserve his kidneys. I did carbon dioxide. I measured inside the vessels to measure everything with what's called intravascular ultrasound, which is this. And then I did what's called a snorkel, where I parallel grafted this intestinal arteries, celiac and SMA, and then grafted in the aorta to fix the aneurysm. So preserving the flow to the intestines, preserving the flow to the kidneys is what I was able to do. And this is kind of the technique. Because initially what I had done, I'm like, listen, the surgery approach makes a lot of sense. They're going to do a bypass, a pump bypass to the kidney. But unfortunately, during the surgery, he basically went into arrest and was coded and was acidotic. So when he said, I don't care what you do, you got to fix whatever it is, I don't care. And so when these patients come to you with these problems, we have to have solutions. And again, I'm able to call my colleagues around the country to ask for their insight and input on how to repair these kind of challenging things. And again, that is the exciting thing about our field. This TIPS procedure is pretty cool. So this is a patient who had massive bleeding. They were coughing up pints and pints and gallons of blood from their mouth. Their blood pressure is taken because there's no blood to get to the brain or to their organs to feed oxygen and nutrition to the body. So again, this is what Colapinto and others developed. Going through the neck, through the heart, into the liver vein, we're able to connect the two veins. So we're connecting the 4 or 5 to 10 with an exit ramp, essentially. We're connecting two highways that are usually blocked with a shunt. Again, all percutaneously. This is the portal vein with a small metal stent. And that's pretty cool. And the pressures drop, the bleeding stops, and the patient recovers. So life-saving procedures is our middle name. So if you like the adrenaline, this is a great specialty for you. We also help patients, like I said, who have excessive bleeding. I was lucky enough to see several patients that I can't wait to treat, but more importantly, I can't wait to see them at 6 weeks and 6 months and see how much their quality of life has improved, right? So we deal with life-threatening conditions, but we also deal with bothersome conditions. And when I can see them feel better and just happy with a smile on their face, who were initially miserable coming into my clinic, but in 6 weeks after, they're just ecstatic and illusion and give you a hug. Pre-COVID, hugs were a guarantee. Nowadays, obviously, it's a little bit different, but very exciting that your patients get this kind of benefit from a Band-Aid in the wrist or their groin with very minimal recovery, right? They can go back to work, they can go back to living, they can go back to doing their thing almost as essentially as an outpatient procedure, as opposed to having scars and other things that, are not necessary. And this is the MRI looking from the side. This is the fibroid mass. This is the bladder is really squished aside, and the rectum and colon can be squished to the back, and this now is gone. Essentially, the bladder has all opened up, so urination is a lot easier, and all these other things. The pain improves, and the bleeding, most importantly, if that's their chief complaint, improves dramatically. I have 3 neurointerventional colleagues who were lucky enough to do aneurysm coiling. And I used to, when I first started, I was assisting in many of these and pretty exciting stuff. So before, you had to crack the brain, crack the skull, take out the skull, identify it. And there's a lot of elegant areas that are focused on speech and movement and breathing that can be impacted if you go the wrong way. Well, we don't have to cut through the brain. We go through the highway of the arteries, right? So, and find that aneurysm and plug it with the metal coils. And this is something our residents now get 3 months of training in. And it has a lot of overlap throughout the body. I do this in kidney artery aneurysms, hepatic artery aneurysms, anywhere in the body we can treat in the same technology, same technique that we use in the brain. So it's pretty exciting. And this little bump, when it bleeds, it causes hemorrhage and a blood clot, and then the brain can herniate downward and the patients can die, or it spasms the vessels. So we want to really prevent this kind of rupture, et cetera. And we're able to do this, or even if it's ruptured, we're still able to fix it. And ultimately, this is the brain looking at it. This is the metal mesh that we put in to prevent it from rupturing. So again, very exciting. This is a CAT scan of the head showing the metal coils. And these are the coils on the angiogram. So again, before, after, and that prevents a fatal rupture and really a Band-Aid, and a short stay in the hospital and rapid recovery. unlike an open brain surgery. These are so many devices that I showed you to remove blood clot. And this is a patient that I was lucky enough to treat years ago, who is a young gentleman in his 20s who basically couldn't move. He had what's called tetraplegia or locked-in syndrome. It's like the Metallica 1 song where you're aware of what's going on, but you can't respond to the world, right? So a very scary thing. And it's from what's called the back of the brain or basal artery thrombus, a 90% mortality. And I was able to assist my neuro colleagues and we removed this clot. And there's no brain, you can see no blood flow to the back of the brain before and after this clot removal. So this is something that, soon after the procedure, he started to move and was able to kind of utter some mumble something, which is a pretty impressive thing and like a life-altering thing for this young person. So again, before this little dark clot in the basilar artery thrombus, and after we were able to clear it. Pretty exciting stuff. Well, we do the same plumbing elsewhere in the human body. This is one of my patients, though I don't do a lot of renal stenting anymore, but I still just got a consult this past week for a patient who, his blood pressure is super high, the kidney function down because of the hormonal imbalance. The renin, which is made by the kidney, goes really high when it doesn't see flow. And when that happens, it raises the blood pressure, requiring 5 medications or so. And this is a patient that had that same issue. She lost her left kidney. She was on 5 medications, including a diuretic, maxed out, and still with elevated pressure. And when you have high blood pressure, your eyes, your kidneys, your brain, your heart are all impacted. And your body is not supposed to see that pressure. You're not supposed to see a torrent of rain or monsoon. It's supposed to see a drizzle, the organs. So we were able to cross that blockage and put a metal stent and open it wide open from a trickle. And then her blood pressure markedly improved and we were able to discharge her. And then I follow them with sequential ultrasound. So I follow my patients every year for the rest of their life that I put a metal stent or implant in. So I have a long-term relationship with many of my patients, which is really exciting. This is another truck driver who I saw in the ER because his leg was in severe pain. It was blue, it was cold, it was lack of pulses, and he was having a little bit of motor disturbance. He couldn't move because his lack of circulation to his foot. And the reason why he's had this aneurysm in the back of his knee that had showered clot. And I was able to put a stent graft in to cover this aneurysm. This is the metal covered stent graft. And then I put clot busting medication to open it up and he did great. Was able to discharge in a couple of days and regained his motor function, regained his ability to move and feel his feet and everything. This is one of my, my colleagues, one of my patients who had cancer and had claudication. Normally, I'm not super aggressive about claudication, but he really was miserable. He couldn't stop smoking and he only had a certain amount of time on earth and he wanted to spend it with playing with his grandkids and not having severe pain where he couldn't do that. So for that reason, I went from above and below. So from the left side of the highway connects everything from the right hip, the left hip, and basically kind of connected the dots, snared it out, and then was able to stent it with a metal stent. And he did great. And he was at least able to play with his grandkids. And that was what I was trying to achieve. And it's funny, it's not funny, actually. It's one of my colleagues just had a severe claudicant with almost Dr. Consagra with the same distribution on the left side that he did with Dr. Bott this past Thursday. So, this keeps on coming. These themes keep on coming over and over again. Various devices to remove clot. This is one of my earliest cases at the old hospital where I was working with this wonderful Sylvia Gonzalez, who's one of my favorite charge nurses, amazing interventional nurse and great assist. And this poor lady had what's called Trousseau syndrome. It was pancreatic cancer with hypercoagulability. She clotted her arm veins to the point that she had dead skin. And so she was essentially going to be on, amputee if we couldn't resolve this because she was having ischemia, such severe necrosis and ischemia. So I was able to use this older version of the angiojet, clear it out and elevate her arm, and she was able to resolve that. So at least, pancreatic cancer, she had metastatic pancreatic cancer. We knew she wouldn't have a lot of time on earth, but God forbid we want to improve her quality of life. We were able to accomplish that. So I still remember that patient, remember talking to her and how miserable she was and how afraid she was, and to be able to help them in their time of need, indeed, is something very powerful as a human. Trauma, this is or either intentional or traumatic, iatrogenic. This is a patient who had a Whipple for a pancreatic head mass and had all these drains. One of these drains was having some blood. We did an angiogram, and there was this abnormality here. So I crossed it, and as I was getting my sheath in and my wire, this is the 18 wire here, and I shoot, his brush stroke goes from normal, which is like 140 to 70. He's diaphoretic, and he's essentially becoming unresponsive on my table. So I quickly got a covered stent in and deployed it. And basically that covered stent plugged up the hole. And then basically he survived. He's still alive, you know? So let me tell you something that's kind of unique to my experience is a first ever medical student. So I've had med students forever, but my first ever med student, many of them are on the call, Navjeet, Henry, et cetera. He calls and tells me his mom is having massive amount of blood coming out of her mouth, and wanted to stabilize her enough for transfer. But I'm like, dude, she needs to be taken care of at a local facility in OC. We got her to her. I walked up to the ICU at 6 in the morning on a Monday morning, 6:30 in the morning, and she coded. And the son's a cardiology fellow at the time, and they were doing she went into VT arrest. They coded her, got her back. We intubated her emergently, got her to her suites. My colleague was able to embolize it, Dr. Harley, and block it off. Crazy thing is, the reason I know, not only is my med student, his dad is my patient who I ablated the kidney cancer of because he had such a bad heart he couldn't undergo surgery. And both of the parents are doing great. The son is a good friend of mine now, and I take, I'm their personal physician of sort. So this is, a decade of knowing that family and following them yearly. Other things we do, and I know Dr. Renati does a lot of this, is cable thrombosis. This is one of my original angiovac cases, and you may hear about it, but it's basically a veno bypass. And this was like, early on in my kind of experience, but this guy couldn't walk his tree trunks. He was on opiates all around the clock. Using this cardiac pump bypass, we were able to remove all this thrombus. The most important thing is he was able to be off IV opiates within 24 hours, and he was able to ambulate the first time in a few weeks in a couple of days. Pretty excited. This is a PhD professor from USC who couldn't ambulate because, again, his legs were so swollen. He couldn't walk or bicycle or do things that he wanted to. And this chronically occluded, and this is, again, years ago, I was able to open up his legs and get him back to cycling, put in a metal stent, open up the chronic blockage, and get his quality of life. We also retrieve foreign bodies. And I know Dr. Helena was talking about the patient that she saw, Dr. Doe. This is another patient of mine that I had who had bariatric surgery and had a metal of the filter break. It's a spear in her right ventricle, which the right ventricle is thin-walled. If it perforates, it can cause what's called tamponade and massive bleeding. I was able to remove this percutaneously. It's very hard to see. It's a thin thing, but it's like a needle. Pull it out of the heart. Instead of cracking the chest and trying to fumble through it on bypass and cracking the sternum, we were able to do this with a small incision in the groin. And it comes out, and there. See, this is like a spear. If it perforates the right ventricle, the patient could bleed to death. So very exciting to be able to do that. Well, I also did that in the kid, where we were able to remove a foreign body from the heart, which was initially sent for heart removal, heart surgery to remove. And I said, let me give it a shot. It was a kid with a cancer who had a catheter, and it broke, and we were able to snare it. And the cardiac surgeon was sitting outside. Again, this was early on when I kind of started, and he was like, "Oh, don't waste too much time. I have an OR slot." I'm like, "Let's take this. Let's give me a shot." So it's a little stressful because he was a disbeliever in interventional. But then I think all the family and everyone is very appreciative that we got this out without cracking the chest. And now this is a common occurrence, right? So future is bright. We're going to continue to innovate. We're going to go to the valve from TAVR, arch reconstruction, and fixing aneurysms. We're already treating, we were treating BPH already, prostate embolizations here. We need more data to really validate in the US, but the UK, it's a common therapy. Treatment of obesity, there's going to be many people on the panel today. Dr. Vaira Murthy, Dr. Goke Akinwande, who've done a lot of research on this with Dr. Weiss. Treatment of arthritis, genicular artery embolization with Dr. Bagla, Dr. Padia. There's some great work going on here for knee arthritis. Hypertension, which is a big disease, renal denervation is making a comeback. And I think the evolution of VIR is really that we've converted from technicians to clinicians, and a lot of data to support that. Okay, we're really minimally invasive, maximum effective, patient-centered care. It is a surgical field with a lot of emergencies, long operations requiring intense training, stamina, and focus. It's a new specialty back in 2012, a new surgical discipline, 6-year training. It is not radiology or opto anesthesia or dermatology. It's a fundamentally different group that we're recruiting. Surgically minded individuals who are passionate about patient care, adrenaline junkies, want to save limbs and lives, stop bleeding, remove clots, and cure infections. Find your mentors, a lot of data and a lot of sites that you can join. Join SIR, it's free. And we'll talk about this on Sunday, kind of what keys to success as a med student. Plenty of meetings. Here's my email. Thank you so much. I'm looking forward to the rest of the day.
Thank you very much, Dr. B. We all are always really excited to hear your presentations. I would like to introduce our next organizer moderator, Lindsay Webster, who is an MS4 at Emory University. Lindsay, take it away.
Thank you. It's my pleasure to introduce you today, Dr. Mona Renate. She's a vascular and interventional radiology attending at the University of California, Los Angeles. She trained in radiology at the Medical College of Wisconsin and finished her fellowship in VIR at Mount Sinai. She's an expert in many arterial and venous conditions, such as fibromuscular dysplasia and peripheral arterial disease. Her particular interest now is in women's health interventions, and today she's going to tell us and teach us more about PAD. And in the chat, we'll have Dr. Bott and Dr. Vatican Cherry, two VIRs who will help answer any and all of your questions. Thank you.
Thank you for the introduction and good morning, everyone. So overwhelming to see 167 participants this early in the morning. This is amazing, and I'm just excited to be here. And I do enjoy PAD procedures a lot. PAD, or peripheral arterial disease, where you essentially see patients with little blockages, little or large blockages, and you are able to have, a minimally invasive option for these patients to open up their blood vessels. And not only do you have immediate gratification from just seeing the images that now, you had a path that was blocked that you've opened up, but you also have, very satisfying professional experience from building relationships with these patients, because a lot of times this is not a one-time only interaction with the patient. Patients that have PAD will become your patients, and you will end up not only seeing them in acute settings, but actually kind of doing a little bit of outpatient medicine and really getting to know these patients. So it's a very gratifying experience. I have 10 minutes to talk about PAD, so I'm going to go over just a general, essentially, definition and what we can do for these patients, and talk about role of IR in treatment and management of PAD. So definition, disease burden. So current prevalence of PAD in the United States is about 7%. So it affects about 8.5 million adults. CLI, or critical limb ischemia or limb threatening ischemia, refers to, more of a sort of a diagnosis that patients carry when they're going towards that extreme where they might lose their limb or they're starting to lose their, toes. And that about, ranges about 1.3% among individuals over 40 per recent study. And obviously this recent study is looking at numbers back in 2008. So the numbers haven't really changed a whole lot since 2008, but that range is about, the same. So of these patients, you'll see that, of the patients that carry the diagnosis of PAD, 50% are asymptomatic, 33% may have atypical symptoms. So they may not have the classic claudication, which is essentially pain when they're exerting themselves, when they're walking, when they're exercising, that's relieved with rest. Some of them will come in with thigh cramping that's in the middle of the night. Some of them will say numbness and paresthesias. And a lot of these can be confused for symptoms of peripheral neuropathy or neurologic as a result of spinal issues. And so you may not be able to essentially call these as classic symptoms. Like I said, 1 to 2% patients with CLI, and ALI refers to acute limb ischemia. That's usually someone that you see in the hospital setting where they have a cold foot. And so you have a cold, discolored foot that has lost pulses, and that's basically suggesting that the limb is threatened and may need to be amputated, unless someone that may be skilled in endovascular skills can go in and suck out the clot and or essentially open up the blood vessel and restore blood flow. So why does it matter? I really like the schematic here. You can see that with lower extremity atherosclerosis, you can have changes in the musculature of your lower extremity. So you have reduced myofibers, impaired mitochondrial function. You end up with muscle damage, which is going to result in reduced leg strength. And now this person that has reduced leg strength is less likely to ambulate. So you end up with basically not only the immediate effects, which is exertional limb symptoms, which would be, that claudication that we see, but you result in, or atherosclerotic disease or PAD can result in functional decline and poor quality of life in these patients, and puts them at higher risk of, having wounds that are not healing, leading to amputation and then, infection and death. And so underdiagnosis of PAD is a barrier for also effective management of their atherosclerotic disease elsewhere. So someone that has PAD also has a risk of having MI and/or stroke. And so recognizing PAD and putting the patient on the right medications, or referring them to your colleagues that might do the medical management of these other things, and at least start screening and also diagnosing some of the associated ischemic cardiovascular risks in the patient can really save lives. Atherosclerotic risk factors are prevalent in PAD patients, but they're less likely to receive intensive treatment. So putting these patients on antiplatelet regimen, putting them on other medications that's going to, help bring down their cholesterol or manage their hypertension, other such things that can really help with their overall health. And obviously, as interventionalists, not all of us have the capability of focusing on medical management, conservative treatment, long-term follow-up. But like I said, some of these patients come to you in an outpatient setting, so you end up developing a relationship with them, and you know their problems, and you're able to communicate with their PCPs or their cardiologists and kind of lead to more effective management of these patients. So most likely when you hear PAD, you think atherosclerotic disease, but there are other forms of conditions that can also result in PAD. And just to name a few, something like Berger's disease, vasculitis, fibromuscular dysplasia, are just a few of the other things that can also, the etiology that can result in downstream having effects of peripheral arterial disease. So we talked about intermittent claudication, which is cramping pain or fatigue that's brought on by exercise and typically goes away with the rest. These symptoms tend to occur in areas that are distal to wherever the arterial occlusion is. So if you have heard of this term called the Riche syndrome, which basically referred to aortoiliac occlusion. So if you had distal aortic occlusion, you just, either atherosclerotic disease or thrombosis, resulting in the symptoms would result in basically saddle anesthesia in the perineal and the regions of the buttocks, as well as erectile dysfunction and some downstream effects to the legs with ambulation and pain as well. Most of the patients that I see are claudicants. They end up coming to me with calf cramping and our symptoms, and that's suggestive of disease in the femoral or popliteal region. Many of these patients, like we had already discussed, do not experience typical symptoms of claudication or may not have clear limb symptoms at all. But recognizing whether or not they have PAD is important, because it can have, these patients may have overall poorer prognosis. And a lot of these patients basically are unable to ambulate in order to palliate these symptoms. So how are we different from cardiology or vascular? We use imaging. We are looking at their imaging studies. And so a lot of times you may see a patient that's bedbound or you may see a patient that's compromised, and you may not elicit a history that suggests PAD, but then if you look at their imaging and you see all of these calcified vessels, it's very clear for you to make the diagnosis and call attention to the fact that, I think this patient can probably maybe ambulate if they didn't have as much pain or their blood flow was improved, and you can kind of make a diagnosis where that diagnosis is missed. So clinical presentation of a patient when we decide to intervene, it's typically, we don't obviously need to operate on every patient that has symptoms or every patient that has an imaging finding. we clinically correlate, and people laugh about, using the terms clinically correlate, but that's what you really need to do, is match the imaging to the condition. And patient may not be saying what they're having, but if you can elicit that they are symptomatic from whatever imaging finding, then you get to basically 4 categories. Is this lifestyle limiting claudication that has failed conservative therapy, including an exercise program? Is this lifestyle limiting claudication with proximal disease? And proximal disease is talking about more iliac disease, which can be very easily fixed with endovascular techniques. Rest pain and ulceration refer to more downstream effects of having PAD, or more extreme version of having PAD, where now you're starting to have, chronic limb ischemia, and that can also be treated by endovascular techniques. So you start by diagnosis and testing. When you see a patient, obviously you're going to do a physical exam, which is measuring pulses, looking at the limbs that are involved. You may order a duplex ultrasound. So that middle image right there is just showing a waveform that you would typically see in an artery, and the color images are demonstrating turbulence in the vessel that appears to be narrowed. And essentially you'd look at systolic velocities through the area that is being measured and come to a diagnosis. You can also do something called ABI and PVR. ABI is ankle brachial index, and the image on the left is showing basically blood pressure cuffs on the limbs, where you would measure blood pressure in the arm as well as the ankle, and you identify if there's areas of stenosis based on what those readings are like. And the image on the right is showing pulse volume recordings, and that's basically measured in the same way. We're looking at blood flow through different segments, and depending on the type of waveform you see, you're able to diagnose whether, if it's a dampened waveform, if, blood is flowing across a certain area, and if that's normal. And the more standard things that we typically end up getting, whether incidentally or for pre-planning purposes, are a CTA or an MRE. So angiographic images, cross-sectional images, either with CT or MR, and you can, those are more expensive, can be more labor intensive. But if you want a clearer idea of what you're dealing with, you can get those images as a secondary thing in order to plan your procedure and/or for follow-up. So when you're looking at physical exam, I already talked about, you're kind of looking at their feet, you're looking at pulses, you're looking at, is there hair growth? Are there wounds that are not healing? Are they, you're eliciting a history of numbness or tingling, you're eliciting a history of cramps and where they have these cramps. And then you can discuss with the patients whether you have endovascular techniques. Endovascular means basically going in through the blood vessels, minimally invasive, image-guided procedures that involve either angioplasty, stenting, atherectomy, which is removing the plaque, and some of these techniques. And I'm sure you'll have, I think later on you have a session where you have vendors that are going through their products and what they can offer. And then you have to be very cognizant that surgery is still an option for some patients. We do see patients that come to us when they are typically non-surgical candidates, but when you're practicing on a level which is outpatient and you're seeing kind of all comers, you might get some patients that are able to undergo surgery, and surgery might be a more durable option for them. And I think it's your duty as a medical professional to kind of discuss all options with them, and for you to be aware of what options exist. So, we're partial to IR because we love IR, but you have to think about it from a patient standpoint. For someone with common femoral artery disease, a lot of times surgery is the best option, because you can really have a lot of complications from trying something endovascular if you're not, very experienced in it, or even if you are experienced in it. I think that, surgery can be quite quick and less laborious for treating common femoral artery disease. And I'm sure Georgie will comment on that, or Dr. Butt. So here are 2 cases. I just wanted to, highlight the points that I just made earlier with these cases. So here's a 58-year-old female. She actually has a history of a knee sarcoma that was resected, and she had an AKA. She presented to me for a port placement and a lung biopsy. And I tend to talk with my patients, and I also tend to review all of their imaging before I go see them, mainly because I didn't want to do the lung biopsy. I was trying to find another target in their belly to biopsy. But I ended up looking at their CT, and while I was reviewing the CT, I noticed that, she didn't really have much for her iliacs. They were extremely stenotic. We didn't have appropriate imaging. It was a non-contrast CT, but I was able to kind of just get an idea of who the patient was before I even went and laid eyes on her. And when I talked to her, I realized that she was having leaking from her stump. It looked like it was infected, and she was here for a port placement. I was just eliciting a history of, is this patient, able to get a port right now? Is there any active infection? And clearly at this time, I didn't think it was the right thing to do because she had an active infection of her non-healing wound. And so I ended up calling her orthopedic surgeon and asking them to get a CTA. She got seen in clinic. They, planned for a surgical intervention, and their idea was to go and debride the wound and, close it. But from my standpoint, that wound would have difficulty healing if we didn't fix the problem at hand, which was essentially the vascular supply. So this is the non-contrast CT that we saw, and I'm just going to point out calcified aorta, watch the right iliac artery. It goes down to almost nothing. And obviously, for someone that's not trained in radiology, that may not be an easy finding to make on a non-contrast CT, but someone that's read a lot of CTs, you look at that, I know that within seconds, this patient doesn't have good blood supply. And then you look at the other screen, when they did get a CTA, you'll see now there's contrast in this artery, and now it just goes out. There's no contrast in this artery now, and it reconstitutes at the level of the femoral. So proximal disease, diagnosed on a non-contrast CT, confirmed on a CTA. I brought the patient to, patient was inpatient at this point for her surgery and pre-op. We went in, did an angiogram. I came in through the radial artery, put a tiny catheter down, did an angiogram. I wanted to plan my approach. I didn't know where I was going to get access in order to open this patient up. And so clearly I'm seeing there's disease on both sides, but I see contrast on the left side, and I'm seeing not as much contrast on the right. I'm going to go back here, and you can see that I managed to get a catheter and wire to cross the area that was occluded, and was able to shoot I was able to aspirate blood from this blood vessel at this point at the level of the hip joint. And I was able to see that there is a femoral artery and there is a profunda femoral artery. So now I got access into the femoral artery in case I needed a particular size of stent, but I was having problems crossing the area of occlusion from the femoral artery access. So I ended up doing the entire case from the radial artery access that I had. So I'd gone from the wrist to fix an area of occlusion in the patient's iliac artery. So here's a balloon. After ballooning, I ended up using a stent because I, identified the problem was that there was atherosclerotic disease and some dissection in the common iliac, and then rest of the artery looked pretty normal. So by placing a short stent, now we fixed the luminal caliber of the iliac, and you can kind of see more robust blood supply. So patient was seen. I have the timeline here in September for her AKA. On 10/15 in October, she presented with this wound to me. And you can see within 10 days or so, she was now, obviously they did debridement, they fixed her. And then we're looking at December. So 2 months later, she said her stump is completely healed. There's no tenderness or palpation and there's no drainage, and everything was totally fixed. So, you see results like this, and it just makes you so happy for what you are able to offer to the patient. Here's another case 2, 70-year-old female smoker. She's a funny lady. She comes in also for a CT guided lung biopsy. Of course, I'm looking at all of my preoperative imaging before I go in and talk to her. And she's talking about how she can't lay on the bed. She has thigh cramping. She has neuropathy. She's taking her magnesium supplements because she constantly has these thigh cramps. Her leg muscle mass is diminishing. She used to be a dancer. She used to love to hike. She doesn't ambulate as much. And I'm like, all right, you have most of the smokers might present to you for an incidental lung nodule biopsy. What's being missed is all of this atherosclerotic disease and the quality of life that they suffer from this, lack of diagnosis or misdiagnosis. She's taking gabapentin and she's taking magnesium, and someone hasn't made the diagnosis of PAD in this patient. And so obviously we got some imaging on this lady, and we brought her to the lab, and I'm just showing you the key components here. Angiogram was done. Basically we did femoral access. We went up and over, we went over to the side that was affected. And here we see a short occlusion. She has atherosclerotic disease on both sides, but clearly she has believe me when I say her rest of her femoral artery looked pretty normal in caliber, and she has good 3-vessel runoff to the foot, except for this short lesion right here. And you measure pressures across this, there's a gradient. So I wanted to be very conservative with her. She's a smoker. She's not on all of the meds, and she's not optimized. So obviously I wanted to be conservative. I just did a little bit of ballooning. I basically did angioplasty for iliac arteries as well as her common femoral and superficial femoral artery, saw a good result angiographically, and I stopped. And the patient was then the patient actually was not put on aspirin because she was told to avoid aspirin because of her renal function. So once she was able to restart sort of, antiplatelets, better have medical management, I referred her to a cardiologist for the medication management in this case. And she's been doing better. I see her every, 3 months, 6 months, 1 year intervals with ultrasounds. And we're just starting to see that she's starting to redevelop stenosis. So you can see this is ultrasound image right here. And you can see that we're looking at peak systolic velocities in across all of the segments. So CFA, proximal SFA, distal SFA, and you can compare the right side to the left side. The systolic velocity is different on the right side as compared to the left side, and that indicates that there is probably an area of stenosis where the blood flow is faster, and downstream there's less blood flow. So basically, area of stenosis, and then the blood flow goes down, whittles down to almost nothing as it goes, as you're looking down at the calf vessels and at the level of the ankle. And so she's recurred. We're probably going to bring her back for some more interventions. And those are my 2 cases, basically highlighting the role of IR in management of PAD. You have a unique skill set. You have the ability to, very quickly perform image interpretation and diagnose a problem. And you can use your imaging technology for not only to guide what treatment you're going to do, but for access, for understanding if you're going to use extravascular ultrasound to navigate your catheters or wires in places where they need to be. You can use IVUS, which is intravascular ultrasound, to identify the size of the vessel, the lesion, if you're going to do atherectomy or stent it, what size stent you're going to use. And that endovascular skill set that you develop, from doing interventions all over the body. So you utilize tools and tricks that you've learned from the neurospace or the visceral space, from like hepatic angiograms that you've done. And you can bring that toolkit to the peripheral space sometimes and think out of the box and offer treatments or treatment options to patients that are otherwise not going to get those type of treatment options. And so it can be very efficient. It can cut out costs. It can cut out like all of the confusion with missed communication and multiple people involved in a patient's treatment plan or in patient care. And so you have less loss of follow-up if obviously you're the person that's dealing with all of their problems, including their oncology needs and their PAD needs, and seeing them on a regular basis for follow-up. So what can you bring to the table? You use your diagnostic skills. Always review all of your preoperative imaging, confirm the diagnosis. Don't believe what people tell you as a diagnosis. You make it for yourself. Do a efficient, I don't sit there and do a full, thorough physical exam like most medicine doctors would do. And I'm not capable of that skill set because, my skill set is different, but I do an efficient one and I try to clinically correlate. I look at the imaging and I basically am able to come to the right diagnosis and reach out to the referring physician and say, maybe the magnesium is not a bad idea. They probably are having some electrolyte issues, but have you thought about the fact that they're having claudication? Should we get, ABIs on this patient? So you can be very helpful in navigating care for this patient and be an advocate for your patients. And that's all I have for you. Thank you.
Thank you very much, Dr. Renate. We all learned a lot from your presentation, and it's incredibly valuable teaching points through there. I'd like to introduce our next organizer moderator, Nihar Gautam, who is a OMS4 at Toro University, California.
Thank you, Nav. Hi, everyone. It's my pleasure to introduce Dr. Gloria Salazar, who will be discussing venous disease today. Dr. Salazar is currently the Division Chief of Vascular and Interventional Radiology at the University of North Carolina of Chapel Hill. She has lectured extensively around the world regarding venous disease and uterine fibroids and has published multiple research papers on these topics. In the chat, we'll have Dr. Jeff Chick, who's currently the Assistant Program Director of the Vascular Interventional Radiology Residency Program at the University of Washington. Dr. Salazar, if you haven't already, can you please share your slides? And attendees, please feel free to ask any questions in the chat.
Thank you so much for the introduction. I'm so excited to be here with all of you and talking about venous disease. I'm going to take a different approach today. I'm going to just go for, the high level stuff and tell you a story about my life, which you probably know. So I started my career 12 years ago, and I was training about everything, just all the great things that we already talked about, except for neuro, because I don't think I've ever been to any cranial vessels, nor do I want to be. And I'm very excited to be in this field, and I'm very happy, and I would choose IR again 10 times over and over. So I'm going to talk about venous disease, but I want to give you a little bit of an idea of what's happening in the world right now with this topic, in particular with the stent migrations and education around how do we place a stent and what is the right patient to place a stent. But I'm also going to tell you a story about how I ended up being in this field. These are my disclosures. So everything starts with the recognition that venous disease is not only about varicose veins in the legs. Of course, we know that, and we know more now than we did 12 years ago. Believe me, I'm going to show you the chart of the publications over the last 15 years. And so when I started my career in Mass General, I was like, okay, I'm going to see varicose veins patients. I'm just going to ablate the GSV, and I'm going to be a happy person, and my patient's going to be happy. Not so much. Because when you look at this data, and this data is not new, this data is from back in 2003. And in this data, when we talk about varicose veins patients, in particular patients who have advanced stages, and I'm not going to kind of give you a basic classification, but C4 to 6, it's about patients that have already chronic venous hypertension, and they already present with discoloration of the skin and ulcers. So these are bad sort of venous patients that have really bad disease. And what we find is that back in the day, and this is true to this day, is that actually those patients also have a component of obstruction. It's not only in the legs, it's actually in the pelvis, or it's actually due to, let's say, thrombophilias and DVTs, deep venous thrombosis that affects the legs. So this is my very first patient in my clinic, and I kid you not, just like Gogi talked about, his long-term relationship with this patient, this is my patient, this is my friend. He's a farmer and in Cape Cod, Massachusetts, and he presented with to me in my clinic with this sort of compression, but I found out this compression later on. What he presented with is that he needed to ablate his GSV on the left side. So we're going to talk a little bit about this. And this is the distribution of how obstruction presents in those patients. And I'm going to focus today on non-thrombotic May Thurner, which, by the way, we don't call it May Thurner anymore. Please use the appropriate anatomical term, which it is non-thrombotic iliac vein stenosis. So here's my patient. You can see his leg compared to the right leg, even though it's not included in this picture. He does have the varicose veins that are probably, the most common thing that you're going to see in your practice when you enter the specialty. But when you look at the right leg, there's something is not wrong with this gentleman. I mean, this is not, for someone who has varicose veins, and he also has some discoloration of the skin, something's not right. And when we do the reflux, of course, he has some reflux, but he also has some deep venous reflux. And quite frankly, when you look at this leg and you think about where is the problem, you really have to think about whether he has, patients have a deep venous occlusion or obstruction or a combination of both. And this is when do we start thinking about sort of evaluating patients for iliac vein stenosis, AKA May-Thurner, is when symptoms that are out of proportion to the detectable infrainguinal pathology. Let's say you find a patient there's no reflux, in this case there was reflux, or a patient who has isolated left leg symptoms, severe chronic disease, like I told you, ulcers and discoloration of the skin, or when patients present with venous claudication, which is quite different than what Dr. Renata presented as arterial claudication. Venous claudication, it presents differently, like patients complain of heaviness and pain after, not right after exercise, but a long time after exercise. Another way of looking at those patients is, okay, so this patient has varicose veins. How do I think about to order the next step or to evaluate further with diagnostic testing? I mean, we are a specialty of amazing procedures, but we're also a specialty of amazing diagnostic skills. So here's when you need to think about it. Again, I already mentioned, pain out of proportion of ultrasound findings. Let's say you don't find any reflux and superficial venous disease. So you kind of have to think about perhaps ordering cross-sectional study or evaluating deeper with ultrasound in the iliac veins. For sure, patients who have prior venous thrombosis, please, please, please don't, in the history and your patient, in the clinical evaluation of your patient, these are things that you have to ask. And we're talking about the transition of IR to a more clinical specialty. Actually, we're always clinical. It's just that we needed to have the structure to actually be able to promote the changes in our practice and be able to kind of evaluate patients in a way that we were able to follow up longitudinally and as well as be able to refer when needed. Other things that you have to think about is, and for me, obviously, because I'm also a specialist in women's health, is that patients with pelvic pain can present chronic pelvic pain with venous disease, can present with iliac vein stenosis, patients with back pain as well. And again, venous claudication symptoms, I think, are pretty indicative of a more proximal obstruction. We mentioned IVUS. IVUS is an intravascular ultrasound. Dr. Renate, kind of talked about it, and I know Goji as well. So what I think it's important here is that historically, I started using IVUS early on in my career. I was not quite trained in IVUS because 12 years ago, I think we were all trying to figure out, and I think some folks have more experience in more of the arterial sort of area on IVUS. And so I started looking at IVUS and trying to come up with my own sort of criteria to when to stent or when to, kind of go to the next therapy sort of for my patients. Now, fast forward 12, 15 years, we do have some idea of how to do that. And recently we have been involved in sort of how do you categorize patients? What is our criteria for stenting? So here's data from the video trial where my colleagues, Dagny and others, kind of looked at sort of patients with non-thrombotic iliac vein stenosis. And they looked at all the patients that they stented. They looked at the IVUS findings, and particularly with patients with advanced chronic disease. Again, I'm pounding on this, these patients with ulcers and skin changes. And what they found is that when looking at the ultrasound, intravascular ultrasound, patients who presented with a 61% diameter stenosis from a normal sort of segment, let's say in this case, this picture below, and presented with a significant stenosis that in their threshold turned out to be 61% diameter reduction, predict clinical improvement, better clinical improvement. What does that mean? That means that the patients that were stented, that presented with 61% diameter stenosis, they did better. They actually really improved their symptoms, because that's what we deal with in this day and age with different interventions and different things that we start doing with innovation, is that which patients actually benefit from it. Is it a 30% stenosis or is it a 61% stenosis? So for me personally, I've always used more than 60% stenosis when treating non-thrombotic iliac vein stenosis. And I think the video trial gives us a little bit of an idea of where you want to be as well. So we don't want to do something that is not below 50%. But it's not only about the venous patients. And again, I alluded to this. This is one of my patients who presented with persistent venous pain and we already embolized gonadal vein. And you can see, I mean, even without the IVUS, this patient has significant iliac vein stenosis obstruction. This patient not so apparent like the other one, but you can tell there's cross pelvic sort of collateral iliolumbar sort of collateral here, indicating, you know, there's some proximal obstruction that may be of hemodynamic significance. So, and within that sort of topic, I just want to bring to attention, just as I discovered in my clinical practice 12, 15 years ago, that varicose veins is not only in the legs, it's not only about the superficial varices that you treat and make it look beautiful and better. Chronic pelvic pain for venous disease, for venous pain, also is not only about gonadal vein embolization. And we're debating about this, and I think there's, you know, very nice sort of discussions and conferences with my colleagues, and, you know, and it depends on where you're at. You know, in my practice, I see both. I see veins patients that ended up having pelvic sort of pain as well as iliac vein stenosis, but I also see patients that are gynecological that presents with pelvic pain and gonadal vein reflux, but then we find, you know, iliac vein obstruction. So this is a nice recent paper that demonstrates that, you know, contrary to what we thought, you know, patients with chronic pelvic pain not only have gonadal vein, but they may present with, you know, 4 times more of common iliac vein obstruction. And here's the data, and they also look at male and females. And by the way, not only females have chronic pelvic pain due to venous disease, male patients can also have that. It's not that common. I had 1 or 2 patients in my lifetime. But women certainly are the most common presentations. And when you look at this data, you see like common iliac vein obstruction is percentage-wise more prevalent in this patient population than you know, isolated gonadal vein reflux. I know I'm bringing a lot of different topics, and I just want to show you all that are looking at this chart. This is the level of or number of publications since 1988 to today, to 2020. About iliac vein stenosis, obstruction, May-Thurner. You can see how we have improved. So when I started my career, 2010, we have not, actually we had 1/3 of the data that we have available now. So I just want you to think about this. All of you guys sitting there, you enter the specialty, what we are probably gonna see is double the number of evidence with more robust, and this is what we need to do actually moving forward. And my purpose in showing you this is that ourselves, Gloria Salazar, you know, all of the other speakers, we have to adapt to those changes. And guess what? This is what's fun about this specialty. We always learning something new and how to better serve our patients. So this is the reason for why I'm showing you this. What you're seeing today probably is going to change in 5 years. And guess what? This is great. This is great. And this is what, you know, sort of, I think it's one of the highlights of our specialty. And in medicine in general. All right, so let's look back in history, or not history, but a couple of years back, Raju's data. And this was the first set of data that was sort of comprehensive and led us to a more, you know, observation of more long-term with the patients, because, you know, it's nice to put the stent. It looks beautiful in imaging, but as other speakers mentioned, if it doesn't lead to improvement of symptoms, there's no point. And this is our challenge, I think, when we talk about, you know, vascular, endovascular, IR, are we really improving patient outcomes? And does that make a difference in a patient life? And so here's a little bit of data about symptom improvement. You know, of course, when we look at different techniques, we look at safety first, and, you know, the bathing that can happen, and this is quite low, as you can see here, 1% of stenting. But when you look at relief of pain for venous disease, it's up to 94%. Improvement of swelling, and this is an important one, is not all that great in this data set. And quite frankly, in my experience, if you're going to stent a patient just because of the swelling, you need to be able to advise this patient that the swelling might not be 100% improved. And on the other hand as well, if you're only going to stent because of swelling, you know, be a little bit, you know, judicious about that. Healed ulcers, again, you know, not all that great, but it does help, 89%. And when you break down 2 different patient populations, patients who actually had thrombosis prior and patients who never had thrombosis, of course, and patients who didn't have thrombosis, the patency of the stents up to 5 years can get to 100%. The patients who had thrombosis prior to stenting, then it goes down to 90%. These are a couple of guidelines, and I think part of the reason that I'm showing this is to demonstrate that this was done in 2014. And if you look at the data chart that I showed you previously, there was not like the amount of data that we have right now. But this is another aspect of our specialty, is that sometimes we need to make recommendations, and we should make recommendations to make sure that we are treating patients for the right indications. And I think that's a very important value and mission for our specialty. We're not just going to be stenting because of the imaging. We're going to be stenting because we need to agree on which patients benefit from what. And here's from the European guidelines, the CIRSE guidelines. And when I started doing stenting, we didn't have this. So 2010, 2008, right? We didn't have any of this. When this came up, I'm like, finally, something to actually I can show the patients and say, hey, we all got together, we consensus-based determined that if you have obstruction and reflux, we'll treat you the reflux. And then if you fail treatment still, we can still treat you with stenting. And this is a nice sort of like way of looking at this paradigm. But what about the most recent data? So here is a patient that we stented and clotted off. So even with non-thrombotic disease, you can still have occlusion of a stent. And if you think about this, on a previously healthy patient without thrombotic disease, that's not quite what we want, right? And of course, we were able to clean it up, and it looks great here. But, I'm showing you this because everything that we do as placing as simple or difficult as placing a stent has an implication, and we need to discuss this with the patient. So long-term patency is an important discussion with your patient. And here is different, about over 10 different studies of outcomes of stents. And I have to tell you too, that within the United States, we started with non-venous stents. We started with, self-expanding stents that were not manufactured to be placed in the venous territory. But then, in the last 4 years, we actually had FDA approval for at least 4 or 5 stents that are dedicated for venous disease. And so we're looking again in our data from those trials, and that has changed significantly the way that we place stents and also the way that we practice. So when you look at this data, many different papers starting, back in 2000s, 5, 10, and then, kind of pretty much the same thing. When you look at symptom relief, you can get to up to 90, depending on the data set. Healed ulcers, you can get to about, 100% depending on the data set. So you see the variation. Primary patency, like you look at this, 60%, and then you have to re-intervene, and secondary patency becomes better. You start wondering why you had to re-intervene. Was it an anticoagulation issue? Was it because you needed to extend the stent, et cetera? And here's the median follow-up of those patients. And again, I can tell you that just like Dr. Vacanteri mentioned before, I actually follow up my patients for life with stents, just to let you know. So it's a busy clinic after 10 years, even though I changed my practice now, so I'm gonna have to restart again. And here's what I mentioned to you. Now we have stents that are dedicated for venous disease. These are all sort of the trials that had been published thus far. And this is a nice review, a systematic review of all venous stents, not only the dedicated ones, but the ones that we started with back in the day. And you can see here, we have 2 different patient populations, the non-thrombotic and the post-thrombotic, and outcomes are different, but the majority of patients have advanced disease. Some patients have advanced disease here, and you can look at the 12-month primary patency. Overall, like in this first 2018 publication, you see that the non-thrombotic iliac vein stenosis, that's much better than the post-thrombotic patient population, and that's what we observe in our clinical practice. But if you mix both percentage-wise, you have a diluted number of 68. And then as we move along in the different trials, with de novo and Vitreous stents, you kind of have sort of similar or a little bit better patency, like with up to 100% of non-thrombotic and 87% of post-thrombotic patients. And I think, part of it is the way that the patients present, and part of it is, how do you place your stent? And here's what I am going to be talking about the technique. So it's not only about the data. Okay, you look at the data, it looks great, right? 100% patency of non-iliac vein obstruction, and great, I'm gonna just do that for my patient. Not so much, because the technique, and you need to learn that, it actually interferes with your patency. Here's a patient of mine, so I'm sharing my failures, okay? I'm open about this. I always show this one, and lucky for me, that was the only one. I hope I don't have any more of this. And this was back in the day when we used wall stents, the stents that were not dedicated for venous vasculature, and they had some, shortcomings when we placed them, because when you look at this one, when we placed the stent, this patient had an compression of the vein because of the artery, and that's sort of the big presentation, the major pathophysiology behind non-iliac vein, sort of non-thrombotic iliac vein stenosis, when the artery crosses over through the vein. And here's a cross-sectional imaging coronal view of the body of this patient of mine, where you can clearly see where the artery is crossing over the vein. And what you observe here at that my stent fell short. So, well, I placed the stent, it didn't quite cover the area that was concerning. And guess what? Now she has a clot. So that's not fun to see. Believe me, it hurts. It hurts me. It hurts more the patient, obviously. So what happened here? So what happened is that, I just want to place the stent just over this area, but those stents that were not dedicated to venous vasculature didn't have quite of a radial force. So I have to extend a little bit more. And I was afraid of extending too much into the IVC, into the inferior vena cava. And because I was afraid of extending too much, I ended up short. And these stents tend to actually foreshorten, over time. And this is exactly what happened here. So we had to intervene. So we want to be careful with the confluence, but we also want to be careful with being too short. And I think now with the venous stents is less likely. And here's the anatomy. This is the big deal for you guys to understand. So here's pelvic veins, common iliac veins, and then the inferior vena cava. Most of the compressions are going to be for the May-Thurner iliac vein stenosis are going to be on this area where the artery crosses over. And you can see this area is not an easy area because it's already at the bifurcation. So what are our challenges is that you have to cover this area with the stent, right? You do have to cover this, because otherwise you end up being like Gloria Salazar in that unfortunate case that we were able to salvage, but it's not fun. And then, not only that, you don't want to quite cover the other side, or even worse, kind of stent the stent into the IVC, where we know from data now, back 10 years in the making, right, from Dr. Murphy and others, that if you jail this with those other stents that we were using, you have a chance of a contralateral DVT in about 3%, or thrombosis of the other side. 3% is low, but it's not fun when a patient didn't have previously thrombosis. So I want you to look at this and remember this. This is what we're dealing with. When we look at the data in the papers, you need to be careful with this. And of course, there's variance. You can have obstruction even on the other side, and I've seen that, or even lower down. So what you want to do is have a stent that has good radial force to keep it open here, so you don't have to extend it all the way, and also be able to keep it, the other side open, and be able to leave it open. So here's the data of, sort of comparing patients that we did not jail the contralateral side and patients that we did jail the contralateral side. Like in this example here, the stent is extending far beyond the bifurcation. And what they found is that the patients that did not have the jail, that had less chances of DVT. So it's sort of, this is the gap, 90 to 99 free of DVT. So it's a 10% gap if you look in here. So we learned with that. We all learned with that, and we didn't want it to do that. But now this problem is relatively solved because we have venous stents that have quite good radial force, but still the paradigm exists because how do you determine the confluence? And you can do this with, catheters, just see, oh, this is where my other contralateral vein is, so I don't want to jail that. But at the same time, you want to be able to cover this. And so we're extensively publications on the technique now with the new venous stents, because it's different. And I go back on my patient that I started with. So here's what he had. He had a compression with the psoas muscle, with the sacrum here is significant. And that's why he had a recurrent sort of disease on the right side, on the left side. And Gloria and I didn't have quite the problem with the bifurcation here, because this was really far down, as you can see here. But then when I placed a stent, and I placed those stents that were not, sort of made for veins, you can see that I quite didn't went over this angle here. So 11 years later, this is just to prove that I actually follow up with my patients for life. So 11 years later, he presents with occlusion of this, okay? And what was the problem? The problem was quite right here at this curve where, just go back. At this curve when it got clotted up. So I had to, so here's my stent. And so I ended up having to crush to go through the struts of the stent, the holes of the stent, because these are non-cover stents, open up with a balloon, and then clear the clot, first clear the clot, then open up with a balloon, put another stent, one of those dedicated high radial force, and then open up for him. And here's the short film, the clotting, we cleaned it up, we put another, see how much clot here. We ended up kind of stenting, and he did good at the end, and we ended up doing that. So obviously, this is what we learned. And the other thing that we learned too is that we can actually stent the stent. So here's another patient that we treated. The stent is at an angle here, but then recurrent symptoms didn't quite clot. But then we decided to put a stent, and here's the stent being deployed over the inguinal ligament, which is an area that is controversial because it's thought to be known for stent fracture location. Now we know that's not quite the case, but these stents are very flexible now, so they can be placed in those areas. And here's the final result with a nice sort of curve and angle, and the patient does much better after we determine that. So this is in a summary, for the May-Thurner patient, now we call it non-iliac vein stenosis lesions. These are very common in patients with advanced chronic venous disease. It also presents with patients with pelvic pain for venous origin, venous claudication. Endovascular treatment is safe and good outcomes, but we need to learn that, we need to utilize our skills as to place a stent properly, and also use, in my opinion, intravascular ultrasound, which I think is becoming, for me at least, standard of care, and I think with many other of my colleagues. And I would only, in these situations, treat patients with more than at least 60% stenosis by IVAs. But the technique is key in for sustaining better patient outcomes. And with that, I would end by saying that we're, a specialty that is always learning. All of us here, we seem to be the experts, and we are the experts, but we are the experts in relearning and understanding where our patients' needs are and understanding with our own techniques. So thank you very much for today's, showing me in this important forum. I am happy to be here, and thank you, and good luck to all of you guys.
Thank you, Dr. Salazar, so much. I feel like we could truly tell how passionate you are about venous disease. Thank you for taking the time to school all of us. And also thank you to Dr. Chick for helping answer all the questions in the Q&A. I'd like to introduce Dr. Henry Seto, a PGY3 at Christiana Care in Delaware, who's going to be moderating the next talk.
Thanks, Nihar. It's my great pleasure to welcome Dr. Maxim Itkin. He's the Director of Lymphatic Professor at University of Pennsylvania. Speaking about lymphatics, which you've heard so much about arterial and venous diseases, but lymphatics is lesser known. So Dr. Itkin, if you
Sorry, I, of course, didn't push there. Just 1 second. Thank you very much, guys. I have only 10 minutes, so I will try to squeeze in 10 minutes, 20 years, what I'm doing in my life. The most important part of the lymphatic system, pretty much the only one we care at this moment, is collecting the fluid from the tissues and delivering back into the venous circulation. Everything starts in capillaries, where the fluid migrates from capillaries into the interstitial tissue. It's governed by the Starling law, balance of hydrostatic and oncotic pressure in tissue and capillaries. And what's very, very, very important to understand for all lymphatic intervention, for all lymphatic-related diseases, is that there's absolutely no venous fluid reabsorption. Originally, and still in some books, the people thought, and writing right now in very, very respectful books, that there is a venous reabsorption. This absolutely doesn't exist. It's been proven approximately 50 years ago by basic science physiologists. So what are the lymphatic flow disorders? They primarily leakage or obstruction of the lymphatic fluid, right? So in the different lymphatic fluids in the body, chyle is intestinal lymph. If it leaks in the pleural cavity, it can cause chylothorax. If it leaks in bronchial tree, it can cause plastic bronchitis, chyloptysis. Abdomen will be chylosositis, chyluria. And then soft tissue lymph, when it leaks, it can leak in the abdomen or in the groin, so it's a lymphocell, or it will be in the scrotum. I'll show a few pictures. And recently we started to do more and more liver lymphangiography and liver lymphatic interventions because liver lymph can leak and it can cause liver lymphorrhea post-surgery or condition important losing enteropathy and other conditions as well. So all these different types of lymph are actually completely different. The chyle, of course, contains a lot of fat and albumin, soft tissue, minimal amount of albumin, and minimal amount of, and of course, no fat, and liver, high amount of albumin and no fat as well. So sorry, just 1 second. So until recently, we talked about non-lymphatic lymphatic disorders. But actually, because of lymph is everywhere in the body, it's responsible for also for non-lymphatic disorders. So everywhere the fluid accumulates in cavities, liver cirrhosis ascites, CHF, or edema, either heart failure or nasarca, the lymphatic system will be part of that. And of course, this is a future because this is a common disease. Lymphatic disease is relatively rare, but this is a much more common disease. So why we completely forgot lymphatic system? Because it's hard to image, it's difficult to introduce the contrast, anatomy is extraordinarily complex, the lymphatic vessels are very small, and there are multiple lymphatic systems. So the reason why things started to get heated during the last 10, 15 years because of developing of new intranodal of new lymphatic imaging techniques, basic intranodal lymphangiography, MRI lymphangiography, liver, CT, mesenteric lymphangiography. So this is a basic concept. You put a needle into lymph node, inject dye, and you can actually see dye going all the way up in the chest. This is how it looks on the patient. On the right is, of course, picture of the us injecting a dye. On the left, that's how it looks on the patient. We use this interstitial lymphangiography technique in different places. If we inject groins, it will be intranodal lymphangiography. It will, if we inject in liver, will be liver lymphangiography, mesenteric, and so on and so on. So this is just an example of the interstitial lymphangiography, where we put a needle inside the lymph node and inject dye, or we can inject glue. I'll talk about that later. Or we can do MR lymphangiography by injecting gadolinium inside the gadolinium inside the lymph nodes and get beautiful picture. On the right, by the way, you can see us injecting ultrasound contrast in the lymph nodes. So we know that when we position our needle in lymph nodes, we are in the lymph nodes. So this is how MR lymphangiography look like. It's actually a dynamic study. You can see it over 10 minutes. We actually can calculate the flow. We published some papers about that. And this is a newcomer. This is intranodal CT lymphangiography. Obviously, gives you beautiful, beautiful images. But more importantly, this CT lymphangiography is much easier to implement anywhere in the world, because MR lymphangiography, it's a complex technique. You have to logistically complex setup. CT lymphangiography, from the other hand, is very, very easy. A liver lymphangiography, we put our needle very close to the portal vein. That's where liver lymphatics live. And by the way, when a radiologist is talking about periportal thickening, edema, that's into congestion of the lymphatics. And on the right, we do liver lymphangiography, and you can see the liver leaks inside the duodenum in this patient with protein-losing enteropathy. And if we'll do CT, we actually can do nice CT liver lymphangiography. What are the therapeutic approaches? We started with basic. 20 years ago, 25 years ago, Dr. Kopp developed this thoracic duct catheterization embolization. We use it primarily for calothorax plastic bronchitis. Recently, over the last 5-6 years, the interstitial lymphatic embolization that's performed the same way as an interstitial contrast injection, but instead of contrast, we inject glue, picked up and opened a whole new territory for us to deal with. And more importantly, lymphovenous anastomosis, thoracic duct venous junction plasty and surgery came recently, and this will be a huge future for us. So what a fundamental problem in the lymphatic system? Two, there are anatomical variants or an increased lymphatic production. Because lymphatic system is so complicated, the anatomical variants are everywhere, and I will show you a few in a second. And because of these variants, the disease happens. An increased lymphatic production, of course, when you increase flow in lymphatic system, it can try to find the places, leakages, refluxes, and so on. And also we're talking about upstream anatomical obstruction. So that this is the three components of pretty much every pathological situation or pathophysiological mechanism of all lymphatic diseases. We start with the first variant, pulmonary lymphatic perfusion. That's a condition where lymph leaking from the thoracic duct into the lung parenchyma can cause all these different diseases listed on the left. So if this pulmonary lymphatic perfusion goes toward bronchial tree, it will be plastic bronchitis caloptysis, interstitial lung disease, and calothorax into pleura. This is one of these conditions, plastic bronchitis, leakage into lymph. And on the left, this is MRI normal patient, and on the right, clearly abnormal. And you can see that there's enormous flow goes inside the lung parenchyma. And this is schematic representation of the same idea. If we inject blue dye, you can actually see the lymphatic leakage into or seeping lymphatic fluid into the bronchial tree. And what's important to understand is that this abnormal pulmonary lymphatic perfusion is a pathophysiological mechanism for a variety of conditions. So the plastic bronchitis and calothorax, non-thrombotic calothorax looks exactly the same. This abnormal pulmonary lymphatic flow, and this is just again schematic representation of the same idea. What do? We can do intranodal lymphangiography, thoracic duct access, thoracic duct embolization. This is intranodal lymphangiography for us to see the lymphatic system. Then we access the lymphatic system with a needle and wire, put the cut wire inside. You can go for all organs. It's relatively safe or very safe. This is how it looks on the patient. And then we can close thoracic duct. We can use glue and coils. Most of the time we use combination of glue and coils. This glue comes, coil comes out. And this is, you can see, injection of the glue. In a second, here it comes. This is glue. Glue is radiopack. So move to the different scenario. Genital lymphoria edema. We found this patient has abnormal flow from the groins into scrotum. This is schematic representation, how we image that and pathophysiological mechanism. And here you can see how we treat it. On the left, of course, MRI. You can see this reflux in the scrotum. And on the right, there's a injection of the glue and the blockage of this vessel. So let's talk about liver lymph. Liver lymph is high in albumin. Why? Because this hole in sinusoids are very, very large. So albumin freely goes there. This is approximately a schematic representation of anatomy. It's very, very complex. But generally, the lymphatic ducts go in liver through the portal vein or through the ligament of triads. And this is how it looks like, a connection to the thoracic duct. So theoretically, liver lymph is supposed to go in the thoracic duct. But there are some conditions: liver lymphuria, protein losing enteropathy, callus ascites, plastic bronchitis, CHF ascites, and we'll talk only about a few of those. We started to see that actually they're leaking into different places, liver lymph. So here we do a liver lymphangiography, and this is an example of a child post Kasai procedure, leaking 1.5 liters a day, and you can see we do a liver lymphangiography and a huge leak, gluing of this close, resolve the problem. Protein losing enteropathy, it's another very significant disease, especially in kids with congenital heart disease, losing of the proteins into the gut, primarily albumin. And what we found out that these liver lymphatics actually leaking inside the duodenum. And you can see we're doing the same trick with blue dye, injecting and coloring duodenum. And this is how it looks after we inject glue. This is a schematic representation of the same idea. So it's always in duodenum for complicated reasons. I don't have time to talk about that, but we never found anywhere else but duodenum. This is CT lymphangiography showing the leak. Oh, this is actually a slide. I forgot about this. The reason why it's in duodenum because the anatomical lymphatic communication are so complex. So recently we started to glue those. We glue it from the liver side. I skipped the slides, but this is what we're doing right now. We actually inject blue dye, see where it's leaking, and then we, this is how it's blue dye leaking, right? You can see it's sometimes just one beautiful hole. And the next thing you can do, you can actually inject through endoscope directly into the leak, the glue, and it works amazingly, amazingly well. And most importantly, this is very safe and well-tolerated procedure by the patient. So I don't have time. This is just another new topic I probably skip because I wouldn't have time, but we started to do angioplasty of the thoracic duct junction. It's a big future for that. And pretty much, guys, I think we will, every department within 2, 3, 4 years from now will have to do at least 1 or 2 lymphatic procedures a week. Right now, we do 3, 4 a week. Other places, maybe 1, 2 a month. But with new development, with new diseases we discover, I am absolutely convinced that everybody will start doing these procedures much more often. And of course, we continue to develop different techniques, approaches, imaging, and so on. And thank you very much.
Thanks, Dr. Aitken. As you can see, we've only just scratched the surface of lymphatics. For our next topic, I'd like to introduce Eric Nelson. He's a third-year medical student at Western University of Health Sciences. Thanks for your time, Dr. Aitken.
Good morning, everybody. It's my absolute pleasure to introduce our next speaker who's going to touch on the topic of Y90 radioembolization and its role in interventional oncology. We have Dr. Meekan Patel. He is a VIR from the University of Chicago. He completed his radiology training at the University of Chicago with subsequent VIR fellowship at Northwestern. He has extensive experience and interest in transarterial radioembolization, venous thromboembolisms, and uterine fibroid embolization. During the lecture, moderating the chat and the Q&A is going to be Dr. Gregory Woodhead. He is a VIR and the program director for the Integrated Interventional Radiology Residency Program at the University of Arizona. And then again, as a reminder for the audience, please feel free to use the chat for any questions, comments you may have during this lecture and anything subsequent. So Dr. Patel, I'll go ahead and turn the time over to you.
All righty, Eric, thank you very much for the introduction. Just can you confirm for me, you can see my screen? Got it? Okay, wonderful. So yeah, like Eric said, I'm at the University of Chicago, interventional radiologist. Was previously at the University of Arizona with Dr. Woodhead, who's joining us as well. We'll just get straight to it, try to make up some time. I mean, I don't need to tell you guys IR is great, otherwise you wouldn't be here. I also don't need to tell you guys that interventional oncology is a huge part of IR. It makes up, we are just looking at some data, and it makes up about 1/4 of the publications in JVIR over the last 10 years. So with that said, let's move forward. I do some work for Boston, but this is kind of the world of interventional oncology, right? These are the kind of patients that come to you. 68-year-old woman, she has NASH cirrhosis, T-Billy's not bad, her liver function's pretty good. She has this MRI, which shows these lesions, red arrows there, enhances, washes out. Cirrhotic patient, HCC, what do you do about it, right? So real high level, what is HCC about? It's the 6th leading cancer worldwide, but it disproportionately causes a lot of mortality. It's 3rd leading cause of cancer deaths, and mostly in cirrhotics, but also this growing population of kind of NASH steatohepatitis. When we think about HCC treatment, we think curative or palliative. Most patients unfortunately end up being more in the palliative sort of stage by the time we catch them. The liver's a robust organ. It can handle having a lot of tumor in it without presenting symptomatically. And so when you're talking about palliative, again, traditionally, you're talking, TACE, Y90, SBRT, various chemo, immunologics, that sort of thing. Curative therapies traditionally have been transplant, resection, and ablation, right? Again, traditionally, we think about HCC in terms of the BCLC criteria. There's a lot on this. That said, there's actually even an update which adds even more to this. What do you got to take away from this? Basically, and this is a whole separate talk I give to my fellows, IR is involved in every single stage of HCC. Even though the algorithm says, for intermediate you TACE and for advanced you sorafenib, that's old, that's 2011. Nowadays, IR is involved in every single stage. You're downstaging people to transplant, you're shrinking tumor and getting liver hypertrophy on the other side to make resections better. You have to be involved in every single HCC patient. I really believe in that, and that's what I teach my fellows. Outside of HCC, though, we can do more than that, right? And this is, again, the talk is a little bit geared towards radioembolization. We're ignoring microwave and TACE and all that stuff. And honestly, that's, you could spend days talking about all that stuff. And there's, like I said, a huge body of literature. So outside of HCC, there's colorectal metastases, and there's kind of 2 big Y90 products out there, 2 big Y90 devices. They're on label for HCC and colorectal, one each. But let's face it, a lot of us use radioembolization for cholangio, neuroendocrine, GIST, and then more rarely ocular melanoma and breast cancer in the liver. There's also some interest in looking at other end organ sort of applications, right? Glioblastoma, prostate cancer, that sort of thing. So a lot more to come in the world of interventional oncology. It can be, we'll start expanding outside of the liver and, kind of the renal and lung ablations. You'll see a lot of applications. What is radioembolization, though? Just to, again, high level, like I said, there's kind of 2 big devices on market made by 2 different companies. They have their pluses and minuses. People argue about it all the time. At the end of the day, what are they? They're beta emitting, they're microspheres that you inject into the arteries that are loaded with yttrium-90, right? And that decays and it emits beta radiation. And what it does is it gives you a very local sort of radiotherapy. It's almost like a brachytherapy sort of thing. The spheres themselves are much smaller than the spheres that we use for other embolizations. They're on the order of 20 to 60 microns, and typically with a TACE or bland embolization, you're using somewhere in like 1 to 3 or larger. And so they're not necessarily as embolic. You still have the blood flow going to these tumors. And honestly, that probably has to do with the efficacy, right? Getting oxygen in there, so it makes some free radicals. The goals of therapy are this is, again, more than the nitty gritty. You're trying to get a large gray dose into the tumor. And you can do that because, and we'll talk about this later, the hepatic artery is an end vessel, right? The capillaries go in, they allow you to put the embolic into the tumor, and they just sit there. Now, there are situations where that isn't the case, right? You have situations where tumors create a lot of vascularity, and all of a sudden the particles don't just go in and sit there, they're flying through the tumor into the lung. And so there are some limitations, right? You don't want to just blast the lung with radiation, and so that's one of the exclusions for radioembolization. The other thing is, if you can't find a nice arterial territory, you're going to end up also spraying some radioembolic into the small bowel or something. that's not something you want to do. And in those cases, you got to start getting a little bit more creative or start thinking of other options, right? So what makes radioembolization work in theory? Again, we talked about this, is, you know, the liver has a dual blood supply, portal vein, hepatic artery. You can embolize into the hepatic artery and the liver will, for the most part, be okay. The other thing is the hepatic arteries are nice end vessels. So it's a nice territory to sort of work in and inject whatever you want, whether it's TACE or Y90 or whatever. When we're doing the radioembolization, we always do what's called a mapping procedure. So these procedures are kind of 2 steps. You come in, the patient comes in, they go through a full angiography mapping procedure. In my practice, this is kind of where the bulk of the time is spent. This is where all the kind of brain cells are firing. You're sort of mapping out their liver. You're figuring out how much of whatever you're going to inject is going to go to the lungs, how much of it's going to go to the tumor. And based on that, you measure lung shunt and you do your dosimetry, right? So this is kind of what that lung shunt looks like. So, you know, we've gotten in, and then just, I'm going to back up for 1 second. Here I have an embedded video. In the interest of time, we're going to skip it. You can look it up yourselves. Honestly, you can just YouTube it. It's Surtech's mode of action. It's a nice little kind of cartoony video for radioembolization. It does a great job of describing at a very basic level. I actually show it to my patients in clinic. So take a look when you have a chance. Like I said, YouTube, Surtech's mode of action. So you've gone in, you're doing your mapping procedure. What you do is you actually, on this mapping procedure, you inject MAA, right? It's a macro aggregated albumin loaded with tech. You put the patient in the SPECT scanner and you can kind of get a practice swing. You basically see where is whatever you inject, where is it going to go? And you know, in panel A here, you can see the blue outline up top. It looks like it's lung, right? And so here we've injected the MAA and a lot of the activity goes to the lung. Well, what does that tell you? A lot of whatever you're going to inject subsequently is going to go to the lung. And based on that, you can figure out how much dose you're going to get in the lung versus how much you're going to get in the tumor. And then you can kind of sort out how much activity you're going to give. Then, like I said, it's not only about how much goes to the lung, you can figure out how much is going to go to the tumor, how much is going to go to the liver surrounding the tumor. And you can do all sorts of complex dosimetry. This is kind of where I geek out. This is where I'm really interested. Dosimetry is complex. You know, we kind of started this whole thing and we were doing very nuts and bolts, like patient is, you know, this many kilograms and their liver is roughly this big, just give them that much. Now we're getting more and more precise, doing more personalized dosimetry where we can actually measure what compartments of the liver and what compartments of the tumor are getting how much particle. And based on that, we can calculate how much gray dosing they're going to get when we inject either, you know, the glass or resin microspheres. And, you know, we have nice software to help us sort of plan that out. The other thing about more personalized and complex dosimetry is it makes us look like we know what we're doing. I mean, yes, we all knew what we were doing. And I think everyone, you know, got good results with the old school kind of BSA or MERD dosimetry. But now it's important that we show up to tumor board and we can, you know, speak the language of medical oncologists and radiation oncologists. They want to see dose maps. They want to see heat maps like this. And it gives us credibility, right? Before there was a sort of feeling that IRs were just going in and spraying and praying. And there may have been some truth to that. Now there's actually some thought put into all these dosings. So at the end of the day, what does radioembolization give you? From the patient experience perspective, it's great. It's an outpatient procedure versus, you know, a potentially big surgery or coming in for multiple rounds of external beam. It is an angiography, right? So it's a little bit more invasive than just taking a pill or getting beam radiation. But as far as radioembolization goes, the side effects are pretty good. And there's, you know, kind of a good study comparing to TACE back in the day. Patients kind of don't have that bad of side effects. It doesn't hurt too much. You know, they get fatigue and kind of radiation side effects, but overall, people generally tolerate radioembolization pretty well. You know, typically patients after they get these procedures, they will be followed up with imaging and serology. And basically what you're looking for is HCC is, you know, HCC is a tough disease. Basically, it will recur and these patients have an underlying bad liver, right? And so they will get new HCCs. And so these patients do need to be monitored. And the point is, you will develop a relationship with your patients. You're going to be one of their cancer care providers, and you're going to have a longitudinal relationship. You're going to follow them up, and you may have to provide them additional treatments down the line. As far as does radioembolization even work, I mean, there's a whole litany of data. Depending on what circumstance you're talking about, there's a concept of radiation segmentectomy or segmental radiation treatment. You can really get an ablative dose for like a target lesion, and then even kind of bigger tumors and more, multinodular tumors. There's good data from some of these studies that you can look up on your own. So going back to our case, 68-year-old woman has a solitary HCC. What do you do? It's, it's a little bit bigger than 3. It's in a tough spot to ablate. So the question is, why not Y90? And so what does it look like when we go to do this? Well, this is, here's a nice celiac run. You can see the vessels kind of going to the screen left towards the liver there, right around where the clips are. As we kind of get in closer there. And here's an early injection through a microcatheter, and then kind of a little bit hard to see, but you can kind of see some tumor blebs developing here just to the screen right of the clips here. And so what do? Well, we get very selective, and we just basically spray a bunch of glass-loaded Y90 right at the tumor. And you can get, I think in this case, we got a dose of about 700 gray just to that area. And that's more than ablative. Here's on the left is her pre-treatment imaging. In the middle is 1 month post-treatment. You can see it's kind of dark. There's some kind of enhancing stuff just anterior to that, but that's kind of the radiation effect. And that's some of the collateral damage we did. But overall, you see it's a very small portion of her liver, and we can get very selective. And then a year later, that tumor is still just scarring down and dead, and there's not much going on outside of that. And that's how she felt. She was happy. So radioembolization is good. IR is good. Good choices, guys. IO is definitely a huge part of it, and there's absolutely zero chance I can cover it in 10 minutes, but that's just a tip of the iceberg there. Thanks.
Awesome. Thank you very much, Dr. Patel. That was a very fascinating lecture, and just thank you very much for the work you do in helping your patients. It's always amazing to see what we as VIRs are capable of doing in the oncology space. And then also another thank you to Dr. Woodhead for monitoring the chat. So just to help keep things moving along, I'll go ahead and introduce our next moderator. It is Dr. Juliet Alla. She is a second-year resident in the Integrated VIR residency at UC San Diego. Dr. Alla, take it away.
Hello. So it is my good fortune to be introducing our next speaker, Dr. Christopher Friend, who is an interventional radiologist and associate professor of radiology at University of California, San Diego. Dr. Friend is fellowship trained in both musculoskeletal radiology and interventional radiology, having completed fellowship at University of Arizona and Emory University, respectively. He's going to be discussing vertebral augmentation today at the intersection of musculoskeletal radiology and interventional procedures as well. We'll also have Dr. Brandon Key of MCW helping to moderate questions in the chat as well. So without further ado, Dr. Friend.
Thank you for the introduction. Thank you for having me speak at this event. It's nice to see so many people interested in interventional radiology. My email is cfriend@health.ucsd.edu if you have any questions. Today, I'm going to be talking about musculoskeletal interventions, and I'm going to try to give a brief overview of what can be done. So I have no conflicts, no disclosures. So this is a list of some of the procedures that can be done in the musculoskeletal system. You can see there's a wide variety, from the basics of soft tissue and bone biopsy to tumor embolization, genicular artery embolization, which is embolizing the arteries around the knee, vertebral augmentation, which we're going to talk about, it's relative sacroplasty. There's just a lot of interesting things that are changing and frequently advancing. And then, of course, CT guided pelvic screw fixation, some interventionalists are doing. There are more. So why do MSK interventions? You can choose your career path. You can develop a practice that suits your interest. You want to develop more of a pain management, that's possible. There are many pain interventions. Oncology is a another topic, treating musculoskeletal tumors or general orthopedics, such as you can also get into general orthopedics, treating artery embolization, joint injections. People are injecting the shoulder to treat adhesive capsulitis. And many of these procedures can be done by IR or MSK radiologists. So we use different techniques. We use ablation, embolization, injection. But probably the most important reason for doing this is it's very rewarding and really improves the patient's quality of life. So if you're interested in building an MSK practice, you have to know the anatomy and disease process. That's important for any field you go into in medicine. Know your referring doctors. In this case, they're often pain management, orthopedics, neurosurgery, and primary care. And also know your diagnostic colleagues, as they're going to be a great source of referrals. Diagnostic radiologists see the images and diagnostic colleagues will see the images first, and they can refer them to you. When you approach these procedures, as well as many of the other procedures in IR, there's many procedures that are shared by different specialties. I think it's important to approach everything with a spirit of collaboration and not competition. In that light, you want to attend multidisciplinary tumor boards and conferences, and be willing to try new procedures. The great thing about the musculoskeletal procedures is they're constantly evolving. There are many procedures that we now do that were not around when I was a fellow. So what I'd like to do now is I'm just going to show some cases of different musculoskeletal procedures just to give you an overview of some of the things we can do. Certainly not exhaustive in the 10 to 15 minutes I have. The first one is going to be vertebral augmentation, which is one of my favorites. So vertebral augmentation treats vertebral compression fractures. And this is a chart of the various types of compression fractures, which we won't go into, but what we're going to treat are the compression fractures. You can see a superior end plate or inferior end plate compression. And the great thing about treating these are patients tend to get pretty rapid pain relief. These are very common fractures, often seen in the elderly with osteoporosis. Osteoporosis is very prevalent, and spine fractures increase in prevalence with age. And these can be debilitating. They can cause pain, they can cause loss of function, loss of activity, deconditioning. You just start down a downward spiral. And with vertebral augmentation, we can get the patient healed, feeling better, and getting back to their daily activities. So the other thing is these fractures, once you have one, you're at increased risk of having another. So these can become your patients for life. There are several patients I have that I've been treating for several years that just when they have a fracture, they know it, they've had it before, they call me and I treat them. So you end up treating 3, 4, 5 levels over the lifetime of a patient. So let's just look at a case. So these are frontal and lateral radiographs of the spine. And if we look, we can see this is a normal vertebral body. See how square that is. Here, you can see a more of an angulated vertebral body. So this is a compression fracture of the superior end plate. What we don't know is whether it's acute or chronic. For vertebroplasty or vertebral augmentation, you only want to treat acute or subacute fractures. Chronic or healed fractures do not respond. So in this case, we had the benefit of having a CT scan 3 months ago where this vertebral body was normal. I often get an MRI on these patients just to see if there's a fracture at the level above or below that we were not able to pick up on CT or radiographs. So this is an MRI, again, looking at it. This is a sagittal looking from the side. And here on this sequence, you can see the increased signal. meaning bright in the vertebral body, and that signifies edema. So compare that to these other vertebral bodies. This is abnormal. Here, you can also see that now it's darker on this sequence in these vertebral bodies. So you have an abnormal vertebral body with edema. You can see a fracture line here. So this is an acute or subacute vertebral fracture. This is an axial image. And we use this to make sure that there's no compromise of the spinal canal. So for the med students out there, the bright stuff is cerebrospinal fluid, and this is the spinal cord. So there's a lot of room here. So the way vertebroplasty, vertebral augmentation, and kyphoplasty work is we access the vertebral body, often through the pedicle. So advance the trocar straight into the vertebral body. Sometimes we'll go outside the pedicle. That's called an extrapedicular approach. Once we get into the pedicle, for a kyphoplasty, we inflate balloon tamp. This creates potential space, and we'll often lift the end plate to restore some height. And then we inject the bone cement to solidify the fracture and stop the fracture from having micro movements. Postoperative radiographs, again, the lateral view, frontal view showing the bone cement in good place. There's no bone cement back here. You do this procedure, you want to watch very carefully so that cement does not get to the spinal canal. And this patient had her procedure done Friday, and Monday her pain was down to a scale, 1 out of 10, so very pleased. So in a similar sense of vertebral augmentation, we can also do vertebral ablation. So ablation means using heat or cold therapy to treat tumors or soft, be them benign or malignant tumors. So this is a 78-year-old man with a history of prostate cancer who also developed a lung nodule. There's a lung nodule right here. Went on to have a PET scan, showed FDG avidity, and it had a squamous cell lung cancer. So he presented with lower extremity weakness and pain. And again, these are 3 sagittal MRIs. Much like the case I showed before, we look for abnormal signal in the MRI. And on this T1 weighted image, you can see the low signal, and then post contrast, see this bright enhancement, which is much different compared to the other vertebral levels. This patient also had a CT scan. So here we see normal bone, and here is the metastatic lesion. Again, looking at it from the sagittal plane, you can see the defect in the vertebral body. So this patient had a lot of back pain. If I recall, it was 8 or 9 on a scale, 1 to 10. This is just a CT MRI correlate, seeing how nicely they correlate. Here's your tumor, here's some reactive edema, again, the tumor. So much like vertebral augmentation, we access the vertebral body. I like to use radiofrequency ablation for these for vertebral tumors. So we use RF ablation to ablate the tumor. Then some balloons in to create some space, and then injected some cement. And you can see there's a little bit of leakage here. But the important thing is this patient had a fair amount of pain relief. We look at the follow-up PET scan. There's a void here and probably just some reactive activity here. It was a very good result. He came back post-op. His back pain was improved, but he did develop shingles. So this is the follow-up MRI. You can see the demarcation where we ablated, and then what is likely probably a reactive marrow edema here. And for those interested, here's enhancement of the nerve root, which goes along with the shingles. So continuing on the spine theme, sacroplasty is probably the most rewarding thing I do. Vertebral augmentation, I quote patients 85 or 90% success rate. Sacroplasty is probably even higher. They really do well. I've had several people come in with in a wheelchair and leave standing. So it's a really impressive procedure. So let's just look at that. Again, for the med students out there, recurring theme. This is a fluid sensitive sequence. We look for the edema in the sacrum. And then on the T1 weight images, look for low signal intensity. So this is a sacral insufficiency fracture. So insufficiency fracture versus stress fracture, you'll hear these terms. Insufficiency fracture is normal stress, abnormal bone. So usually osteoporosis or tumor. Stress fracture, abnormal stress. You run a marathon, you get stress fracture in your tibia in normal bone. So sacral insufficiency fracture is a very common cause of pain in the tailbone pain in the elderly. Conservative therapy often does not work, and sacroplasty is safe, quick, and very effective. So here are just some images. Again, we access the sacrum using similar tools and techniques as vertebral augmentation, and then inject the cement. And as you can see, I've treated this patient several times. So this is the cement in the sacrum, and the patient did very well post-op. Embolization. We've had several talks on embolization. Basically means blocking a blood vessel with particles or coils. So embolization in the musculoskeletal system. One of the first things described was treating recurrent hemarthrosis and knee arthroplasty. So this patient had a knee arthroplasty. There's an effusion. It required several taps to drain hemarthrosis. What happens is a lot of times with synovium will hypertrophy and bleed, and we can go and embolize it. So this is a case I did a few days ago. This is just the arteriogram. So again, in addition to ablations, musculoskeletal interventions can also involve arteriograms and embolization. So there's a lot of variety. If you look closely, you can see some hyperemia along the joint line here. This is just a still image before embolization, again, the hyperemia, and this is post. So you can see we've devascularized that area and try to reduce the risk of recurrent hemarthrosis. And this is just a post-op image. So this is now, a lot of people are starting to do this for osteoarthrosis, which is very exciting because osteoarthrosis, as you know, is very common. And this has been shown to treat pain in folks who are not yet ready for knee arthroplasty. So this is just an example of the embolic. In this case, you can see small particles here to block off the smaller blood vessels. And just to show you how what we're doing, these were the journal articles for the UCSDIR Journal Club this past week. So genicular artery embolization to treat knee osteoarthritis, and then embolization to treat adhesive capsulitis of the shoulder. So there's a lot of exciting work being done using embolization to treat musculoskeletal disorders, and a lot of promising work. So I think in the essence of time, I'm going to try to run through this case quickly to sum things up. This is a 37-year-old male that's had chronic right calf pain. It was found to have this lesion here. This is an ultrasound. So mildly hypervascular. See, this is fluid sensitive sequence, abnormal. A little harder to see here on the T1 weighted sequence. Just kind of showed it nicely. Anyway, this was a vascular malformation that was symptomatic. I'll skip this in the essence of time. So we did an angiogram to further characterize it. You can see some early draining veins here. And we decided to use cryoablation. So the spine we treated, we used radiofrequency ablation with heat. This is cold. So here's the lesion. Here's a needle going through. And then you can see the ice ball. This is what it looks like. Here are the cryoablation probes as we actively ablate the lesion. This is the post-op showing the ice ball, and here's normal muscle. So this is an exciting way that's being used to treat more. This is an exciting technique being used to treat more and more vascular malformations percutaneously without surgery. So this veteran had just 2 small excisions. So to conclude, MSK, there's so many procedures that can be done and are being done. We can only cover just the tip of the iceberg in 15 minutes. But the nice thing about MSK is we get to combine many different IR techniques, ablation, embolization, injections, and try to really do them to help the patients and improve their quality of life and treat their symptoms. And for me, it's been a very rewarding and dynamic field that the innovation is just continuous, and it's very exciting to be in. So with that, I'll stop. Sorry I went over time, and thank you very much.
Dr. Friend, thank you so much for that talk. I know that I have a list of articles and topics to follow up on after that. Absolutely beautiful, incredible cases. And thank you, Dr. Key, as well, for helping to moderate the questions in the chat as well. In the interest of time, I want to turn it over to the next moderator. This will be Pierce Hedelman. He's a second-year medical student at University of California, San Diego.
Thank you. And I should say that I also have the pleasure of introducing our next speaker. It's going to be Dr. Anthony Tadros. He is a vascular and interventional radiologist and assistant clinical professor of radiology here at the University of California, San Diego, which is my institution where I'm a medical student here. Dr. Tadros received his bachelor's degree in biology at Cornell University. He then traveled all the way across the United States here to UC San Diego to complete his medical education. He did his medical internship at the University of Colorado Anschutz campus, then returned to UCSD for his radiology residency. He's dual fellowship trained in musculoskeletal imaging at UCSD and vascular and interventional radiology at the Medical College of Wisconsin. He has a special interest in musculoskeletal interventions, pain interventions, and palliative care, for which he'll be talking about right now.
Okay, great. Well, thanks so much for that generous introduction. I'll jump right in. So palliative interventions is a big topic, and there's a lot that can be included in the field of IR, but I'm going to focus in on cancer pain. No disclosures. Okay, so we'll talk about the pathophys of cancer pain, and then we'll talk about some of the interventions that we can do for cancer pain. Chris talked about musculoskeletal interventions, so I'm going to focus in mainly on nerve blocks. But what about cancer pain? Is it a big deal? And it is. I mean, if you look at just from like a hospital burden perspective, it's the most common reason for ED visits by cancer patients. And then probably the most important is actually in 2021, there was a study that came out that said patients who present with severe pain at ED presentation actually have increased 30-day mortality. So that's a game changer. There was some attenuation when you consider some of the other clinical factors, but that means that it's more than just even quality of life. We're talking about survival. And so treating cancer pain is important. And how does everybody else feel about it? Well, the NCCN adult cancer pain guidelines do include interventional strategies, and they list in detail what are some of the reasons to have referral to interventional practices for treatment. So we are in the NCCN guidelines as far as offering adjunctive therapies for cancer pain. So we'll kind of talk a little bit about the pathophysiology, and this really is how I approach my patients. And if you know where the pain is coming from and you can correlate that with the imaging, then you're going to be able to decide on what's the most appropriate intervention. So I think everybody's familiar. So somatic, that's going to be pain that's coming through your somatosensory system. So that's like this picture here on the left. And that's like classic as bone, right? So it's going to be some type of, say, for example, a bone lesion, you're going to have well-localized sharp pain. Whereas if you have visceral pain, you're looking at a more dull, poorly localized, and that's coming through your autonomic plexus. So that's these guys that live here on the right, and these are in the paravertebral space, and we'll run through some of these various nerve blocks. But you're just marching down here, you have, basically different ganglions that we target. And then neuropathic. So those are nerves that are damaged, and that's typically burning, throbbing pain. So what are the interventions? So you can group them by the different types of pain. So if you're talking about somatic pain, you're usually talking about bone metastases. And if you're talking about bone metastases, then you're usually talking about two different types of pain. there's the tumor that is destroying the bone, that causes pain. And then when the bone gets weakened, therefore you have abnormal motion at the bone, that causes mechanical pain. So it makes sense, right? So ablation, you're going to kill tumor. And then, so that treats the tumor-related pain. And then cementoplasty, you're treating the fracture. And then there's a combination of various things that you can do. You know, when it comes to visceral pain, we're often doing nerve blocks. And similarly, when it comes to neuropathic pain, we're doing nerve blocks. You have to select your patients appropriately. You know, you need to know what nerves have motor and what don't, and then you can counsel your patients appropriately. So we'll kind of run through some of these here. So Chris talked about some of the bone ablation and stabilization techniques, so I won't talk about those, but there's obviously a lot of different interventions that we can do there. I'm going to focus in on the nerve block side, and we'll run through some of these case examples. So stellate ganglion lives up here, basically mediating pain from the upper extremity. Intercostal, that's a somatic nerve, classically chest wall disease. Celiac plexus, the most classic nerve block, upper abdominal cancer-related pain, that lives right by the celiac artery. Different ways to approach that. Lumbar plexus can be used for PAD or CLI. Superior hypogastric plexus, right below the aortic bifurcation, that's for pelvic pain. And then we're marching down, so pudendal, so that's a somatic nerve. And then ganglion of Impar, the lowest sympathetic plexus. Okay, so we'll just run through some of these examples, just give you a little bit of a sampler. So celiac plexus, a lot of data. Look at this, data is old, 1995. And this is, 24 studies, good pain relief, 2001, 6 RCTs with, lower opioid usage. And there's so many different techniques, but this is the classic technique. This is a anticrural celiac plexus neurolysis here. This is a lady who had neuroendocrine cancer. Her pain was significantly improved. She was off opioids 4 months later. And then we do all kinds of different techniques. Had a patient who couldn't lie prone just 2 days ago. And so we did a transabdominal splanchnic neurolysis, and he had good benefit. And so a lot of different techniques here, but certainly something that is often asked, and for good reason, because we have a lot of data in common disease. Hypogastric plexus, so we have not as robust data, but we have good data to show that there is pain relief. And here you're talking about lower abdominal or pelvic malignancies, usually GYN or GU. In this case, it was a patient who had a large rectal mass. This is a transabdominal technique. This is using needle navigation software, although you could do it under fluoroscopic guidance if you wanted. But we're able to, this was coming in anteriorly, just at the bottom of the L5 vertebral body. This is how we map it out on the iGuide. And then we injected alcohol, about 10 cc's, along with bupivacaine, and she had significantly improved back pain. Intercostal is one of my favorites. I think some of the most impressive pain relief I've seen and dramatic benefit is with these blocks. And so this is obviously a somatic nerve, and the idea here is that you're shutting down dermatomes, and we have a couple of good studies showing good pain relief. And this particular one in 2020 showed cryoneurolysis for chest wall neuropathic pain. This is a case, actually, patient came in for a biopsy. He was in horrible pain, had a lot of PCA. We said, why don't we try to do something for your pain? Did a paravertebral block. This is what it looks like on a cone beam, 3D reconstruction. You could see diffusion underneath the ribs. And he had good response to that, so brought it back and did a cryoneurolysis. This is a technique in the Dobby study in 2020. So you're placing the cryoprobe right at the neuroforamen. We did a multi-level. Pain was completely gone. He was off the PCA. He's using occasional oxycodone 2 months later. It's just a complete game changer for this patient. Stellate ganglion is one that we don't see as often, but classically you'll treat patients who have brachial plexus involvement from, say, like metastatic breast cancer. This is a coronal MRI. You can see these are normal nerve roots here. These are all thickened and abnormal. This patient had horrible pain down her left arm. So we did a stellate nerve block, and here this is a needle. This is one approach. There are different approaches, but we're targeting basically the first rib head. We injected actually just bupivacaine and brought her back every couple months to do that. And she had improved hand function. She was able to cook with her daughter again. it was a big deal for her, and we did that for her until her cancer had progressed. Pudendal nerve, somatic nerve. This is a patient who had rectal cancer, severe perineal pain. This is a cryoneurolysis here. So here we're targeting Alcock's canal, and this is CT guided. You can see the ice ball forming right around here. When you're doing cryoneurolysis, you want to try to get as much of that probe along the length of the nerve, and this patient had improved scrotal pain. So to speak to some of the practice building, when I first came back to UCSD, we weren't doing really much at the university. Chris has been doing some amazing things at the VA, and we've been able to really grow our practice, and that's really through some of the things that Dr. Key has mentioned, and a lot from some of the mentorship that I got from Sean Tutton, who's now joined us at UCSD, which is a big win for us. And at the end of the day, it is multidisciplinary care. And so what we did is we started an inpatient palliative conference, and these are some of our palliative care doctors, and we have everybody there: anesthesia, pain, radiation, oncology, and it's tumor board style. And we're discussing probably the more difficult patients that are stuck in the hospital with cancer pain. But by starting this, we were able to develop referrals from our palliative care doctors. And basically over the first year, we were able to grow our palliative interventions by almost 600%. And the main reason is just people weren't aware, and we have a big cancer population and patients, so the need is there. And we are now bringing this out into the outpatient center by developing an outpatient multidisciplinary cancer pain clinic. And everybody's on board, because there are times where we're not effective, and anesthesia pain can offer something different. And even when we overlap, we work together to get patients in, whoever can get them in sooner. So collaboration is key in this world. And I think it's really exciting, and we can really change patients' lives. I put together this little palliative IR guide. There's so many other things that we do: malignant ascites, pleural fusions, you name it. But this is like a kind of pocket medicine sort of guide. If you're interested, you can email me, and I'll try to get us caught up here. Thanks.
Thank you, Dr. Tadros, for that. It's always exciting to learn about how IR is providing benefits in new areas of medicine. So I have the benefit of introducing our next moderator, who is Delaney Aguilar, a third-year medical student at Western University of Health Sciences, Oregon, who will take us to the next session.
Hi, I'm Delaney Aguilar. I've got the pleasure of introducing Dr. Alan Sogg. He's an assistant professor of radiology at Duke University School of Medicine and faculty interventional radiologist at Duke University Medical Center. In the chat, we will have Dr. Park. He is an interventional radiologist at the University of Texas Southwestern Medical Center. Go ahead and take it away.
That's perfect. Thank you so much, Delaney. I appreciate the opportunity to be speaking here today. And I also wanted to say thank you to all the organizers. There's a tremendous amount of work that goes into creating something of this scale. And I think everyone has done a tremendous amount of work, and I appreciate being invited to speak. Also, great to be on a panel with so many wonderful other panelists from the interventional radiology community, and especially Dr. V, who is one of my personal inspirations for going into IR. It's also great to have Dr. Park in the Q&A, who is an inspiration really for many of us in the domain that we're going to be talking about today, which is thyroid IR. And it's always a pleasure to be alongside Tim Huber, who is a total rock star as well in the thyroid RFA domain. Really exciting topic today, thyroid artery embolization, and let's get into it. So before I begin, please know that I have no financial conflict of interest. So you're rotating on Duke IR, and your first patient in the Dr. Sogg clinic is a patient who has trouble swallowing. And she's sent to us from the endocrine surgeon. Turns out that she has trouble swallowing solid foods. That's been going on for a while. She's tried to compensate for that by taking smaller bites, maybe moving to more liquids, more shakes. But ultimately, it's gotten to the point where at night when she lays down on her back to sleep, she's having trouble breathing. Also, she's noticed that her voice is kind of raspy, and she's noticed this cosmetically disfiguring goiter, and she would like help with this. Turns out the story started many years ago when she was diagnosed with a goiter, and that was treated surgically. And surgery has come a long way since then. Take a look at this nerve, vagus nerve, coming down. It's going to recur. You've got a recurrent laryngeal nerve right behind the thyroid. And unfortunately, this structure was injured during her surgery. So what happens there is she has one paralyzed vocal cord. You can fix that. Inject the vocal cord with some kind of synthetic substance, medialize it. Now she has her voice back, but she's dependent on one vocal cord. So the stakes are high. They left half of the thyroid in. She did well for about 10 years, but then progressively had this enlarging goiter. Biopsied, clean, not cancer. Her symptoms are getting worse and worse, and she's not a good surgical candidate, and we'll talk about why. But first, let's look at some imaging. CAT scan, looking from the side. Got the brain, oropharynx. When she's swallowing food, it's trying to squeeze between this, which is her goiter, and this, which is her spine. And that's why she's having trouble swallowing. Looking from the front, we got the brain, got the goiter, all on one side because she had the other side surgically removed. You can see, looks big. What are her options right now? So we have a multidisciplinary team. We have a team of surgeons, endocrinologists, ENTs, and I would say to all medical students who are going into IR, who are interested in IR, find your friends who are going into ENT, endocrinology, and endocrine surgery from now, because most likely they're going to need you in 6 years. All right. So surgery, good option. We're looking here at some video that one of my friends provided of a lymph node dissection during a thyroidectomy. And this is standard of care. This is ATA standard of care. Everything I'm going to talk to you about currently is not really reflected in the ATA guidelines yet. That's how new it is. You take out the thyroid, the bulk is gone. They have instant relief. But unfortunately, since she's had surgery on one side and it's unclear whether they tried the other side, we don't know the details of that surgery, we have to assume that she has scar. And scar makes all of these steps very difficult, because you can see when you're trying to cut through various layers of the neck to get down on structures like this, which is a vein, if those tissue planes are fused by scar, you could cut into much more than you bargained for. And unfortunately, if she loses her other recurrent laryngeal nerve, she's going to need a tracheostomy, she's going to lose her voice, and if they take out the whole remainder of the thyroid, she's going to have to take replacement therapy for the rest of her life. And also, don't forget about the parathyroid glands. She's currently euparathyroid. So another option is, if this takes up I-131, why not just spike some iodine? If this takes up iodine, why not just spike some iodine with some radioactivity and have her swallow that, and it'll all go to her thyroid and scorch it. And that's an option, but this one didn't have that uptake pattern. Thyroid RFA is great. You're going to hear about it from my colleague, Dr. Huber. Essentially, this is an option that at the time we saw this patient, this was a while ago. This was before we had our thyroid RFA machine, so device availability was a problem. And device availability may be a problem for others who are interested in getting into the thyroid domain. So what I'm going to talk about is something you can do tomorrow with stuff that's already on your shelf as an IR. And that's thyroid artery embolization. So this patient was discussed, and we decided to approach this with thyroid IR. Videos taken intra-op were showing access into the radial artery. So you can see we're actually accessing the snuff box radial artery. So when you learn that snuff box in anatomy, finally, very, very useful here. 2 millimeter artery. Anecdotally, I like to inject nitroglycerin directly onto this, and I wait about 5 minutes, and oftentimes I get a little bit of growth, but 2 millimeters is an acceptable amount for us. We can get into that artery. Contrast dye in, and you can see the arteries going down to the hand. The blood is flowing towards the hand, which means that we are in an artery, and we're going to drive up that artery. All right, let's go. We are headed up all the way, subclavian, selecting out inferior thyroid artery. And these were the images that we got. Take a look at how much blood flow is, take a look at how much blood flow is going to that thyroid, by the way. This is a tremendous amount of blood flow. This is so much blood flow that if you put your stethoscope on the goiter, you might even hear a bruit. And that was one of the diagnostic criteria that you'll read about in your textbooks. So tremendous amount of blood flow. This is all the tissue that we want to destroy. This is the goiter, but suspicious. Look at how there's a cutoff here. That's weird. Why is that? Turns out of this goiter, you've actually got two different vascular territories, and that's okay. We're not trying to destroy her whole thyroid. We want to leave her thyroid and some parathyroid too. Catheter in, we actually sent a microcatheter even further in. Particles in. What are particles? They're little pieces of medical plastic that clog up the arteries so that the tissue can't get oxygen. And then the mitochondria fail, and then the tissue dies. So the fact that all of this gray is no longer seen means that we had a successful treatment. How did she do? Well, we ended up having to treat her another 2 times, but these were all gentle outpatient treatments through a pinhole in her neck. And ultimately, we shrank down this goiter to her happiness. She was so happy that now she had a completely flat neck. She was previously coming to clinic with scarves and turtlenecks, and now she was very happy to not have this. Euthyroid at the end, euparathyroid at the end. Separate patient, just to demonstrate one of the things that I think Tim might also talk about in his section, and I'd be interested in Dr. Park's thoughts, is a retrosternal thyroid goiter. This is behind the sternum. This is a tough area to reach by ultrasound, and with RFA, it's a big volume. Look at this airway, pushed all the way to the side. All right, very symptomatic. Last thing, CAT scan. We're looking in cross-section. Look at all this food trying to get down, all right? This person, if she lays down, she could aspirate some of that. And just a quick showing, again, radial access, catheter in, goiter lighting up, ready for treatment. There is emerging evidence, the Yilmaz paper, huge, this drop this year. For those interested, take a look. Bottom line is that you get about 50% shrinkage of that clinical target volume in 6 months, which is comparable to RFA. It's my pleasure to speak to everyone today. I'm going to stick around in the chat. Very excited. If you have any questions or are interested in this topic, please reach me. You can DM me at my Twitter. And wishing everyone a successful and enjoyable rest of the meeting. Thank you.
And thank you so much, Dr. Sog. It's really incredible to see like how much the goiter diminished just after the particle embolization. But I'd like to now introduce Eugene Moon. He's an MS3 at Creighton University in Phoenix.
All right, today's it's my pleasure to introduce Dr. Timothy Huber. He is a vascular and interventional radiologist currently practicing at Oregon Health and Science University as an associate professor of interventional radiology. He received his medical degree and completed his diagnostic and VIR training all at the University of Virginia. And he has numerous publications with the topics ranging from thyroid radiofrequency ablation to prostatic artery embolization. Today, he'll be talking about thyroid radiofrequency ablation.
All right, thank you very much, Eugene, and thanks, Dr. Park, for moderating, and thanks, Alan, for that excellent introduction to the whole topic of thyroid intervention. It's a really interesting and exciting time for thyroid intervention. You know, for a long time, our role in IR was more or less relegated to biopsies, and that was about it. But increasingly, we have a lot of cool new procedures in our toolbox, and I think pretty soon we'll be able to do just about any size nodule that needs to be treated, from the smaller ones with RFA to these big, you know, monstrous substernal things that Alan's able to treat with embolization quite effectively. So I'll present a complement to Alan's talk and talk a bit about thyroid RFA for both benign and malignant thyroid tumors. if this will behave. Here we go. So what is thyroid nodule RFA? So you're familiar with RFA in other parts of the body. It's a thermal ablation technique where we're using electric current to create an induction of electrical heating in tissue. So we're typically using this in like liver, bone, lung, organs where you generally have a lot of space around a tumor where we can kind of ablate a margin with relative impunity. But in the head and neck, we're trying to treat thyroid nodules. There's a lot less space that we can heat into safely. We don't want to cause injury to the trachea. We don't want to cause injury to the esophagus or the neurovascular structures in the head and neck. So RFA was sort of not a great option for many, many years until special electrodes were designed that were more compatible with those tight spaces in the head and neck. So it's all the same principles for RFA in thyroid versus other parts of the body, but we have, as you can see here, shorter electrodes. On the bottom is the thyroid-specific probe, much shorter active tip, shorter shaft, handle still relatively the same, so you still have good control of the electrode, but a lot easier to use in the head and neck. These are internally cooled electrodes, so the shaft is cooled, which helps reduce char and kind of protect the skin as well. And basically in the US, we have different options for active tip lengths. You can see they're all very small, so 5 millimeters, 7 millimeter, 10 millimeter active tip lengths. And that's the active tip. Here you can see that's shiny and silver, and that's the part that's going to heat up. The rest of it's cooled and relatively protected from heating, but this is where all the action is going to be right around the tip. And the interesting thing with the way we do RFA in the thyroid, we're not doing a stationary technique. We're actually moving the electrode the whole time. So this is sort of a distinction between a dynamic and a static ablation. So in the liver, for instance, we're putting the electrode into a tumor and we're letting the electrode over time slowly heat an area of the liver, including that tumor that's going to be killed as we heat it slowly. In this technique, we're not waiting to grow an ablation zone of a certain size. We're actually causing sort of very local injury within a few millimeters of the active tip, but we're not letting the heat spread too far beyond that. So instead of parking the electrode in one spot in a static type of an ablation like the liver and growing the ablation zone, we're instead moving the electrode almost continuously through the nodule, burning small subunit by subunit until we've treated the entire nodule. So a little bit of a different concept to what you maybe be more familiar with. So we call this a moving shot technique or more of a dynamic ablation. It gives us a lot better control of the ablation zone shape. So we can shape the ablation zone to be a little bit irregular, or if the nodule is kind of lumpy bumpy, or if it extends into the isthmus, you can treat all of that kind of funny irregular shape versus just a regular, more ellipsoid or spherical ablation zone. It's also much better in these high-risk areas. A lot of these nodules, as you'll see, are close to the carotid artery, very close to trachea, close to the recurrent laryngeal nerve, or close to the esophagus. And we don't want to deposit a lot of heat energy into those areas for obvious reasons. So this lets us get very precise control of the tumor without having to damage those structures. So I'll present two cases. First one is a lady with a slowly enlarging nodule for about 5 years. She had normal thyroid function, so no underlying thyroid disease, and her symptoms were basically a worsening foreign body sensation and pressure in the neck. So we always talk to patients in clinic about sort of what their symptoms are. We don't want to treat asymptomatic nodules. When they get to a certain size, usually over around 2 centimeters, they can start to put pressure on the local structures in the head and neck. And so in this case, they're starting to put pressure just in the sort of soft tissue region, this kind of constant feeling like there was sort of a golf ball in her neck. All of these symptoms were worse when she would turn her head or extend the neck. And as that sort of makes sense, you're putting pressure on the capsule of the thyroid and on this nodule that's sort of extending out from the thyroid gland. Now, interestingly for her, she had had a prior right hemithyroidectomy, so this nodule was on the left. This is for a benign nodule 10 years previously. And then an interval had anterior cervical fusion. So she was really wanting to preserve her thyroid function. Again, normal function, didn't want to start taking Synthroid. And her surgeon wasn't very interested in going back into her neck after having had prior surgery and then the anterior fusion. So we brought her into our clinic to chat, and you can see here, this is her nodule. It's a little over 3 centimeters in biggest dimension. Volume is about 8 cc's. TSH normal, free T4 is normal. We always check those labs on folks ahead of time just to make sure there's no underlying thyroid disease and to get a baseline to make sure their TSH is normal, both pre and post. And you can see a nice isoechoic spongiform nodule, very benign in appearance. Nothing about this that makes us very concerned. We got 2 FNAs. She had had one previously, and then we got another one when she came to see us, and they were both Bethesda 2, both benign. The KSAR guidelines, which we sort of use in our program here, more or less, recommend 2 ultrasound-guided FNAs before RFA. And this is because, unlike surgery, where we take out the nodule and can section the whole thing, we're ablating and leaving the tissue in situ. So if there is a focus of cancer in this nodule, it's going to be left behind, hopefully killed by RFA, but it's a little bit more risky to leave indeterminate cytology behind. The other part is if this starts to grow later and you're unclear about if this was benign or malignant when you started, if you biopsy it after ablation, it's going to come back with some very strange pathological results that look suspicious for cancer and probably end up getting cut out. So better do the full workup ahead of time. So recommend 2 FNAs prior to ablation. There are ATA guidelines in the works, and I think that they will be very similar to the KSAR guidelines and the ETA guidelines, which both recommend 2 biopsies. So here she comes in for the procedure. So day of procedure, you can again see this nice spongiform nodule kind of within the thyroid gland, nice rim of tissue along the outside. Not that vascular, a little bit of peripheral vascularity, but nothing too intense. And so we start these in a transisthmic approach. So you can see my lidocaine needle coming in here, anterior to the nodule. And here we're doing a little bit of, it's not really hydrodissection in the true sense, but we're injecting lidocaine in a perithyroidal fashion. So just in front of the thyroid capsule here, this hypoechoic bubble is lidocaine. And you'll find that as you inject in that space, it'll really run superiorly, inferiorly, and laterally, and really bathe the whole anterior surface of the thyroid in lidocaine and anesthetize everything really nicely. I do a mixture usually of lidocaine and 0.25% marcaine, and that gives a good long-acting anesthetic. So you can see that there. This red triangle is what we call the danger triangle. This is an area between the trachea and the posterior border of the thyroid gland. It's where the recurrent laryngeal nerve runs that goes to the vocal cords. You don't want to damage that, so we're very cautious. Our approach going from medial to lateral makes it very difficult to kind of leverage your RFA probe into that region and damage the nerve. So that's why we recommend doing that sort of transisthmic approach. Here we have the carotid artery and the jugular out laterally. You can see the nodule is very close proximity to both of those, and the vagus nerve runs in close proximity to those as well. So here we are again going from a medial to lateral approach with the tip of our electrode at the posterior and lateral border of the nodule. You always want to start deep when you're doing these ablations, because as you'll see, as we're doing our ablation, we get a lot of microbubbles and cavitation of these little foci of gas around our tip as we're ablating and burning, and that will shadow out what you're doing posteriorly. So if you start anteriorly, you're going to be able to not really see what you're doing in the posterior part of the nodule. So always work deep to superficial, kind of like we're doing here. And we basically go and we ablate and pull back slowly and ablate multiple little subunits all the way through the nodule, and then repeat fanning up a little more superiorly. Keep doing that until we've done the entire nodule. And at the end, it should hopefully look like this. You can see this nodule is totally devascularized, very heterogeneous in appearance, mostly hypoechoic with a few little areas of hyperechoic bubbles trapped in some of the thrombosed venules here. So that's sort of what you're shooting for. She came in to see us at 1 month, and you can see here the appearance at 1 month, again, devascularized, hypoechoic, starting to shrink down in size. Her symptoms that improved subjectively basically had resolved. The volume went from 8 down to 5 cc's. The reduction ratio is about 36% at 1 month. TSH still normal, and she stayed normal as far as her TSH for her full 12-month follow-up. In the end, she ended up reducing the volume of this nodule by about 85%. So a really good result for her to not need surgery, and symptoms totally resolved. So this is what you want to see, a really well shelled out nodule, no peripheral areas of viable tissue. And in these, you can expect a very good reduction in volume. So benign solid nodule with compressive symptoms. So these thyroid nodules are very, very common. A little less common by palpation, but by ultrasound, almost half or more of the population is going to have a nodule of some size, but most of them are very small, won't grow very much, and don't cause symptoms. But in some patients, they'll get to a size or be in a location that does cause compressive symptoms. So again, roughly 2 centimeters is kind of what I use in my mind as a sort of threshold. Below that, pretty unlikely to cause symptoms, although in the right patient, in the right location, they certainly could. So RFA is a great alternative to surgery for these patients. The benefits are it's outpatient. There's no anesthesia required, no moderate sedation, just local anesthetic, and it preserves the thyroid tissue. There's really not really a risk of making these patients hypothyroid after this procedure. Really important to do good hydrodissection, kind of perithyroidal lidocaine injection. That's how we're going to keep these patients comfortable through the procedure. But with that, they do very well. And some anatomic considerations. Again, we want to think about that danger triangle, the recurrent laryngeal nerve territory medially. And size reduction. So what can patients expect? What's sort of keeping us on track in terms of expected reduction in size? So Dr. Beck's group has one of the bigger experiences in the world. They reported in their 4-year follow-up results about a 70% reduction at 6 months, about a 90% reduction at 1 year. Now, this may be a little bit, he's very talented and has a lot of experience in this, and his results may not be what everyone else in the world can expect, but I think this gives us a ballpark of what to shoot for. And this reduction in volume was definitely maintained out to last follow-up at 4 years. So very good reduction in size of these nodules. So case 2, this is switching gears here to malignancy. So this is the case of papillary thyroid cancer, an older male, 71 years old, who had a thyroidectomy for PTC and left neck dissection with all positive lymph nodes in that specimen. So he got RAI, and then a year later had additional positive nodes. So more dissection, more RAI, and then additional RAI 2 years later for recurrent nodes. Was stable for a couple of years, and then in 2020 had a positive level 3 node and a thyroid bed node and some lung nodules that were indeterminate. So he came to us because he needed a biopsy, and so we got specimens from this nodule next to the carotid and this little node in the thyroid bed here. Thyroid globulin had been going up slowly over a few months, so that was worrisome for recurrence. So they came back as positive for PTC. So we had a big discussion about where to go next. Do we do surgery, immunotherapy, RFA? His oncologist wasn't too excited about pulling the trigger on chemotherapy or immunotherapy, and the surgeon was not excited about doing another neck clean out on him. So we all felt like it would be a reasonable option to offer RFA. So you can see here, this is the node next to the carotid, really kind of plastered on. We were hoping to be able to hydrodissect this off. So here we are during the procedure. Here's the node. We've started some hydrodissection here. You can see posteriorly, we're doing some hydrodissection to move this structure away, which is the vagus nerve. So we were able to come in with this a little bit unusual but lateral to medial approach along the long axis of this node. And we were able to dissect here and actually get some hydrodissection fluid in between the carotid and the node. We were able to ablate that. But it's very important to know your anatomy. So here you can see we had to pick up this finding of the vagus nerve and move that away from the node before we could treat it. So in the postoperative neck, anatomy can be a bit distorted. They had taken the jugular vein, so that landmark wasn't really there. And so we were basically looking at this vagus with a node more or less in this region. So we ablated, we got a good ablation. Here you can see it's devascularized. And we turned our attention to the thyroid bed node. Again, it's this guy, a lot of scar tissue in this region, very difficult tissue planes to image, but here's that positive node. So we came from, again, sort of an out of plane shot here, but along the long axis of the nodule here, with our electrode through it. And did sort of a pullback maneuver and got a nice ablation zone encompassing the node there. So 3 months after the procedure, you can see the one near the carotid is shrinking down quite a lot here and here. And thyroid bed also right in here. So biochemically, he dropped from 7.9 initially. Initially, he had a rise to 10.8 and then dropped down ultimately at 3 months to less than 0.09 as thyroid globulin. So this little transient bump is really common. Basically, as we're ablating the tumor, it's just releasing thyroid globulin, but ultimately drops down as we've treated these tumors. And the level 3 node decreased in size significantly, as did the thyroid bed node. So some different technical considerations for these. Hydrodissection is really important. You want to make sure that you push all the vascular and nerve structures away from these nodes before you treat them. So we try to get a 5 millimeter margin around the nodule if possible. It will dissipate, so you need to move kind of quickly with these and get everything kind of in place, ready to go, do your dissection, and then ablate as quickly as possible. And they have to decide if you're going to do more of a stationary or dynamic ablation. Typically, I do sort of a pullback ablation where we're kind of into the nodule, start ablating and pull back slowly. But sometimes you can size your electrode such that you can do sort of one station, kind of more like you would do for a liver ablation instead of that moving shot technique. So how does this work? Again, looking at Dr. Beck's work in Korea, This is one of their earlier reports of 29 patients with 46 recurrent PTC tumors. And they report again at last follow-up, a large decrease in the number of tumors. They had complete disappearance in about 91% of these tumors. And then looking at surgery compared to RFA, in 73 patients, 27 had RFA and 46 had repeat surgery, and they had very similar 1 and 3 year recurrence-free survival rates. So slightly better reported in RFA, but not different statistically. So certainly not inferior. So at OHSU, we have a multidisciplinary program, like you're hearing a lot today. Multidisciplinary programs, I think, are a really great way to go with any of these programs. So ours is a collaboration between our department and the Thyroid and Parathyroid Center. We're in our second year of operations. We've treated about 57 patients so far. We have a group of myself and then representatives from head and neck surgery, surgical oncology, and 2 endocrinologists. And we discuss all the patients that get referred into us for this procedure and kind of try to decide on the best and most reasonable procedures for the patients, whether it's surgery or RFA or observation, and make sure they're all worked up appropriately. So how are we doing? So in our first 30 consecutive patients with 38 benign nodules, all non-functional nodules in this group, we had a mean baseline nodule volume of about 12 cc's. At 1 month, that was decreased on average to 6 cc's, 3 months, 4.5 cc's, and at 6 months, 38. So, 3.8. The volume reduction ratio of 61%, and that was significant. But how do patients do symptom-wise? So we grade their symptoms based on a sort of score from 0 to 10, 0 being not bothered at all, 10 being bothered sort of constantly. And our patients on average rated their symptoms a 6. At 6 months, that was down to 0.6. That was significant. And then cosmetic score, we grade them from 1 to 4, 1 being no cosmetic defect, up to a 4, which is a visible lump in the neck. And on average, we were at a 3.7 at baseline. And at 6 months, that was down to a 1.8. So that's our program. That's Thyroid RFA. I'm always happy to answer questions by email or tweet. Thank you very much for your time.
All right. Thank you, Dr. Huber, for that talk on thyroid RFA. And thank you, Dr. Park, for answering questions in the chat. For time's sake, I'd like to introduce our next moderators. First is Ty Matheson. He's an MS4 at University of Washington. And Troy Sanders, MS3 at University of California, Los Angeles.
Thanks, Eugene. Yeah, so it's my pleasure to introduce the next panelist. We have Lee Casadaban. He's a vascular and interventional radiologist at the University of Colorado. She received her medical degree from the University of Illinois College of Medicine. She completed her diagnostic radiology residency at Brigham's Harvard Medical School and completed her fellowship in vascular and interventional radiology at the University of California, Los Angeles. Through her career, she has accumulated publications in a wide variety of areas, including genicular artery embolization, portal hypertension intervention, and neoadjuvant chemotherapy for colon and liver cancer. So she'll be giving us a talk on portal hypertension. So without further ado, I'll pass it over to Dr. Casadaban.
Thank you so much for that very kind introduction. And thank you so much to the organizers and hosts. What a wonderful platform this has been so far. Great discussion so far. It's an honor to be part of it. Thank you so much. Also want to say hi and shout out to Dr. Ed Lee, who's moderating the session in the chat box for this as well. He was my program director and a wonderful resource, taught me almost everything I know, and you guys should definitely utilize his expertise during the session here. So without further ado, I'm talking about portal hypertension. It's kind of hard to cover this entire topic in 10 minutes, but I'm going to do my best. So once again, I'm Lee Casadaban from the University of Colorado. So just basics to start. So portal hypertension and its complications is a major cause of mortality other than hepatocellular carcinoma for patients with decompensated cirrhosis. It leads to portal systemic collateral veins that can cause variceal bleeding. It can cause ascites and hepatic encephalopathy. Here's a basic diagram here that shows the portal system. It's an intercapillary bed system. It takes all the blood absorbed from the gut and it brings it to the liver, which acts as a first pass for any toxins. And when you have disease here with the liver, you can have increased resistance in the portal system. It can lead to increased hypertension and formation of these collateral vessels here shown that can cause a lot of problems, in which I'll get into more detail soon. So portal hypertension is defined as hepatic venous pressure gradient greater than 5 millimeters of mercury. That is an incredibly important number that you should all commit to memory. It's very, very important to know. HVPG itself is just a surrogate for the portal systemic pressure in general. So to get a direct measurement, you have to stick an actual needle into the portal systemic system, the portal venous system. But we use this sort of gradient as a surrogate for it. Usually it's the wedge pressure in the hepatic veins minus the free pressures, and that's a surrogate. And those are the numbers that we usually go by. So clinically significant portal hypertension is defined as a gradient greater than 10 millimeters of mercury. That's really important. So even though you can have portal hypertension, you're probably not going to have symptoms until your gradient gets above 10. And even more importantly, variceal bleeding really occurs at gradients greater than 12 millimeters of mercury. These are just basic numbers that's really important to commit to memory. There are many causes of portal hypertension. We often think of just cirrhosis, but it's actually much more complex than that. I'm not going to read the whole slide here to you, but it's important to understand there's more than just cirrhosis, and you can divide them into three main categories. The first being prehepatic causes, the second being hepatic and sinusoidal causes, and the last being post-hepatic causes, which include Budd-Chiari syndrome. So there are many imaging findings for portal hypertension. This is a Y90 patient that I treated last week. As you can see, there's recanalization of a paraumbilical vein, which is pathognomonic for portal hypertension, shown here. And he's also got a non-occlusive thrombus in his portal vein too. So you also see the ascites here, nodular contour of the liver. These are all classic signs for portal hypertension. In addition, you can see these collateral vessels and varices. This is a patient from my clinic. You can see what's probably most important on this screen here are these vessels here. So these are dilated veins within the wall of the stomach. So these are gastric varices, and the reason why they are so important is because they can bleed even at very low pressures. And so you have to be very cautious when you see these, and you should think about, offering a patient a procedure or treatment for if you see something like this and they have had a history of bleeding. You can also see the same patient here has multiple other collaterals shown up in the left upper quadrant. You can see these mesenteric collaterals shown here, and of course splenomegaly. So these are all images of the same patient. This is a young patient who had a portal vein thrombus from a very early age and has all these complications with portal hypertension. So what are the complications of portal hypertension? Well, there are a few. You can have ascites, you can have esophageal varices, gastric varices, and variceal bleeding from those. And each one carries a 30 to 50% mortality with each bleed. You can have portal hypertensive gastropathy, enteropathy, and colopathy. You can develop hepatic encephalopathy, which is the confusion. You can develop hepatorenal syndrome, hepatopulmonary syndrome, and congestive splenomegaly and hypersplenism as well. What are the treatment options available? Well, there are always lifestyle modifications. We can recommend dietary sodium restriction for patients with ascites. We can recommend some medications such as propranolol for varices. You can recommend diuretics for ascites, but there are also interventional radiology procedures that we can offer. So number one being creation of a shunt. So transjugular intrahepatic portal systemic shunt is an example of something that is a very common IR procedure that we perform. You can also offer a balloon dilatation of a hepatic vein for patients with, for instance, Budd-Chiari syndrome, transhepatic clot thrombolysis in patients with portal vein thrombosis. You can offer a splenic artery partial embolization, which helps decrease the pressure head and takes off the amount of volume going into the portal system. And then ultimately, a liver transplant is another treatment option, which is a curative option for these patients. So this is a case I actually borrowed from a colleague that we performed last month. This is the creation of a TIPS. So you can see they've gotten access across the liver into the portal venous system, and they've passed a pigtail catheter here for a contrast port cabogram. What you see here is, in addition to normal anatomy, you see this abnormal vein here. This is a coronary vein. and you get abnormal filling, and then you can see it kind of goes into the esophageal area here, probably filling some esophageal varices. So this is abnormal. And when you see this at the time of TIPS creation, you can actually coil across and prevent blood flow from going through that area and help treat these varices. This is the same patient. We got our catheter a little bit further down into the IMV, and this is abnormal. Usually veins are supposed to go up towards the liver. In this case, this is retrograde filling towards the rectum here. And the reason why this is abnormal is because contrast is going the wrong way. It means blood flow is going the wrong way and filling these rectal varices, which is causing this patient symptoms as well. So we were able to get down into those areas and coil and prevent further blood flow down into the rectal varices. So there are many indications for TIPS. These are all highly testable, very classic boards questions that you need to understand. So the two main indications that you should be able to rattle off the top of your head are recurrent variceal bleeding and ascites refractory to medical management. So typically before offering a procedure, you want to see these patients have done something, tried to treat these symptoms before, and have failed before offering a TIPS. In addition to these two, there's also a role for TIPS in the acute variceal bleed scenario. So when patients present with the acute setting in that hospital admission, if they fail pharmacological therapy and endoscopic sclerotherapy, you can actually perform a TIPS in what we call sort of an emergent scenario and setting. So that is also an indication. You can perform a TIPS for hepatic hydrothorax that is not adequately managed, for portal hypertensive gastropathy, hepatorenal syndrome, lower gastrointestinal and stromal varices, and then Budd-Chiari syndrome that's not responsive to anticoagulation. There are also contraindications to TIPS. These are also just as easily testable. Severe chronic liver disease or rapidly progressive acute liver failure is a contraindication. And the reason for that is because creating the shunt is going to siphon blood away from the liver. And so if the liver is already compromised, siphoning more blood flow away from it would put that patient into progressive failure. Patients with severe encephalopathy resistant to medical management is a contraindication because you're increasing the shunt of blood with toxins, including ammonia, that can get into the systemic circulation and cause encephalopathy. Severe right heart failure is a contraindication because a TIPS would increase your heart pressure. Uncontrolled sepsis carries a risk of stent infection. Cavernous transformation of the portal vein can make it technically challenging to perform a TIPS. It's not an absolute contraindication, kind of depends on the anatomy. Cystic hepatic disease is another contraindication, occlusive main portal vein thrombus, and hepatic malignancy or hemangiomas. Now, I will say some of these are relative, but some of them are absolute contraindications. All right, if I could impress upon you guys one thing during this talk, it should be this. It is the MELD score. It is an incredibly robust and very strong scoring system. It was created in 2000 to predict mortality in patients undergoing a TIPS procedure. However, it has been shown to be so strong and robust that it has completely revolutionized the field of hepatic transplant medicine as well, and is often used in deciding which patients should be candidates for transplant and the scoring system used. So just a very interesting example of something that was created by and for IR that has now revolutionized other fields of medicine as well, because it is so strong. So this was a paper that I did in my training that I'm going to allude to here. We looked at a 100-patient cohort. We wanted to validate the MELD score for the emergent TIPS population. So before this, the MELD score was really used for elective TIPS, but not used necessarily in the emergent TIPS scenario as strongly. And so what we did is we took our own 100 patients and we ran a whole bunch of variables into the statistic analysis. And what we came up with is we almost completely rederived the exact same MELD score. You can see it's just an equation of bilirubin, creatinine, INR, and the cause of cirrhosis. And even despite putting a whole bunch of new different variables in there, we recreated the exact same MELD score, which just is a huge testament to how robust and strong it really is in predicting mortality after TIPS. So from that paper, we divided the patients based on MELD score and looked at 90-day mortality. You can see less than 10 MELD had pretty good mortality and even up to 18. But once you get above 19, the mortality just gets super, super high. And again, this is for the emergent TIPS population in this scenario. This is a Kaplan-Meier curve of the transplant-free survival for MELD score less than 18 shown here. And then above 19, you see there's almost an immediate drop-off. So these patients were dying right away after TIPS. And so this is a pretty clear indication that you should be very careful who you offer TIPS to. And I personally would rarely offer a TIPS to someone with a MELD score above 18 unless they were already on the transplant list. All right, a couple more things to go over that I think are really relevant and important. It's important to understand that gastric varices are not the same as esophageal varices. This is a very interesting paper that was sort of established that isolated gastric varices, here you see the Sarin classification, isolated gastric varices actually bleed at much lower pressure gradients than even gastroesophageal and then esophageal varices. So very interesting that, you know, these two entities are different and should be treated different. And at least personally, it would make me much more eager to treat someone with gastric varices with isolated gastric varices. All right, one more paper that I did in my training was looking at hepatic encephalopathy. It was almost, you know, there had been some case reports, but not as well clearly defined in terms of, you know, what was the incidence of hepatic encephalopathy after TIPS. We found a total incidence of 42% in our population after TIPS creation, half of which were de novo cases. That seems pretty high, but it is actually in line with prior reports. It's between 30 and 40%. What we found was that hepatic encephalopathy really developed about 2 to 3 weeks post-TIPS in de novo cases, but it actually occurred earlier in patients with a prior history of encephalopathy. So they were already primed and more prone to develop it, and it occurred a little bit earlier. Cases were mostly mild or moderate, which is incredibly good. And when you're counseling your patients, you should tell them that this could occur, but it's mostly mild or moderate and very amenable to medical management. We only had 4% of patients that had to have a subsequent procedure, such as a TIPS reduction or occlusion to help treat their encephalopathy. And then we found that worse liver function and also older patient age contributed to encephalopathy after TIPS. It'd be amiss if I didn't mention the burrito procedure. That was a joke. That was Dr. Ed Lee's joke, actually, which I think is hilarious. So this is not a burrito. This is the BRTO procedure, balloon occluded retrograde transvenous obliteration. This was very, very frequently practiced in Asia, but recently has become more common in the US as well. And this is a treatment for gastric varices only. That's very important to know and remember. Particularly, you know, you want to scour the CT scan to look for these portal systemic venous shunts, because that is the mechanism which you can go through to do the procedure and coil the gastric varices. So you're looking for like a gastrorenal or a gastrocable shunt that you can access through the venous system and do a retrograde obliteration. There have since been many modifications of this technique. Parto, Carto, and Bato, which I'm sure you guys have heard of. That in itself could be a whole new lecture just describing these different techniques. But overall, it gives a very high rate of technical success, 77 to 100%. Bleeding rates are low, 5 to 15%. But it's important to know that a BRTO is not the same thing as a TIPS. You're not really treating the portal hypertension, you're only treating the gastric varix in this scenario. And so this may actually worsen the portal hypertension. So you have to be very careful in who you offer this to. And so patients, you should look and make sure, see if they have esophageal varices, if they have ascites or hydrothorax, you need to counsel them that this could actually worsen those because you are actually worsening the portal hypertension, but you are treating the gastric varix. All right, that's all I had. I tried to keep it down to 10 minutes. And so if you have any questions or comments, please feel free to reach out.
Awesome. Thanks, Dr. Casadaban and Dr. Lee, who has been in the chat. Very interesting talk on portal hypertension. And I'm sure that we can take these tidbits in the future. I'm pleased to announce the next moderator, Viraj Patel. He's an MS2 at Albany Medical College.
Thank you so much for the introduction. It is my pleasure to actually introduce our next speaker. We have Dr. Miles Conrad. He is a professor of radiology at the University of California, San Francisco. He completed both diagnostic radiology and interventional radiology fellowship at the University of Arizona. Additionally, he obtained his MPH in quantitative methods from the Harvard School of Public Health, and today he's going to be talking to us about the role of IR in trauma. Also, we have Dr. Bairamurthy, an assistant professor at USC, moderating the chat to answer your questions. Thank you so much for your time today, and looking forward to your talk.
Thanks a lot. Nice to be here on a Saturday morning. Good to be at this conference. This is an outstanding conference. So I'd like to talk to you today about unstable patients in the IR suite and embolization and other things that we can do in IR to take care of them. This is a kind of a challenge to the traditional paradigm, which is that stable patients come to IR. But when you move into the OR, as you'll see, there's more of a inclination to treat sicker patients. So these are my disclosures. So unstable patients in IR is kind of thought of as a new frontier. The origins of embolization and interventional radiology really came out of the need for alternatives to surgery because surgical interventions, for example, in pelvic fractures, had poor outcomes in some situations. And obviously we just heard about TIPS and variceal hemorrhage, and the mortality rate in those were quite high. And so it's normal for IR to innovate in that situation. We're kind of used to basically being in, faced with critical situations, and we have to come up with different decisions, and that leads to innovation. And the hybrid OR is a ripe place for innovation. So I'd like to talk about that and the experience of algorithms for non-operative management of hemodynamically unstable patients, which is a new shift that we're seeing, and talk a little bit about how it relates to the pelvis and solid organs, and then briefly mention innovations in the IR suite in future directions. So in 2016, there was basically a city bond was passed in San Francisco, and a new hospital was built. And San Francisco General, which is a very old institution, our Department of Public Health has been around and had San Francisco General as our primary trauma center. And with a city bond, we were able to build a new trauma center. And as is the case with many new hospitals being built, IR basically gets pulled out of wherever it lives, which is in the basement or the lobby or whatever floor of the hospital, and gets put into an OR. This is called being redlined, and people talk about it in good and bad ways. It means you basically lose your, potentially can lose your availability to referring providers, because if they want to visit you, they have to put on a bunny suit or wear scrubs. And so if you ever are in this situation, ideally you have your IR suite built on the periphery of the OR so that people can still come into the reading room without scrubs. But this is what happened, and we're now behind the red line. And those are the disadvantages. The advantage is that all of a sudden we're right next to the OR level 1 primary suite for major trauma. And we are there with all our anesthesia colleagues. We have a couple hybrid suites with a vascular surgery suite that we can use as well. And then the key here is that there's a CT scanner in the IR suite. And this is basically a chemoattractant to anybody who's having problems in the OR, namely hemorrhage. They don't know where it's coming from. They're going to possibly want to use that. And in addition, they threw an interventional MR suite. So basically have all these toys, all these different personnel, and then a lot of energy, because we're pretty excited about this stuff. And so we've been able to kind of push the envelope and see how we can expand the indications for some of our trauma interventions. So what happens when you move an IR suite with a CT scanner into the OR at a level 1 trauma center? Well, the first thing is that non-operative management can extend to more unstable patients. And there's 2 categories of unstable patients that come to to IR. The first is if you have a crisis and you need CT to find the bleeding. Those patients will often come to the IR suite, get the CT, and then they'll stay there for an embolization. And so here's the CT scanner that just rolls in, and then basically it moves away, and then the fluoro suite comes into play, and then we just do embolization after that. The second category of patients that come to IR is if endovascular care has better outcomes. This is the case in the surgical soul of the abdomen, so-called in the epigastric area, deep in the retroperitoneum, places where you can't find the bleeding, like the chest wall sometimes, lung bleeding, skull-based bleeding, posterior liver, and other hard-to-reach places. This is an ideal situation for us to kind of get involved in some of these sicker patients, because surgical exploration can be fraught with problems. And as I mentioned, the CT and the IR is a chemoattractant. I mean, people just gravitate to it if they are in stressful situations. If our surgeons don't know where bleeding is coming from, they might do that. This is an example of one of those cases where someone's on the table here. This is the C-arm. There's a surgeon suturing a scalp wound, and the CT scanner can come in. And the whole point here is that the IR needs to be basically shepherding this case around. I mean, this is like a dance, because this thing right here, this gantry will come in, it'll rip all the endotracheal tubes out of the patient. It'll hit all the lines, take the IVs out. It'll beep when it hits people's heels, for example. And so it's a great place, but you have to know what you're doing, and you have to be very proactive, and kind of, we can all work together, but we have to show people around. And it also poses the chance of boundary issues, the risk of that being exploited potentially. But as long as we're there and we're being very multidisciplinary, as we always are, we can kind of control the flow of patients, and they definitely don't want to break any equipment. So what happens is you start seeing patients like this. I mean, this is somebody that would never have come to IR before. More penetrating trauma. This is somebody who had GSW to the chest, and they have uncontrolled hemorrhage. They don't know where it's coming from. They come to the IR suite after they transiently stabilize the patient. You get a CT scan, and you find this aortic injury, and then we're able to do here's the extravasation coming off the aorta, and you put a balloon up, and it turns out this is this REBOA technique, this resuscitative endovascular balloon occlusion of the aorta, which is a temporizing maneuver. You put the balloon there, and if you don't inflate it enough, it likes to bounce down the aorta and then make bleeding a hell of a lot worse. So you got to make sure you put it in the right spot. So here it is occluding the aorta, and then we put an endograft in with our vascular colleagues. Other things that we never used to see, but now we do see, penetrating lung injuries. Like here's 3 penetrating chest injuries. You have a gunshot wound to the chest here, gunshot wound to the chest, pseudoaneurysms, and then a stab to the lung. And this kind of thing is just enabled because CT tells us where the bleeding's coming from, and then we can go ahead and treat it. Here's a weird thing that I haven't seen happen in a long time, but basically this is somebody with extensive pelvic fractures, retroperitoneal bleeding all over the place. You can see this massive area of extravasation. This patient was unstable. They were ejected. They never would have come to IR in the old days, but because we have the scanner, we're able to take a look, and then we can do these pan angios where you're just basically treating the entire patient with an angio and embolization, and even looking and finding renal vein injuries, renal dissections, renal artery dissections. Here's a lumbar artery bleed, and watch out, there's the artery of Adamkowitz. So it's just a reminder that even in fast-paced situations, you got to be really, you really got to watch out for complications, especially when you're treating retroperitoneal things in the lumbars. And these sort of cases, as I mentioned, never would have come to the IR when we lived in the old hospital in the basement. So is this really a new frontier? We're seeing unstable patients in IR. Well, I submit to you that it's not really, because the origins of embolization really were born out of necessity in unstable patients back in the early 1970s. And so now that we're back in the OR and we've had great success, you know, a lot of us, you know, IR has been more affable. We're a little bit more aggressive than we used to be in the old days. And so that's led to some new developments. And the origins of catheter embolization are in unstable patients, and we should look at that and see if we can treat these patients. So I just want to remind you a little bit about pelvic arterial injury, and we can look at how this approach applies there. So in general, most pelvic injuries that are associated with bleeding are venous. Only 2% are thought to be arterial, although that number is probably gone up a little bit because we're finding more bleeds with our CT scanners. They're better. But the mortality is high if you have arterial hemorrhage. And importantly, it goes up the longer you wait for embolization. That's in the case of arterial bleeding. The majority, as I mentioned, are venous hemorrhage, and it's easy to understand why. The veins are all along the spine and along the sacrum and along the pelvic floor, and they're easily torn by fractures. With the arteries, we have the superior gluteal artery going along the roof of the greater sciatic frame and often gets torn there, and the obturator artery going through the obturator canal right here often gets torn. So these are the intervention, these are the embolization targets. Here's this, the obturator artery will go through the obturator canal, easily torn, greater sciatic frame and supragluteal artery easily torn here. And here, these are the standard targets here. Supragluteal artery gets torn between the iliac bone and the piriformis muscle. I'm getting the pinwheel of death. There you go. There you go.
Dr. Conrad, did we lose you?
Yep. Can you hear me at all?
Yeah,
we can hear you. We can hear you.
Oh,
yeah.
All right, cool. I got a pinwheel of death here on my screen, which I haven't had in a while, but
that's okay. I mean, just keep on kind of talking about what you're.
Okay, I can't advance the screen at all, but basically there we go. Now it's doing a thing. Okay, cool. We're good.
Kind of keep it interesting.
Thanks. So I'm going to try to put this back on. There we go. Okay, we're good. So anyway, this is the original discussion of pelvic. I'm going to take. Can you hear me okay still?
Yeah,
we can hear you.
This is the original description of pelvic arterial embolization, which was used with autologous blood clot in 1972 by Ernie Ring, back when you could publish a case report in the New England Journal. And see if I can, having a hard time going forward on my slides. Yep. Give me a second here. All right. Yeah, I got a frozen computer.
Do you mind holding on that slide, and maybe we can jump back to your presentation?
Yeah, no problem.
Okay.
No problem.
Sounds good. So why don't we take a quick detour here? I'd like to bring our next moderator, who will be moderating the OB-GYN section. Give me 1 second here. I'd like to introduce Setban Molij, who's from MS4 at Western University of Health Sciences. Take it away.
All right, thank you so much, Navjeet. Appreciate it. So it's my honor to introduce Dr. Theresa Caridi, who is an associate professor and also was the associate professor and the division director of the Vascular and Interventional Radiology Department at University of Alabama at Birmingham. She's also the vice chair of the interventional affairs at the radiology department over there. Dr. Caridi completed her medical school and her residency training at the University of Florida, and then she pursued her fellowship training at the University of Pennsylvania. She's also very active in SIR and serves as the vice chair of the SIR Foundation Board of Directors as well. So Dr. Caridi, all yours.
Sissy, what's the matter?
Oh, we're hearing somebody else. Thanks so much for having me. And as all the other speakers have said, this has become a wonderful conference, and I'm really glad to be able to listen in on it and also participate. I entitled my talk, Women's Health Interventions Delivered by a Woman in IR, but for all. And that's because I think sometimes we get confused about the fact that lots of women do perform women's health interventions, but also many men do as well. And it's really an area of interest for people of all genders. And so what I'm going to talk about specifically today, these are my disclosures, are a couple of interventions that we do within interventional radiology. Obviously, women's health is much bigger than this, but we utilize uterine artery embolization, some pelvic venous disorder therapies, and also fallopian tube recanalization. And sort of our bread and butter practices. You know, fallopian tube obstruction is another thing that's probably coming down the line within our space. Obviously, it's been done by OBGYNs for a long time, but Jesse Stewart, some of you work with, I know is working on animal study in this space. So specifically within the uterine artery embolization realm, there's many disease processes that we treat with this one single procedure, which is part of the reason why I really enjoy it. And those include uterine fibroids, adenomyosis. Sometimes we use uterine artery embolization in a preoperative fashion. So for women who don't accept blood products, for instance, and are high risk surgical candidates. Sometimes in the setting of postpartum hemorrhage, and that kind of comes in two flavors. It can be immediate, you know, right after birth, or it can be something like retained products of conception or uterine AVM later on. And then also in malignancy, not for curative reasons, but if a woman is hospitalized with cervical cancer and abnormal uterine bleeding from that, we can often use uterine artery embolization to get them out of the hospital. I can't talk about all those things today in 10 minutes, so I just want to introduce the concept of UFE, or uterine fibroid embolization, which is uterine artery embolization specifically for fibroids, because this is something that really, you know, no matter what type of practice you enter in IR, this can be done in the outpatient setting, inpatient setting, whatever it might be. And some might even argue outpatient setting is better in terms of sort of patient preference. And I think that's reasonable. But the point is, no matter what type of practice you end up in, this is something that'll come into your practice model most likely. So uterine fibroid embolization, what's interesting about it is, you know, it sort of sits somewhere in between the other things that are done for fibroid therapy. So there's hysterectomy, of course, which is a definitive treatment for fibroids because you remove the uterus. And so it's a global treatment. But uterine fibroid embolization is also a global treatment. And essentially what we're doing is going into the artery, and we're treating those arteries that supply fibroids by taking away their blood supply, which, you know, takes away their nutrients and oxygen and makes them non-functional, and also reduces their size. That's a little bit different than myomectomy, where a surgeon goes in and individually removes fibroids. The similarity with myomectomy is that it's uterine fibroid embolization and myomectomy are uterine sparing. So what's interesting about UFE is I think it lies somewhere in between the gold standard, which is hysterectomy, and this, you know, and a myomectomy, which is individual removal of fibroids. And so that's what I think makes it such a nice procedure. It's very efficacious. About 90% of women get better with this procedure. And so, you know, that really rivals surgical therapies. And so it's one of the more efficacious procedures we do in IR, which is why I would suggest that you learn about it and also that you incorporate it into a practice. And then the recovery time is more beneficial, of course, than a surgical therapy, because women usually recover this, you know, within days to a week at the very most. This is what it looks like when we do a uterine artery embolization. So our catheters are in the left of screen, but right and left uterine arteries. And these are later in the phase of injection of the uterine arteries. So you're not so much seeing the main uterine artery, but these kind of robust hypervascular tumors. And again, they're benign tumors, but they're tumors nonetheless. And so we treat them similarly to how you have heard lots of other of the speakers talk about, which is with embolic. Those little particles, which are kind of like grains of sand, they're on the micron level, and these lodge in the vessels and take away the blood supply to the fibroids. I should also mention while I'm on this slide that part of the reason why we don't treat the normal myometrium or the other uterine tissue is that these fibroids sump the blood flow to them. So initially when you're treating, you're going to treat the fibroid vessels first. And then as you go on, that's when you know you get to your stopping point when you start to see those normal myometrial vessels. This is what we expect to see with uterine artery embolization. So you can see on your left of screen, this is prior to embolization, these robust enhancing things. You can see why women often have bladder symptoms because they sit right on top of the bladder. And then on the right screen, you see what happens after embolization. And this is about 3 months after embolization. So we've had some volume reduction. And of course, the fibroids are these dark holes because they no longer pick up contrast. We get roughly about 50% volume reduction, which is significant for a woman who has these symptoms. And of course, the functional aspect of it makes the bleeding go away. And those are the typical outcomes of the procedure. So just to kind of enforce these concepts and take you through a case, this is Casey Friedman, of course, a fictitious character. She's a 45-year-old female with menorrhagia, so that's heavy bleeding, which is a common way that patients with uterine fibroids present. And she wants to wear white again. And the reason why I say that is because women will come in and tell you they can't drive from home to work without flooding their seat, and they can't even make it into work. They have to call out, things like that. So this is important to women. These are some MRI images or MR images of this patient's fibroid. So you can see on the far left in the middle, there's fluid sensitive sequences, and you can see the round tumor taking up most of the uterus. And then the far right is just showing that it heterogeneously enhances, but enhances nonetheless. So when we take someone to uterine artery embolization, we end up, whether you come from the radial approach or you come from the femoral approach, either way, you end up in the same place, which is the internal iliac artery or the hypogastric artery. And this is an oblique view of a digital subtraction angiogram where we're trying to highlight the origin of the uterine artery, which is this very corkscrew artery. It has a characteristic shape. And so we do just that. When we park our microcatheter, and you can also use a macro catheter, just depending on physician preference, you can see the microcatheter takes that bizarre, crazy, tortuous course. You can see part of the fibroid enhances, but you get a sense that there's a lot of blood flow that you don't see. So we treated there, and then we go over to the right side. This is the right uterine artery that we're looking for now. We're in the right internal iliac artery. We see some of the posterior division, but we don't see that classic tortuous uterine artery. And so we turn and do a different, one view is no view. So we turn and do a different view, and we still don't see that tortuous uterine artery anywhere. And the internal iliac artery anatomy, just so you know, is one of the more complicated in the body. So it may take you some time to kind of learn this, but just for time's sake, you don't see it here. So one of the classic places that fibroids can be supplied from, or uterine flow can come from, is an ovarian artery. This is an aortogram. So similar to what Dr. Conrad just showed in some of his images, but it's a little later in the phase so that you can see this dilated and enlarged and tortuous ovarian artery, which also has a very characteristic shape. And because it's so dilated and abnormal, we suspected it supplied fibroids, and it doesn't have that on the patient's left side, as you can see. So we get into it again with our microcatheter. And as you look late in the phase, what does it show? It shows that rounded fibroid that we saw in the MR images quite well. And so if we had left this patient and only treated the left uterine artery and just said, oh, we don't see a right uterine artery, and not looked for the collateral supply, this patient would have gone essentially untreated. And when you go back, you always want to go back and look at your images pre-procedure. And what I found on these images is that a lot of time the information is already there for you. So you can see here the left uterine artery is quite classic in position. You don't see anything in the right pelvis, but then it's hard to show this in a single image, but you actually can see the dilated right ovarian artery. And so we actually really had this information before we started the procedure. I'm going to transition and talk briefly about pelvic venous disorders. This is sort of a newer umbrella term, and that's why I have the umbrella here for, you may know the term pelvic congestion syndrome. That's an older term that we're trying to get away from, and I think I'll explain why as we talk briefly here. But some of the things that go along with this, some of the symptoms are pelvic pain, which of course can be seen in a lot of other different conditions. And so we have to kind of parse that out. Leg pain is not uncommon. flank pain, and women often have varicosities in various locations and also sometimes hematuria. So when I think about pelvic venous disorders, I have to kind of break down the anatomy and the etiology so that I understand the process and the physiology. And basically, when we think about the old term of pelvic congestion syndrome, what we're really talking about is venous insufficiency due to valve dysfunction. So when I think about that, I think about enlarged dilated gonadal veins with abnormal valves, and the blood flow reverses in direction. But similarly, you can imagine similar symptomatology occurs if you have narrowing of an upstream renal vein or other vein. You're going to get the same issues with blood flow. And this is really oversimplifying it, but I just want to give you some concepts to kind of begin to understand what this disease process does. Similarly, if you've ever heard of May-Thurner syndrome, where you get compression of the common iliac vein on the left, you can have similar symptomatology. You get reflux into the internal iliac veins. Sometimes there's reflux into the internal iliac veins because of venous insufficiency that isn't related to venous compression. All these terms are a little bit of older terms, but I just want you to see them so you know what they are when you hear about them. So when we talk about the efficacy and what we do for pelvic venous disorders, and really we're talking about embolization. Now, of course, that depends on the underlying etiology. I'm focusing specifically on pelvic venous insufficiency because we can't cover everything. If it's a venous compression syndrome, embolization isn't the answer necessarily. But when we look at pelvic venous disorder embolization for pelvic venous insufficiency, what you see is there's not a lot of data. And part of the reason there's not a lot of data is because for many years we haven't spoken the same language or had a good classification system. There is this systematic review which pools several single arm studies or retrospective analyses to give us the best information that we can. And what you see here is a very commonly used scale for women's health intervention studies because often women have pain related to these disease processes. So on the left, you see what's called a visual analog chronic pelvic pain score, and below you see months from embolization. So what I'm just trying to depict here, even though this is low level data, I'm just trying to show you that essentially pain scores drop dramatically and this response is sustained. And so we have some signal to believe that this works. Now, of course, none of that takes into account the placebo effect because these aren't clinical trials. This is that classification system that I said we've been lacking. This has been developed by the American Vein and Lymphatic Society, International Working Group on Pelvic Venous Disorders. And so you can see it's kind of complicated, but the good news is we have an app for that. So if you want to impress your attendings, your faculty members that you work with, and you're seeing a patient for pelvic pain, download this app and look at it. I have nothing to do with this app whatsoever. I just find it very helpful because it is a complicated classification system. So we're going to finish with a case on this topic. So meet Melissa Koss, again, a fictitious character. She's a 41-year-old female with chronic pelvic pain, and chronic pelvic pain means pain longer than 6 months. Usually these patients have had a lot of other things ruled out, but sometimes they get cross-sectional imaging for abdominal or pelvic pain in the ER, and you have findings such as an enlarged gonadal vein like you see here on both of these images. I always, when I'm teaching my trainees, I always stop and say, so does this woman have pelvic venous insufficiency? And inevitably some people say yes. And the reality is, if I hadn't given you her symptoms, or if I don't go into detail about her symptoms, you can't really answer that. Lots and lots of women without any symptoms whatsoever have these imaging findings. So you really need to make sure that a woman, when you're seeing them, they not only have these findings on imaging, but they also have the symptoms to go along with it. So this is how I do one of these cases. I go into the left renal vein and I do a venogram, and that's because I'm simultaneously looking for whether there's venous compression of the renal vein and for whether there's reflux into the gonadal vein. And here you see the catheter parked into one of the branches of the renal vein, no venous compression, filling into the IVC, but also filling down an enlarged gonadal vein. And then we get into the gonadal vein, and as you can see here, when we do our initial injection, we know that this is abnormal because this is very enlarged, but really we don't see a tremendous amount of reflux down to the pelvis. It's kind of back and forth. And so just remember, you have tools. These women have been laying down for a while when you do these procedures. All you do is tilt the table and you might see something like this. And that's what happened with this patient. You can also do Valsalva, but what I've learned is Valsalva can make anything look like reflux. So if you just tilt the table and take a look, this is what we see. And so when we treat these women, I mentioned before that we do embolization. Well, what does embolization mean? It means we block the blood flow. If we were to try to use coils and plugs down in this periuterine reservoir, we'd have to get into every little branch and we'd probably be unsuccessful in getting everything. So we treat that area with sclerosant. And then as we go up the main trunk, we use coils or plugs or something, and usually some sclerosant in between. That's all provider preference. This is the right side, had a similar look. Again, when we tilted them and got down into the pelvis, we saw all the filling of that periuterine reservoir. Don't forget the iliac veins. You know, here we got into the common iliac vein, and we did an injection. And what I'm not showing you is that we use intravascular ultrasound and look at the iliac vein to make sure it's not compressed. This wasn't compressed, but we see all this filling of collaterals. And so we treated those collaterals, and this is what it looks like afterwards. So no May Thurner or no compression of the iliac vein, but just venous reflux. Thank you for your time. I love this thank you card. I have two things here that were given by students. This one was one of my brilliant students who drew this thank you card with wires and catheters, which I thought was so interesting and just speaks to the next generation, and this one as well. Thanks again.
Great. Thank you so much, Dr. Caridi. We really appreciate your time for this great presentation. I think we're going back to the rest of our talk about trauma. So
thanks a lot. I'm just going to keep it in this mode because I'm worried it's going to crash the computer again. But essentially, embolization has been done in the pelvis for a long time. It started in the 1970s, and we're using gel foam as the most standard agent. There's a lot of different ways to prepare gel foam. You can cut it up. You can form a slurry, which is what we're doing here. That slurry can be thick or thin, depending on what size of the particles you want to use. And there's also gel foam torpedoes, which are large chunks. So, but what I wanted to talk about is that the pelvic algorithms are kind of in flux, and embolization has, been done for a long time, as I mentioned, but we're not in-house. And so one of the big barriers for IR getting involved in unstable patients is because we're just not in the middle of the night. We're not sitting there. We're hanging out at home. And so there's been some maneuvers to try to temporize patients. One is pre-peritoneal pelvic packing, and another is REBOA. So pre-peritoneal pelvic packing was born out of the necessity because IR just wasn't in-house. And in the old days, you could come straight to angiography if you had a negative fast ultrasound and you had evidence of pelvic fracture. And there was thought that you might be hypotensive from retroperitoneal hemorrhage. But the challenge, of course, was we weren't in-house. So pre-peritoneal pelvic packing emerged, which is just basically a midline mini laparotomy with multiple lap pads. And there you can see all the radiodense lap pad markers there. And this basically is our friend. This gives us time to get to the hospital. And after they get packed, they'll either go to the ICU or come straight to IR. Another move that's been done a little bit more frequently, I don't know where the evidence is going to lead us here, but is REBOA, resuscitative endovascular balloon occlusion of the aorta. And basically, this is another temporizing maneuver. The problem here, of course, is that you're putting an occlusion balloon, this is what they look like here, into the femoral artery, marching it up blind, often in the ER, and then inflating that balloon. And we know that there's a lot of bad things that can happen with that acutely. And then also because you're shutting down the blood supply to the aorta or to the pelvis, you can have thrombosis. And this is what it looks like on CT. That's with the pelvis. So I think there's an opportunity for unstable patients in pelvis because we have these temporizing maneuvers. A bigger problem is with solid organs. The issue is that we're not in-house, as I mentioned. And traditionally, these patients are really treated with surgery because you can easily do a splenectomy in just a few minutes. But importantly, the origins of this procedure are, again, in unstable patients. And so we should challenge that idea. This is a standard technique. This is a patient with intraparenchymal splenic pseudoaneurysms. This is a distal splenic embolization. Here we go out distally and just embolize. And many of you probably are aware there's proximal embolization that's been done as well, and people go back and forth in that. But in the original publications on splenic embolization, it actually was for patients that were unstable who had other comorbidities or other problems, and they couldn't go on to get splenectomy. So 2 of the 4 patients in Sclafani's original publication in the early 1980s were in fact in shock. And if IR goes in-house, which I'm not suggesting that we do, if that is an option, and it does happen in some other countries, for example, in Japan, interventional radiologists there's actually acute care surgeons or ER doctors that are trained in endovascular techniques that live in the hospital, and they have recently published a study on treating unstable patients, and they showed that there was a very high comparable survival. So again, the issue is that we're not in-house, and we live in different places, and this is San Francisco. There's 3 choke points getting into the city. So how do we even manage this? I mean, level 1 response time is 30 minutes, but a lot of us can't even get to the hospital in that time. So I think the important thing is that there's a lot of opportunities for innovation in this situation. I like to think of the hybrid OR as a pressure cooker and an incubator at the same time, and it can lead to incredible innovations, and it's just an exciting place to work. Some of the innovations can happen with partial REBOA, for example. Maybe we partially inflate the balloon and still retain some blood flow distal. This can lead to other applications like in orthopedic surgery in lieu of a tourniquet, for example. And we need better embolics, resorbable embolics, temporary embolics. And the IR suite in the OR can lead to interesting other innovations like percutaneous embolization. Here's somebody with pseudoaneurysms of the spleen, and they were treated endovascularly, but those pseudoaneurysms recurred. And, you know, we have all this technology. We have ultrasound contrast, and we can go after these things now and percutaneously puncture them and inject thrombin. So we should challenge the paradigms in IR trauma. And so in conclusion, endovascular trauma interventions were born out of the necessity in unstable patients without alternatives. Embolization has since transitioned to stable patients because we have good outcomes, and we're riding the wave of non-operative management. But IR in the OR reopens the door to unstable patients, and hybrid ORs are incubators for innovation in trauma care. And I think as we've learned again and again today, we really need to embrace multidisciplinary environments because we thrive in them. That's it. That's all I want to say. Thanks so much.
Thank you very much, Dr. Conrad. I'd like to introduce our next organizer moderator, David Mittelstein, who is an MS4 at USC. Go ahead.
Hello, everyone. I'd like to introduce for the prostate artery embolization talk, Dr. McWilliams. He's a section chief of VIR at UCLA. His clinical practice includes a high volume of PAE procedures. And among many achievements in this field, he is the first author of the SIR multi-society consensus position statement on PAE published in JVIR. Also in the chat, we have Dr. Bagla, who's a trained radiologist and president and CEO of Prostate Centers USA, one of the first and only collaborations between interventional radiologists and urologists with the aim of bringing comprehensive prostate care to men around the globe. Thank you very much.
Hey, thanks everyone, and thanks for that kind introduction. I'm actually calling in from Death Valley, and my internet may not be terrific, so I'm actually going to stay off of video, and we'll just do the voiceover. Let me know if any trouble hearing me. It's a big topic, and I want to stay to time, so we're just going to cover some of the basics of PAE, talk about very quickly what's new over the last year, and leave you guys with some ideas of how you can start getting into PAE and building your practice. Here are my disclosures. So, you know, just in brief introduction, BPH causing urinary symptoms is extremely common. About a quarter of men over 70 have moderate to severe BPH symptoms that are impairing their quality of life. So that means millions of men in the US alone. And just to have an idea of how you initially evaluate these patients, this is the same system that urologists use. We use this scoring sheet called the IPSS, or International Prostate Symptom Score, which basically looks at 7 of the dominant urinary symptoms like incomplete emptying frequency, weak stream, etc., and scores them based on how frequently they're occurring, from not at all to almost always. So you end up with a 35-point possible score, and the higher, the more severe. And then that survey ends with a quality of life score, which basically asks the patient, how do you feel if you had to live with your urinary symptoms the way they are now for the rest of your life? And that ranges from delighted to terrible. And the way you score this is basically based on the IPSS score on that 35-point scale, and you can put that into a mild, moderate, or severe range. And the traditional treatments really were medical and surgical with nothing really much in between. And the medical therapy would be alpha blockers like Flomax, 5-alpha reductase inhibitors like finasteride. And the IPSS improvement, as shown on this graph on the right, which is from a very large urology trial, is only in the 3 to 5 point range. And if you're talking on a 35-point scale, that's really going to be not very much difference. So it's great for mild symptoms, but for moderate to severe symptoms, a lot of these patients need something more. And what the urologist often will recommend to them is surgical therapy like TURP or open prostatectomy. And how they choose that is based mostly on prostate size. TURP is kind of the gold standard procedure for prostates up to 80 to 100 cc's, open prostatectomy for larger prostates. And these are very effective. I never argue with patients about effectiveness of these treatments. They work very well and they're very durable. And they cause an IPSS improvement on that 35-point scale of anywhere from 10 to 18. The downside, though, are these risks, this urinary incontinence risk, erectile dysfunction risk. Very frequent, over 50% of patients will get retrograde ejaculation and urethral strictures. And so what you end up with is kind of a medical therapy that works well for mild symptoms, and then surgical therapy, which is very effective, but can really lead to a lot of adverse outcomes. And so what happens is the millions of men choose to avoid treatment altogether, at least beyond medical therapy. And so that's where I think prostatic artery embolization really fits in. And the idea follows from many other embolization procedures. The prostate is hypervascular. It has a blood supply that we can identify and get into. We can super select the prostatic arteries and embolize them, usually with small beads that can lead to partial ischemic necrosis of the gland. You never completely infarct the prostate. It's got too rich a collateral network. So the goal is really just to shrink it. And that's what happens after an embolization. You can see on the right, these areas of devascularization leading to shrinkage of the prostate. And just like any other organ, you can achieve pretty good shrinkage of the prostate, usually between 20 and 50% after an embolization. So this is what a procedure actually looks like. We've come into the femoral artery here, but you can also do it from radial artery access quite easily. I come in to the contralateral side, and this is what an internal iliac angiogram looks like. And it basically separates out the branches of the pelvis when you go into this ipsilateral oblique projection. The origin of the prostatic artery is really variable. Here it is here in this case. It's a very small artery, usually between 1 and 2 millimeters in size, and it can come off from 4 or 5 different places, and sometimes there are multiple on each side. Once we identify the prostatic artery, we'll go ahead and access that with our microcatheter. Usually it's a very small microcatheter like 2 French. Get out into the prostatic artery, and you can see this really dense blush of the prostate. That's what you want to see. Once you get to there, you could either go to an AP view and confirm the position. That's what we've done here. You can see it's really filling out the hemiprostate very well here. We see no supply to the bladder, the rectum, the penis, or anything else. And then we can go ahead and proceed with embolization. I often nowadays will use a cone beam CT here just to confirm that I've got complete coverage of the hemiprostate. And then we embolize, and that's usually with small particles. Anywhere from 100 to 500 micron are the most common sizes that are used, and may or may not follow with a coil embolization. Then we recheck, make sure there's no accessory supply on that side, and go ahead to the other side to complete the treatment. Usually takes a couple hours. Just so you can impress your attendings on your rotations, here's a look at an ipsilateral iliac angiogram in a 45-degree ipsilateral projection. That's usually the best way to locate the prostatic arteries. And there's a little shortcut you can use to find the most likely supplies to the prostate. And that's if you locate the obturator. The obturator here is marked in blue. It always looks like this, has this kind of distal forked appearance, crosses across diagonally across the pelvis. The prostatic artery in this 45-degree ipsilateral oblique projection will almost always cross over the main trunk of that obturator in over 90% of cases. So it's a nice shortcut to kind of locate where your prostatic artery supply is. In this case, there was actually 2 prostatic supplies. They both were kind of following this rule, crossing over the main trunk of the obturator, and we would super select each of these to check their, make sure that they're passing on to the prostate. So a useful little tool, we call it the CROB sign or crossing obturator sign, to locate the prostatic artery in that 45-degree ipsilateral oblique. So what are the advantages of PAE for BPH? Well, we're not limited by prostate size. In fact, the bigger the better. So there's a lot of crossover when you're under 100 cc's with other minimally invasive urologic treatments like Rezum and Urolift, et cetera. But as prostates get bigger, over 100 cc's, patients are really limited to things like HOLEP and open prostatectomy. And so PAE really adds to the armamentarium there. It's outpatient. We don't have to admit patients to the hospital. I never do. They always go home the same day. It's done under conscious sedation and sometimes even under local. It's essentially painless. A lot of my patients want to watch the procedure and talk to me, so they're basically completely awake. Recovery is rapid, couple hours in the post-procedure area before they go home. And usually a few days worth of side effects or symptoms that then fade away pretty quickly. The morbidity is probably the biggest advantage. It's very low. There's no impotence, no incontinence. I never place a Foley catheter unless it's truly necessary for a patient that's obstructed, for example. Ejaculation is usually preserved and the blood loss is minimal. And we've had an on-label indication with the FDA since 2017. Still has been a bit of a battle with insurance companies, and actually some of us, probably including Dr. Bagla as well as myself, be meeting with the AUA and trying to get a joint consensus statement. They've been a little resistant to putting this in their guidelines, so it's still a bit of a challenge sometimes getting insurance approval, but progress is being made. If you're starting out a PAE practice, these are the main candidates to look for. Patients who are poor surgical candidates, maybe because they're old or have multiple comorbidities, maybe they just absolutely refuse surgery. Patients with a very large prostate, over 100 cc's, those are really terrific for PAE. Patients with a Foley catheter because they're completely obstructed, we can often free them of that in over 80% of cases, so that's another one. And then patients with refractory hematuria, we can shrink their prostate while also stopping the bleeding in about 90% of cases. So just a very quick review of what's new over the last year. There's just 3 or 4 studies I wanted to quickly highlight. The first is the latest randomized controlled trial. This came out of Spain and basically took 45 patients and compared half of them with PAE and half of them with TURP. These, of course, had to be patients with kind of relatively smaller prostates so that they could qualify for either a PAE or a TURP. So in some ways, this is sort of working against PAE, which in my opinion works better the bigger the prostate is. But essentially, even despite that, this study showed no difference in outcomes. The IPSS score improved to a similar degree between the two groups. And quality of life was similar as well. And the real difference was on the morbidity side. So here's a look at the complications that were encountered from those two procedures. And if you look all the way over to the right, you can see a total of 47 adverse events in the TURP group, only 15 in the PAE group, most of those being mild. So really 3 times the rate of complications when you take the patient to surgery. And this really underscores the minimal invasiveness of the PAE. The latest systematic review and meta-analysis has now kind of extended the outcomes to 2 years, showing that PAE is non-inferior to TURP in regard to improving patient symptoms. It is true that functional parameters like peak flow and post-void residual tend to improve more after a TURP than after PAE. So I always counsel my patients that that's the case. But as far as symptomatology, PAE is very comparative to TURP, and you get very good results. Also, those results seem to extend to at least 24 months based on this meta-analysis. We're starting to get some long-term data. This is out of the Brazilian group, one of the first groups to do PAE, and actually who I trained with when I first started about 9 years ago doing these. Dr. Carnevale down in Sao Paulo, he outlined his 10 years experience with treating BPH to look at what is the durability of this procedure. And just pay attention to the orange line here. You can see that over the years, you can see the months on the bottom there. Over the years, you start to have recurrences as that orange line drops, but it really only crosses the 50% mark, meaning half of patients have had recurrence by around 6 years. So I use this with my patients. I find it useful to counsel them that, PAE is a terrific treatment, but it may not be quite as durable as TURP or prostatectomy. We expect that half of men will start to have recurrence around 5 or 6 years. And so that helps them make their decision. Now, fortunately, you can repeat a PAE in case the PAE doesn't work well enough or recurs in the future. And that's where this next study comes in. This study out of Portugal, which is the other main group that started doing PAE long ago, and Dr. Bilham's group, basically looked at how patients recurred. And you basically separated patients into relapsers and non-responders. So patients who initially improved and then had relapse of symptoms, they actually do quite well after a repeat PAE. Over half of patients get significant improvement that lasts for 2 or 3 years. However, if the patient did not respond to the initial PAE, there's probably no reason to go back in and try it again, because only about 20% of those patients ended up having a response to the repeat PAE. So look at patients who have relapsed after an initial good result, and those are the ones you might want to repeat PAE on several years down the line. I want to close with a example case. I have lots of examples, but this is just one kind of important one to show just how much we can help these patients' quality of life. This guy was 74. He's actually a CEO down in Orange County. He had a very big prostate. You can see it's about 7 centimeters across. You can see he's got Foley catheter in place because he cannot urinate at all. I do CTA in almost every case to outline the configuration and size of the prostate, get a look at the bladder, and also find the arterial anatomy of the prostatic arteries, which, as I mentioned, is quite variable. He had episodic urinary retention, had multiple UTIs. That's required a Foley. His prostate volume was quite big, so fitting right into that category that I really like to treat. 150 cc's. He has a large median lobe bulging into the bladder. That's no problem for PAE, as several studies have shown. He'd already failed medical therapy, and his urologist had offered him a prostatectomy, too big for TURP. He was not happy with that idea, concerned about side effects, and was referred to me for PAE. And this one I did almost 5 years ago now. This is a couple representative images from the procedure, very big prostate. You can see the bilateral prostatic angiograms there. We did the PAE successfully using microspheres, had no side effects. 2 weeks later, his Foley catheter was out. It usually takes 2 to 6 weeks to get liberation of the Foley catheter. He was out in just 2 weeks. At 6 months, his prostate had shrunk significantly down to about 100 cc's, so about a 33% volume reduction. His median lobe had shrunk as well. And his IPSS was like he was 30 years old again. The guy was thrilled. He was peeing great. His bother score is 0. I've been following him every year since then, and we've just had our 4-year follow-up. His IPSS remains almost 0, so he is absolutely delighted and has been able to avoid surgery and urinates just like he was a younger man. So a really terrific result, and a good proportion of patients fall into this category where they just have a fantastic result for many years. But I do caution patients that this isn't every patient. There's quite a few patients where you get significant improvement, but maybe not, complete improvement like this. So, and then there's about 20% where we just don't get much response. We cannot get the prostate to shrink enough, or they might have a bladder contraction problem that causes them not to improve as much as we hope after PAE. But suffice it to say, most patients do very well. So in closing, it's a very effective and safe therapy. We've had multiple studies. I only showed a couple, but we've got thousands of patients now in a variety of settings that have shown that PAE works well and is very safe. And the way I see it, it really fills this gap between medical and surgical therapy. So patients who haven't done well with medicines or still have resistant symptoms, but really don't want to opt for surgery or maybe aren't a good surgical candidate, PAE is a perfect compromise between those two. And it can also be a very definitive option in patients who are not good surgical candidates, or their prostates are very big, or they're having blood in the urine. And the interest is certainly increasing in an aging population. At least half of my patients are self-referrals. Urologists are getting more aware of this. And in fact, if you speak to individual urologists, they're often quite agreeable with it. The AUA has been a different matter, but when you speak to individual urologists, they want to help their patients as well. And so we can partner with them and help get the word out. And the way that I did that was with a YouTube video. This I did through UCLA, and did about a 10-minute talk about PAE and some of the basics of it. And this was a couple of years ago, and you can see I've racked up about 116,000 views and have gotten dozens and dozens of referrals from this video. So it's a really nice way to get the word out. But that number, really not that impressive if you compare Jackson Mahomes. This collection of his very cringy TikTok videos already has 260,000 views in just under a couple of months. So, I think we have a lot more room we can improve here on our publicity for what we do. But hopefully, with your all's help, we can make this procedure more of a mainstream procedure and help millions of these men in the US and worldwide. So I'll conclude there, and thank you very much for your attention and for letting me bump in front of our next speaker. I really appreciate that. You guys have a wonderful day.
Thank you, Dr. McWilliams. Fascinating procedure and an excellent review of the crossing operator sign as well. And thank you, Dr. Bagla, for his comments in the chat. It's very fascinating to hear about the advocacy that happens behind the scenes in these procedures. Introduce the next moderator, Sanskrit Kapoor. He's an undergraduate student at the University of Rochester for the Neuro IR section.
Thank you for the introduction, David. So for this neuro intervention, presentation, we're going to have Dr. Dunn presenting, who is an interventional radiologist at PIH Health based in Los Angeles. He received his medical training from Feinberg School of Medicine at Northwestern. We will also be having in the chat Dr. Narson, who was a neuroembodied interventional radiologist currently practicing at the University of California, San Francisco.
Thank you. Thank you. Can all you hear me? I might be still muted. Hold on.
Yes, we can. We can hear you.
Okay, cool. Sorry about that. Well, thanks, guys. Thanks for having me on. I'm Sabine Dond, and thanks for the organizers. This conference has been great so far. It's always been great. So, Navjeet, thanks for being so on top of things, and all the other organizers. I'm always excited to talk to you guys about stroke. It's something that a lot of IRs, and especially trainees, think that if they're not going to go into neuro, that this is not part of their wheelhouse. But believe me, it's very much part of it, and I encourage all of you to get exposed. And so I'm going to hopefully incite some excitement, and I'm going to plow through these slides so we try to keep on time. These are my disclosures. I work around here in LA at 3 hospitals: Whittier, Downey, and recently in downtown. So you can see us do all of this at any of these centers if you want. And this is my team. We are at Lake. We work at PIH Health, and I've got a great team of 8 IRs and an awesome PA. So we hold it down, and we're always expanding. So I really always like to give this seminars in IR. This volume was done by Venous and Martin, and they really went over all kind of a general approach to neuro IR. And you can see the topics here. And I thought these are really great. I love this journal actually, because it really just takes a review approach to many procedures. And so I think it's great for trainees and early career physicians. Now, ischemic strokes we'll talk about. Now, they are the most common. You got ischemic and hemorrhagic. Ischemic is the majority, 80% of the strokes. And we think of it like a heart attack, right? There's cardiac ischemia and infarct. So think about the same thing like that, where the brain has ischemia and then infarct. So you have this reversible time period due to collaterals. And that's what we take advantage of during stroke thrombectomy in order to save or reverse the stroke. So time is brain. Neuro IRs, people doing neuro, they love saying this phrase. You'll hear it 10 times a day. But it is. Time is brain. 2 million brain cells die every minute. There's very few things in medicine where you just run and do stuff that's trauma, STEMI, stroke. These things there's no time to wait. And so stroke is definitely no joke. We're just going crazy fast. And you want to have this type of brain. This is a patient, normal brain. You want to avoid something like this. This should not happen if patients are getting appropriate care. This is not compatible with life. Bilateral, large strokes, midline shift, craniectomy. Of course, this patient didn't make it, but it was not at a time when stroke thrombectomy was prevalent. Now, I've gone over before. I really wanted to update my slides and not do a repeat presentation. So I'm going to actually go and talk about evolution of techniques today. We've talked about stent retrievers, how they've improved, and the design has changed from this initial mechanical thrombectomy device, which is like a little spring that you put up in the brain. It was called Mercy. The guys at UCLA invented this in 2001, which is pretty recent if you think about it in the grand scheme of things. But even though this video acts like it works really well, it never did. It doesn't break the clot like that. It just unraveled. So it wasn't really a big device being used in the early 2000s. Now, stent retrievers improved over the next decade, and these are what they look like now. They look like stents that are wielded to a wire. And with those devices, we select the appropriate patients, and you can see very few images in radiology are colored, and we do get to have perfusion studies which are colored, which is a breath of fresh air in diagnostic. But our imaging standards have vastly improved over the last 2 decades, and we are able to select patients that will benefit from thrombectomy. And in 2015, data run from the world totally validated this procedure and made it the standard of care for anyone presenting with a large vessel occlusion, initially within 6 hours, but then additional data came out to say that within 24 hours, a whole day, you can be having a large stroke and you may benefit. And hot off the press, just this week, it was announced the rescue trial, which we'll go into a little bit, but this is even more. So we're just at the tip of the iceberg. Patient selection we've talked about, that is key. You can see the modern medical team here. Not exactly the case, but it's a funny parody of what medicine sometimes is becoming. But a key team is good to key success. This is one of our articles that we wrote in that seminar journal, and it really talks about the team and the workflow. And you can see how many things are going in parallel in order to get the patient thrombectomized, if that's a verb, and get him to save his brain. So lots of things going on. It's a very well-oiled machine when you start working at a comprehensive stroke center. Now, penumbra, the area that you'll hear that word penumbra and core, and those are the beautiful color images or CT perfusion scans that you will definitely see in radiology, where you can identify patients who have an affected brain, but the time to transit to come to that side of the brain has increased. So the blood flow is delayed, but the volume is maintained because of those collaterals. So it just means that it's decreased time, but it's maintaining the volume through those collaterals. That is the type of brain, that's the type that can be saved. So that's penumbra. Core is if the volume was also dark, as if the flow right here. So that can be tough, but again, I'm going to talk about the rescue trial where core might not even affect your decision to do a thrombectomy. Anatomy is totally different. I was unfamiliar with neuroanatomy when I started actually my job, and there's a lot of challenges. You can see that here's an actual case going from the groin. You fight a lot of vectors. You go up, you go down, you go up again, and you can see we got our a catheter up here. And so basically, you fight a lot of forces to kind of flick you down into the ascending aorta. You can go radial, or you can use a ton of different devices, as you can see here, to really help you get stable access into the brain. And this is what an AP and lateral view look like of a normal anatomy. And I just want you to imprint this in your brain so I can show you some cases. But here's the middle cerebral artery, which is kind of the predominant anterior circulation. Here's the anterior cerebral artery, and middle cerebral artery. Those are the two territories we talk about in large vessel occlusions in the anterior circulation of the brain. Now, if you take that, like I said, imprint this, and now what's missing, right? This is a large vessel occlusion. This is a clot that's preventing blood flow to the left side of the brain in the middle cerebral artery. Now look at all these other vessels coming. Those are the collaterals. That's middle cerebral artery, actually. Those are the branches. But the collaterals are the PO collaterals and other collaterals that are filling it. So that's an actual angiographic depiction of what penumbra looks like. And so techniques, right? What are techniques to get to that clot and get it out? And that's what I wanted to focus on today's lecture on. And I'm going to show you what technique that we use at Lake and PIH. And I don't want to bore you. There's a lot of techniques out there. We have gone, and neuro people, I don't know what it is, but they love their, abbreviations. You got Slumbra, Arch, Trap, Adapt, Save. I mean, it'll keep on going. But there's one awesome abbreviation that I'm going to have to go into. And just to see what it looks like, here's this clot here on the right side of the brain. This is a microcatheter that's being pulled back. You can see the stent retriever being deployed in the brain, and then an intermediate catheter. There's actually another catheter below the skull, but this is your main working system right here. And you can see that's all it is. And I'm going to show you how we use this. In this case here, we use that system and we were able to open up this clot. And this is a matter, these things happen fast. They go fast. Again, like your time is brain, so you're working really fast. This would be from the time to puncture to reperfusion here is a matter of 11, 12 minutes. So it goes really fast and they're really rewarding. This is a stent retriever that took off this clot. This is the same case right there. That little clot was blocking the entire right side of the brain, or at least the middle cerebral artery. So you can see that these little tiny boogers can cause a lot of damage and morbidity and even mortality. And so just to give you a little animation, we deploy that stent retriever. This is the OG technique. And I call it the OG, but it's actually resurfacing as a very popular technique now, where you just take the stent retriever and pull it all the way down all the way into the balloon guide catheter. Here's a balloon guide catheter that's resting below the skull. A lot of people use this technique, the ADAPT technique, where you just take a catheter, no stent retriever, and you literally just suck the clot out, okay? These are the two big techniques, and there's variations of each. But I would say that there are believers who only do ADAPT, and some people who do stent retriever, and some people who do both, myself included as both. Now here's Solumbra. Solumbra, a little fun little technique. So you actually pull the catheter into this intermediate catheter. All right, if you can see what I'm doing here, this is an old case. I don't do this technique anymore, but you pull, there's still a catheter down here. That's a balloon guide catheter. You can see that's bouncing on the bottom of the skull, but you pull the entire stent retriever into the catheter. You can see Solumbra, it's being pulled. The intermediate catheter remains at the area where you left it, okay? The save technique, right? That we finally realized that doing that could shear off the clot. And just imagine you're pulling the clot into the catheter that's smaller. Why don't we kind of cork the clot? So instead of pulling the entire stent retriever into the intermediate catheter, you put it partially and then you pull it back in. So this is something where we're pulling it partially in and we're pulling it all down into the guide catheter. You might think, okay, that seems not very different, but it actually is, because one, you're corking the clot up here, like I showed you, and then we're pulling the whole system down. And it's a small variation, but it makes a dramatic difference. And if you can see in this save technique, they're just using a regular catheter there. But now what if we change it to a balloon catheter? And we do the save technique. You keep the catheter. This is the save, but you do it with the balloon guide catheter, right? I know it sounds very variant, very little changes, but little changes make a big difference. So when you put that all together right here, it's called the badass technique. And I love this because I think it's badass. And that's what we do. So, and all IRADs want to be badass. So it's the balloon guide with blah, blah, blah. We won't go into that. But I thought it was pretty neat. So that's what we do. But again, some people will do the ADAPT technique, or again, just the OG stent retriever and balloon guide. Here is an example of a case where we have the stent retriever, the intermediate catheter, and the balloon guide. Unfortunately, I did not say, I was trying to look for fluoro saves. I know I have them, but I couldn't find one. And the next stroke I do, I'll just save one for the purposes of this talk. But you can imagine this whole thing coming down into here once you grab the clot, and it's very, very effective. So again, badass, it's badass. And it works. I mean, these are various clots that we've taken out of brains at Lake. And, you know, it's time is brain. And some of these cases are very easy. Some of them are very challenging, but it definitely teaches you a lot and things that you can apply to the peripheral space. Now, going more further, and what I wanted to kind of touch on is LVO. People were throwing this word all the time. LVO, large vessel occlusion, large vessel occlusion. And that was the anterior circulation I was talking about. Now we talk about MEVO. Okay, MEVO is a new term, just got denoted like the last year or two, and that's medium vessel occlusion. Okay, I tell you, you gotta love neuro-IRs and their abbreviations, but what the hell does MEVO mean? And what MEVO is we're just going more and more distal. And here's this catheter, it's called the Zoom catheter. This is taking the market by storm, kind of like how Inari is for pulmonary thrombectomy. This is now taking storm for neuro and stroke. And it has, just imagine if you were smart enough to do this. These guys are annoying because it's so easy concept, but they made a beveled tip. They just changed the tip of the catheter. Instead of being straight, they changed it to beveled. And now it's 15% greater surface area to grab a clot. It's the most simplest idea, but now you have a larger surface area. And then they made smaller ones. So they made a 71, they made these smaller catheters with a bevel tip, and now you're able to have a larger surface area to grab clot, and you can go more distal into the brain. So here's a case, 71-year-old guy with left arm and leg weakness. Here's the perfusion defect. It's small. The other ones I've shown you are all big, right? This is small, and the brain looks like this. A lot of white matter changes, but the gray white is intact. So he's having a lot of weakness, is pretty strong weakness, can't even raise against gravity. So how could such a small stroke cause those big symptoms? Think about the motor strip. This is going back into anatomy. And your motor strip and your sensory cortex is right there. So even your distal emboli can be very life-changing. And this is what this guy's angio looked like. And I'll be honest, it took me about a year or two in doing thrombectomy to actually recognize where the clot is here. And this one's a little bit obvious, but you might not be seeing where the clot is. So believe me or not, that's the clot, okay? And that's in the distal M2, proximal M3. And now I'll show you with the video, and I think you'll believe me, where you'll see the clot now. So it actually took a while to, I would miss that in the beginning of my career, but that now we want to be able to do these techniques out there. And you can see there's the beveled tip, right? Right there, we take the beveled tip to the clot. This is far into your brain. This is to the level of your ear. Look how far that is, right? I'm able to take this catheter all the way, that bevel tip, to the clot, and believe it or not, it works great. This was just an ADAPT over there, and I was able to suck out the clot. There was a little bit of spasm, which will resolve, and this was his diffusion or his MRI after. The motor strip completely intact. That's your gray cortex you need to keep. A little bit of white matter infarcts, no big deal. This guy did absolutely great. And like I said, tip of the iceberg, right? now we're doing Nevo clots. What about patients who are presenting really late after one day? What if their brain shows a lot of changes? This is the Tesla trial. We're actually enrolled in it at PIH, and we are enrolling patients who already have advanced stroke changes, and to see if we do a stroke, is it going to help? It's not the Tesla car. Select 2 is very similar, and endo low is another very interesting to see if a patient comes with a clot, but their stroke isn't that bad. Do they benefit from stroke thrombectomy? I mentioned that this just came out literally this week. It was the International Stroke Conference last week, and in Japan, they basically did a small version of the Tesla trial, and they showed that it was actually a dramatic improvement. So now we're going to open up this door to people who already have large strokes, acute strokes, that have edematous changes to even do this procedure. And this actually just got published. It was our paper in JVR. It's still in press, but I won't spoil the surprise, but we compared IRs to neuro-IRs. We took 1,009 cases, and this was really fun. So I won't spoil the surprise, but I'll show all the data at Wings in a couple of weeks. But we just got that. So there's a lot going on. And again, tip of the iceberg. I'm really excited. I think stroke, I love it. And I really, really want to promote my passion and instill it into others to be able to do. It is something that is a great benefit to our patients. If you want to learn more about it, I'm obviously in my back table gear. We have tons of back table podcasts. We have another like 10 on the line. So keep a lookout, and please don't feel free to contact me, email, Twitter, whatever you want. So thanks, guys. That's what I had on stroke.
Thank you, Dr. Dunn, for the amazing presentation. The next panelist for the next session is going to be Vishal Jindal, who is a third-year medical student at Touro University in California.
Thank you for the introduction, and I have the pleasure to introduce Dr. Desai, who will present about interventional radiology's role in critical care. He has a unique insight on this topic, as he's the first fellow with an IR background to train in Brigham Women's Hospital Anesthesiology and Critical Care Medicine Fellowship Program. And prior to this fellowship, he completed his diagnostic training at Brigham Women's Hospital and did his interventional training at the University of Virginia.
Hi, everyone. Give me 1 second. I'm just going to share my screen here. All right. Can we all see that?
Yep.
Perfect. All right. So let me go back here. All right. So thank you all for inviting me to speak. My name is Kanant Desai, and I completed my IR training at UVA. And I'm currently a surgical critical care fellow at Brigham Women's Hospital. I'm excited to speak to you on the role of critical care in IR training. So I'm halfway through a one-year critical care medicine fellowship with the Department of Anesthesia after completing an independent IR residency. To my knowledge, I'm the only IR to have completed a SICU fellowship as part of their initial training. And this is the #1 question I get from everyone these days: radiologists, intensivists, nurses, my parents. So in this talk, I want to share why I think critical care training is crucial to the growth of IR as a specialty, and also give some examples through personal experience of how kind of acquiring these acute patient care skills can make you a better IR. So a little bit of background. In the beginning, there was this man, Charles Goiter. There's a picture of him in 1960. He's the father of IR and inventor of angioplasty. He has this very famous quote: if my fellow angiographers prove unwilling or unable to accept or secure for their patients the clinical responsibilities attendant on transluminal angioplasty, they will become high-priced plumbers, facing forfeiture of territorial rights based solely on imaging equipment others can obtain and skill still others can learn. So, there's always been a desire to become a clinical specialty. And of course, we all know kind of the background of how IR has evolved and a lot of times lost procedures. So in 2014, there was a redefinition of IR/DR training, with the major driver of this change, as Dr. Kaufman says, being the importance of non-procedural patient care and the necessity for additional training in such. So let's talk about patient care in IR, why it matters and how it can be optimized. So what is non-procedural patient care? Well, to me, it comprises these two things. There's the longitudinal management of patients using disease-specific expertise, and then there's acute management of patients in the hospital in the peri-procedural period. As you've heard so far today from some of these amazing speakers, IR is doing a fantastic job of establishing themselves as disease experts on par with hepatologists for portal hypertension, or vascular surgeons for PAD, or surgical oncologists for HCC. But how are we doing on this part? The reality is IR takes care of the sickest patients in the hospital. These are all real scenarios that I've encountered. Ask yourself, would you know what to do if the following occur? Acute severe hypertension that can't be treated with labetalol and hydralazine. Someone with cardiac arrest in the pre-procedure bay before hemodialysis circuit declot. All of these have happened to me. If your answer to these questions is that the primary team will evaluate and manage the problem, or you're going to wait for the code team to arrive, you've missed the boat. An IR with a focused mastery of critical care knowledge can improve outcomes in each of these scenarios. So why emphasize acute non-procedural care? Well, if you assume comprehensive responsibility of the sickest patients, you're going to deliver faster care with improved outcomes. This is going to generate greater trust and increased referrals, and that's going to lead to the growth of your practice and of IR as a specialty. What do we need to learn? I kind of think of acute non-procedural care in these three buckets. There's inpatient admission and management, there's inpatient consultation, and there's management of peri-procedural emergencies. And how do we learn it? To me, there's three major educational opportunities for learning acute care. So there's inpatient consult and admitting service, there's critical care training, and then there's didactic education. So I'm going to pause and kind of go into my story a little bit. The road to critical care fellowship. So, I've always wanted to be my patient's doctor, and I sense that a lot of you share the same desire. I don't want to just be their proceduralist. So on my required SICU rotation during the ESIR year, I approached the program director of the SICU, who was an anesthesiologist, with my vision for mutual benefit to both specialties. He loved this idea, and I matched. And so I completed my independent IR residency at UVA, and I came back to Brigham for a one-year anesthesia critical care medicine fellowship. I made sure to have dedicated IR elective time during this year. There was some resistance, of course, and some misconceptions with my plan as well. How will you keep up your IR skills? I think that's a great question, and that's why I wanted to have dedicated IR time this year. What makes you think you can work in the ICU after 1 year of clinical training? Do you even know how to manage inpatient diabetes? Literally, a nephrology fellow told me this as soon as I met them. And that is why it's crucial for everyone to work hard during their training to do the reading and to keep up with clinical care of patients. My personal favorite, do you hate making money? I don't have an answer for that. It is 1 extra year of training. It's really useful to have a radiologist on rounds to interpret images. On surface, this is a great notion, but the important thing is you don't want to get pigeonholed when you're doing your critical care training into being the radiologist on service. As Dr. Vatican-Cherry says, you're there to learn critical care. You're not there to just be the radiologist on service. And a lot of IRs feel and have told me kind of you're pigeonholing yourself into an IR niche of trauma, bedside drainage, GI bleed. That's not what I see this as. I see this as augmenting my skills as an interventional radiologist to become a better doctor overall. These are just some of the things I've picked up over the course of the year and I'm still learning. Physiology is number one. It's something that we don't get in our traditional radiology training. And of course is the core of critical care training. Things like bedside focused cardiac echo to assess for hypotension, bronchoscopy to treat hemoptysis. We treat it from inside the vessels, but imagine if you also knew how to treat it from within the airway itself. ECMO is a very interesting opportunity. It's kind of one of my passions this year. We can do these procedures. We can cannulate someone from ECMO. That's our bread and butter. Imagine if we also knew the physiology that goes along with it. It opens up a whole world of possibilities in IR. So I'm going to go into kind of an imaginary case here, but it's something that is kind of a conglomeration of things I've seen over my IR training and critical care training. So this is a 55-year-old female executive, history of smoking, COPD, OSA on CPAP, hypertension, coronary artery disease, and heart failure, who developed severe right lower extremity pain and swelling after a flight from London to Boston. And of course, you see this on exam, and they get an ultrasound that shows a DVT. So in the ED, they start a heparin drip, and IR is consulted for consideration of endovascular management of DVT. So you go and see the patient, and as you're talking to her, she starts telling you about some new onset chest pain and shortness of breath. And as you're speaking to her, her vitals pop up on the screen, and they show a systolic blood pressure of 92, tachycardia, tachypnea, and an oxygen sat of 87%. She does appear euvolemic on a lung exam. So there's some immediate physiology here for you to address. Despite her history of COPD, she's citing less than 88%, and she's got dyspnea. So she actually has hypoxemia. And given her history of hypertension, a systolic of 90 represents probably significant hypotension here. So you recommend O2 via nasal cannula at 4 liters. You want an O2 goal of greater than 88%, and you recommend getting a chest x-ray. Given her history of coronary artery disease, you're concerned for an MI, and you ask for a 12-lead EKG and serum troponin and BNP. On the positive front, she took her home aspirin, and she's already on a heparin drip for DVT. And then lastly, you recommend an A-line for monitoring her blood pressure and for access for future ABGs should you need them. So you get this EKG, and again, this is something you don't typically look at when you're on IR training, but absolutely something you should know at least the basics of. The EKG comes back without any sort of ST elevation or depression, a normal or a regular rhythm, and tachycardia. The troponin comes back at 80, and so it's elevated. The BNP comes back at 350, which is kind of in the intermediate range. So you, at this point, have diagnosed her with an NSTEMI. Now, is this a type 1 or a type 2? Hard to say. Your next step then should immediately be a bedside-focused ultrasound of the heart. Now, we're radiologists, right? But for whatever reason, we've given up echocardiography. And while we don't have to be echocardiographers and do a 45-minute exam, I think every one of us should know the basics of focused cardiac ultrasound. And so this is an example. This is a peristernal short axis view of the heart, and this is a apical 4-chamber view. And what we're seeing is the left ventricle here, the right ventricle here, and here we're seeing RV, RA, LV, and LA. And so important things that we're noting immediately. There's no pericardial effusion. There's no gross regional wall motion abnormalities. The LV is normal in size and function. But the RV, which should not be bigger than the LV here, is large. It's moderately dilated. And you do what's called a TAPSE. So you measure tricuspid annular plane systolic excursion just to see what the RV function is. And you find out that it's 16 millimeters, which is below the normal of 17 millimeters. So she's got a dilated and hypokinetic RV. She's an RV failure. You also look at her IVC real quick and you see that it's plump and there's no respiratory variation. And so she's certainly not fluid underfilled. You get this chest x-ray and honestly, it looks pretty normal. So at this point, this patient has a type 2 NSTEMI. She's got shock with RV failure and dilation, and she's got hypoxemia. Why? So now you go through your differential of shock. She could have a type 1 NSTEMI from coronary ischemia. She does have a history of CAD, certainly. She could have acute flash pulmonary edema, but this is less likely from a normal chest x-ray and a euvolemic physical exam. She could have septic, cardiogenic, or hypovolemic shock. These are all less likely, though, because she has no history of infection, no STEMI on EKG, an unchanged ejection fraction in her left heart, and a plump IVC, which tells you that she's not fluid underfilled. A PE can cause obstructive shock, and it can give you this constellation with hypoxemia. And so this absolutely has to be ruled out. So how will you treat the initial hypotension? Well, typically you give IV fluids, right? But you just did an echo and showed that she has RV overload. And so you, in your mind, have to be very judicious about the amount of fluid that you give her. So you go to your ED colleague and you tell them all of this and you recommend a CTPA. You think she has a PE. But the patient develops oxygen sat now, again, less than 90 while she's on nasal cannula, and she reports worsening dyspnea. The nurse tells you she's too unstable for the CT scanner. You also draw off an ABG and it shows a pH of 739, a PCO2 of 52, and a PaO2 of 74. You have to know what type of respiratory failure is this. Now, initially, you might think that the PCO2 of 52, which is elevated, might make this hypercarbic respiratory failure, maybe from hypoventilation. Maybe she's just not breathing as fast as she needs to. But then you look at the pH and you notice that it's normal. And so that tells you that this is actually probably compensated COPD. She's a compensated retainer. So she does have a low PaO2, and you can surmise that this is hypoxemic respiratory failure, which again can happen from a really significant pulmonary embolism. Now you need to start considering higher levels of respiratory support. So you can think of a non-rebreather that can give you 6 to 15 liters of flow. You can think of high flow nasal cannula at 10 to 40 liters of flow. But also you got to start thinking of things like BiPAP or even intubation. I, at times, have made the call to intubate someone on my initial consultation in the ED as an interventional radiology fellow. Well, now her systolic remains in the 80s. She's got MAP somewhere between the 55 to 65 range. It's time to think about a pressor as your concern for a massive pulmonary embolism increases. And so which pressor are you going to start her on? Well, you know, Levofed might be your initial go-to, and it's not a bad choice, but you have to remember that it does have alpha activity. And so that will raise your pulmonary vascular resistance as well. And in someone with a PE, that might not be the best option. And so then you got to think about things like epinephrine, which is actually a great choice. It's got beta activity, which will help her right heart failure, but it will also decrease your pulmonary vascular resistance and help out with that right heart failure. Vasopressin also has a similar effect. And so maybe you start her on some epi instead of levo. So she stabilizes and finally makes it to the CT scanner, and you get this. This is something we've all probably seen. It's a saddle pulmonary embolism. And so you've made the diagnosis of a massive PE. So then you run to your MD Calc and you calculate the PE severity index, the PESI score. You plug all these numbers in and you get a score of 145, which tells you that she's class 5, she's very high risk, meaning she has 10 to 25% 30-day mortality. Then you put it all together. So you go to your ED colleague, maybe your vascular medicine colleague who showed up at this point, and you tell them, you know, this is a patient presenting with a DVT. She subsequently developed saddle PE causing type 2 NSTEMI, hypoxemic respiratory failure, and obstructive shock with RV overload and failure. This is a massive pulmonary embolism with RV failure and hemodynamic instability, and she's got a PESI score of 145. What should we do, doc? So I want to make the point here, and this is the point of this whole case. If you are a master of physiology and acute care as an interventionalist, you will become the person that everyone will look to for that last most important question: what should we do? You can intelligently give an opinion now on, should we give IV TPA? Should we do catheter-directed thrombolysis or thrombectomy? Should we think about intubating this patient? And should we even think about doing VA ECMO to support her right heart and her respiratory failure as we do some sort of intervention to clear this clot? So let's talk about some future directions in the time I have remaining. As a new specialty, there's a huge potential for expansion in each of these three educational opportunities. The easiest one is inpatient consult and admitting service. We all have limited or different amounts of resources as IRs, but this is something you can institute from day one. Ask for inpatient admitting privileges and write consult notes on your patients. Critical care training and didactic education I'm going to talk about. So this is the ABR VIR study guide for the certifying exam. There's 3 pages. This is page 1, this is page 2, and this is page 3, and we're talking about hospital inpatient care, inpatient consults, and principles of life support. I think there's a huge opportunity to expand things like an in-training exam, core examination, and expand what's required knowledge for us in terms of inpatient care. Just for comparison, this is actually the surgery ABSITE exam, and you can see that 24% of their exam is medical knowledge, things like fluids, electrolytes, and acid base, transfusion, and disorders of coagulation. And I'm going to throw in a plug here for the SIR Critical Care Introductory course. I know Dr. V is very involved in this. This is a great primer on, if you're interested in learning this stuff, where you can go to kind of pick up the basics of it. If you're interested in doing dedicated critical care training, this is something I'm very passionate about. I want to turn critical care into a subspecialty of interventional radiology. Now, there's a precedent for this. Pain medicine is exactly this. You can do a pain medicine fellowship and take the board examination through the ABA and get certified through the ABR in pain medicine. Again, if you're interested in this, I think we can get this done, and I think it would be a great thing for the field to have critical care be a subspecialty of IR. So back in 2014, we had this goal of becoming a clinical specialty. We've had that ever since 1960 with Dr. Daughter. And now the training is evolving to match it. We want not only diagnostic imaging expertise and procedural expertise, but now we must have patient care expertise. And I'm really excited that, everyone here is dedicated to that principle, and really looking forward to the future of this. So this is my references. These are some pictures actually literally from last night. I'm on a med flight elective, and we transported a stroke thrombectomy patient into the city of Boston. So these are just pictures from our transport. This is a picture of my former co-resident and now wife, lovely wife, and she recommended that I get a Twitter for this presentation. So please feel free to reach out to me with any questions, concerns, and thoughts about future directions. Feel free to text, email, or find me on Twitter. Thank you all for your attention.
Thank you, Dr. Desai, for that wonderful presentation. I want to introduce Terry Zhu, who's a fourth-year medical student at USC.
Hi, thank you. It's my pleasure to introduce our next speaker, Dr. Paul Rachan, who will be speaking on healthcare disparities in IR. Dr. Rachan is an associate professor of radiology at the University of Colorado School of Medicine, where he serves as a program director for independent and integrated VIR programs. In addition, he's the director of non-invasive vascular imaging and co-director of the HHT Center of Excellence. He completed his residency at University Hospital's Case Medical Center and Louisiana State University, and his VIR fellowship at Miami Vascular. His clinical interests are pulmonary interventions for HHT, PAD, venous and arterial interventions, and oncology. He's also active in research and a champion for diversity and inclusion in our field. Dr. Rachan, if you're ready.
Thank you very much, Terry. Can you see my slide presentation that's not on the presenter's view?
It is on the presenter's view, but we can see it.
Okay, I'll switch that over then. My apologies. Is this better?
Yes, that's perfect.
Okay, thank you. And let me go ahead and show my face as well. Here we go. Thank you so much. Wonderful meeting, everyone. Happy to see some friends, colleagues, as well as future colleagues in the medical student arena. I'm going to be talking about the impact of unconscious bias on healthcare, specifically IR, as well as how unconscious bias does play into the role of our healthcare disparities that we see across the board. And in the spirit of this month, Dr. Martin Luther King said it eloquently: of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And this is something that we can definitely all play a role in as we move forward. My disclosures are I do have unconscious bias, and I will try to get right each and every time. I learn something every single time I read something about some type of health disparity, some type of injustice, some type of thing that we can actually make a difference and change as we move forward. So some things I wanted to talk about are just a glossary of terms: microaggression, intent versus impact, stereotypes, cultural humility, and as well as social determinants of health, which are really dependent upon our health disparities. In terms of a microaggression, these are things that are brief and daily. They can be verbal or behavioral, disgrace, indignity. Now, they can be intentional or unintentional, and that's the thing that leads to the impact of that microaggression. It can be hostile, derogatory, or negative. Prejudicial slights or insults can also be included. And this can be any group that we encounter, any group in healthcare, our patients, our colleagues, you name it. So cultural humility is the behavior and attitudes and beliefs that guide us physicians to work effectively in cross-cultural situations. And the social determinants of health are conditions and circumstances in which people are born, live, and learn, as well as the systems that are put in place to address illnesses. Said conditions are usually molded by a wider set of forces, such as socioeconomic, policies, and politics. Now, unconscious bias is any negative or positive belief of the character, nature, or ability of another individual or group to which an individual belongs. And the thing is, we all have it, and we all can do a better job each and every day to dispel it. But it requires a conscious process and effort. Implicit bias, this is a type of training that all of us go through each and every year. And I would say we should stop looking at it as training, because this is a continuum. This is like continued education in this non-interpretive skill. And then it's an attitude or stereotype that affects our understanding, actions, and decisions in an unconscious manner. And these attitudes can result in unfavorable and favorable assessments. Now, stereotypes are activated in situations when an individual is stressed. And now this is every single one of us on this call right now. Stress will not leave us at all, because we're constantly multitasking and under time pressure. And it was noted that about 22% of radiologists admitted to having biases towards specific types of groups of patients that impacted their clinical decision-making. Now, that's a high amount whenever we are trying to do the best that we can in terms of our clinical care for our patients. Now, conscious bias in healthcare, we all know that there are a lot of things that leads to distrust that our patients have for healthcare. There was the Tuskegee clinical study and the Henrietta Lacks incident that really leads to distrust in medicine. And this is something that we need to do a better job with leading our patients to the best care possible. Now, things that we can do to measure bias is an implicit association test, where we can actually take this and look at something and decide, well, what do our unconscious methods point to? And we can tell a lot about ourselves, the things that we don't even know about. Now, implicit bias in healthcare professionals, there's a systematic review, 42 manuscripts between 2003 and 2013, and showed that healthcare professionals have some degree of implicit bias as the rest of the population. Not unheard of. Now, biases perpetuate disparities, and these are things that we wanted to talk a little bit about today in IR. Well, how do we mitigate this bias so that we can try to mitigate the disparities? We need to look at organizational changes, leadership, meaningful diversity training, continuing education, self-reflection on personal biases, questions and actively countering those stereotypes. We need mentorship and more so sponsorship, cultural humility and curiosity, and intentionally diversifying our experiences across the board. Now let's get into health disparities. It's interpreted in a variety of ways by different groups and individuals. And all in all, it's inequalities of several global health and health-related issues based on multiple factors that we can include. Geography is a big thing in terms of zip codes, socioeconomic status, race, ethnicity, age, and sex. So let's move a little bit to the world female population. We're all trying to move towards more diversity in healthcare, more diversity in IR, women in IR. Our world female population has definitely increased over the last several years. Now, the leading causes of death in females in 2015, heart disease, cancer, chronic lower respiratory diseases. Now, these things are really prevalent in our female population. And when you look at all between whites and blacks, heart disease, cancer, and stroke or COPD lead the top three. But when we look at other populations, Hispanic, Alaskan Native, Asian Pacific Islander, cancer is actually the top, and then heart disease is second. So how do we actually address these disparities in women? There are a lot of interventions, and one thing I want to say, and this is a great meeting that we need to continue to discuss these. We as interventional radiologists treat every single disease known. Neurointerventions, interventional oncology, peripheral vascular disease, women's health, you name it. So we have an impact to actually change and make a huge impact to decrease these health disparities. The cancer-related health disparities in women, HCC altogether. Now breast, colorectal, and lung cancers are the top ones in women. So those are things that we can definitely decrease as we move along. This was a past Endovascular Today Women's Health issue stating the different types of conditions affecting female patients. Dr. Creedy eloquently talked about women's health interventions that all of us need to be aware of. Sex differences in abdominal aortic aneurysms, that peripheral vascular disease that we continue to treat, underrepresentation of women and ethnic minorities across randomized controlled trials. Those are things that we need to do a better job with in terms of these trials that we're trying to make a difference with. Now, UAE and uterine fibroids, that elephant in the room. I mean, we know that women are 2 to 3 times more likely to get a hysterectomy than uterine fibroid embolization. Now, that's due to the awareness, and it takes those YouTube videos that Dr. McWilliams put out for PAE, all those things so that women can be aware that this is another option for them. The burden of uterine fibroids for African-American women, a lot of things. And altogether, African-American women have more severe symptoms, unique concerns, and different information-seeking behavior for fibroids. But we've seen over the last several years that women are actually being more proactive in getting those self-referrals to learn more about UAEs. And it's because of the initiatives from our interventional radiology field. Pelvic venous disease, or the old term pelvic congestion syndrome, where women were perceived as being just crazy. Well, this is an entity where we need to fight harder for approval, effective embolization, pelvic venous disease altogether. Now, when we look at the disparities in IR, there's so many, but I wanted to highlight a few on this slide, talking about, let's say, peripheral artery disease. Well, all in all, Black patients have higher amputation risks than white patients altogether. So we need to do a better job with that in terms of prevention across the board. In terms of portal interventions, access care for TIPS. Black patients are less likely to get first-line endoscopy and second-line TIPS treatments. And also, Black patients who do undergo TIPS for decompensated liver disease have a 2-fold higher increase in mortality. Hepatocellular carcinoma, HCC, IO is a huge part of interventional radiology. However, we think about it as surveillance. Also, now Black patients have decreased surveillance and because of low income, or not because of, and also those patients who have low income and socioeconomic instances. Dialysis patients altogether also have more grafts are actually have been shown to be placed in our in Black patients due to increase. Well, and we know that those actually have increase in infections compared to AV fistulas. Also, there's decreased amount of underrepresented minorities who are undergoing transplants as well. IVC filters have been shown to be overused in Black populations as well, particularly in the bariatric population. In RCC, an increased incidence in Native Americans and Blacks compared to whites, and also access to those treatments that would decrease, and also their surveillance. So these are just a few documented disparities, and I urge everyone on this call to really push the issue and looking at, well, what disparities do we have in this disease process that I treat in interventional radiology? Now, moving back to women IR, bridging the gap in society, what we need to do is just become a more diversified society across in healthcare as well, more women and more underrepresented minorities. This paper showed that increasing numbers and awareness of medicine, about 10% of active IRs were women at this particular time. Now, at this time, our integrated match has definitely increased the amount of females in interventional radiology. And this will be a significant to decrease those disparities in all service lines. Now, this was hot off the press at the time. Fewer than 10% of practicing IRs were women in this clinical practice patterns paper. Females had a high proportion of evaluation and management of clinical visits compared to males. And longitudinal care is best for better patient care. And as we have shown across the board in our training and as we're trying to improve that. Now, one thing we need to look at also is pipeline and trying to get URMs in radiology and interventional radiology. I'm just going to move through these slides for the sake of time. These are just URMs and US residency programs all together, and it shows that pipeline programs have been developed for fields such as orthopedic surgery, and more so for interventional radiology, as we all know, the GEMS program, and also radiology and the PEER program through ACR. URMs and IR, there's a paucity of underrepresented minorities, and over the 7,000 SIR members, less than 1% report. Now, this is volunteer reporting as African American, American Indian, and Hispanic Latinos. We need to do a better job with reporting so that we can know where we stand. An IR, as we know, can benefit from the inclusion of underrepresented minorities in many ways. This goes back to the health disparities and the distrust that we see that some of our patients have. Our patients also want to see someone who looks like them and can trust them a little bit more. Not to say that anyone cannot treat these patients, but it's becoming the awareness of why some of these patients may distrust the healthcare system. I'm just going to skip this slide right here. Just talks about academic medicine and underrepresented minorities. And as we go up the ranks, there's less and less of underrepresented minorities altogether. Now, one thing that has really impacted the health disparities and making us become more aware is why we're on this virtual platform probably today, COVID-19. And about 33% of hospitalized patients early on in the pandemic in 2020 were Black, and that's 18% of the community. And this was in New York. Also looking at disparities across the board among COVID patients was really high. Hispanics, Blacks were ones that were actually found in the ICU more so than white counterparts. This all showed us that reduction of disparities in COVID-19 incidence can be done with efforts from culturally responsive and targeted interventions. This is the same thing that we need to do as IRs in our own diseases that we treat. COVID has actually made us more woke in this situation altogether, and need to invest in social determinants and structural racism that affect health inequalities. COVID-19 health disparities, this was not random. Immigrants and underrepresented groups work for decreased pay and take on essential jobs. Remember when we were quarantined many times in 2020, and many patients had to, many of our citizens lost their jobs. A lot of Blacks and Hispanics, 25%, work in service industry jobs compared to 16% of non-Hispanic whites. And there's no paid sick leave. So those patients needed to actually get to work. Now, the coincidence is an HIV pandemic initially emerged amongst white male homosexuals, and now Black males are disproportionately affected. So what's the difference? We have more data in HIV, and we're beginning to inquire more demographic data for COVID-19. And this goes hand in hand where we need to get more data for all of the IR procedures that we actually treat in disease processes. This is pretty much the crux of everything that we are trying to do to dispel or to get rid of health disparities. But this is the hardest thing that we have as a population, those social determinants of healthcare. Social isolation, which a lot of us have been put through the pandemic. Some patients have no access to virtual technology. We've been moving to more telehealth, but some patients can't be reached that way. Transportation to get to clinics and to appointments and to procedures. Social connections that are a key to happiness and wellness. Healthcare altogether. Talk about health insurance. I have patients who cannot come back for their follow-up lower extremity procedures because they cannot pay for it. And they're on that brink of, they're not poverty, but they still need to pay their bills. So trying to find ways that patients can have that assistance. We talked about the distrust in medicine as well. Nutrition goes into play, those preventive measures that can help our patients all together in all of the different diseases. We talk about climate change as well and the zip codes that our patients live. Now, this is some information that we got initially through our COVID patients at our institution. And I just wanted to break this down that the majority of our patients in our ICUs were Hispanic and Black. Now, this was just a turnaround that we had when the majority of our patients were white. This actually also showed the disparities in disease severity in chest radiographs in patients with COVID-19. Now, I know that we're all interventional radiologists, but we're also diagnostic radiologists as well. So this definitely has an impact on what we do. And the conclusion of this paper showed that non-white patients hospitalized with COVID-19 infection were more likely to present with higher severity disease on admission chest radiographs than white or non-Hispanic patients. And increased severity was associated with worse outcomes for all patients. Now, this is a significant trend that we see in a lot of our health disparities across the board in disease processes. Now, how does this affect us as radiologists? Well, some of us may not, now this is not interventional radiology, but our diagnostic radiology colleagues may not have contact with patients, may not directly treat patients, but it still affects all of us. And this is where we can actually play a huge role in our radiology umbrella that we actually train under as well. This was some ACR chest recommendations for COVID-19. Talked about CT should not be the first line test to diagnose COVID-19. Now, the dilemma is whenever our inpatients with COVID-19, there was concern for PE, those instances that we really need to hone in on. In the ICU, we are working in the ICU these days. A lot of our colleagues are managing ICU patients. You have ICU rotations. And normally we get a CT-PE scan when we are questioning some things as correct. Now, the chances are in this COVID-19 pandemic, the patient may be non-white. Dilemma is it may be construed as we're not scanning patients with COVID-19, or we will put up a fight with referring providers ordering scans for COVID-19 patients who by percentage are marginalized patients and suffer from health disparities. Now, it was talked about earlier that there's a need for multidisciplinary communication with a focus on health disparities. We're all sitting on multidisciplinary boards for vascular disease, pelvic pain in women, tumor boards, hepatobiliary. We need to actually address these issues as we come upon these clinical situations. This is just an image taken off the web of the diversity of all of us are on this call, all of the patients that we treat as well. I want to thank you all for this, for listening to this presentation. It just touches the surface of things that we can actually do in interventional radiology. A lot of things that we can actually continue to do in our education for unconscious bias, healthcare disparities, and implicit bias. Thank you very much, Terry, and have a great rest of your day.
Thank you so much, Dr. Rachan, for sharing your knowledge on this incredibly important topic. It's actually a great segue to our next session, which will actually be a panel featuring some pioneering women in our field. Unfortunately, Dr. Newton won't be able to join us today, but I have the pleasure of introducing our three other panelists today. First is Dr. Catherine Vu. She's an associate professor of radiology, former integrated interventional radiology program director, and division chief of VIR at UC Davis. She received her medical degree and was a distinguished graduate at the George Washington University School of Medicine. She completed both her residency and VIR fellowship at the University of Colorado, Denver. She's been at UC Davis since 2012, and her clinical interests include venous disease and PAE. Dr. Ann Roberts is professor and section chief of interventional radiology at UC San Diego. She's a pioneer in the field of vascular interventional radiology and has served as former SIR president, former vice president of the American College of Radiology, and vice chair for the Department of Radiology at UCSD. She completed her diagnostic and VIR training at Mass Gen before starting at UCSD. She's won numerous awards for excellence in patient care and contributions to interventional radiology, including the SIR Gold Medal in 2015. Her research has spanned gynecological interventions, venous interventions, and bronchial artery embolization, among other topics. And finally, Dr. Vicki Marks is a professor of radiology at the University of Southern California, former diagnostic radiology program director and current associate program director. She shaped the field of VIR, paving the way as the first ever VIR fellow at Mallinckrodt Institute of Radiology, has previously served as president of SIR, president of the Association of Program Directors in Radiology, a trustee of the American Board of Radiology, and a member of the Radiology Residency Review Committee. Prior to USC, she worked as faculty and VIR section chief at the University of Michigan. So just jumping into a question for a couple of our panelists here. For Dr. Roberts and Dr. Marks, how did you discover IR? And what other specialties did you consider, and what made you ultimately choose IR?
Anne, you're muted.
There we go. You start.
Me? Okay. I started out in general surgery. And I went into general surgery for medical school because I didn't understand sodium. And I liked doing things. I wanted to see the effort and results would happen faster in surgery than in some other specialties. And so I started out in general surgery. By the end of my first year, I didn't like it. And the reason I didn't like it was that so many people in my department where I was were unhappy. And the older they were, the more unhappy they were. And I wanted to live a life that was happy and not sacrifice that for my job. So I'd been a medical student at the same institution. So I thought around what other people were doing, and I made an appointment with the head of angio at the time and asked him if he was happy. And he said he loved his job. So I went into radiology to do interventional radiology before interventional radiology had a name.
And I started off in OB/GYN because I couldn't decide between radiology and OB. And at that point, radiology didn't go through the match. So I knew I had to do an internship anyway. So I figured I would go do an internship in OB/GYN and see if I liked it or not. So I went to do that and found out I hated OB. I like gynecology. I like the surgery. And if I'd stayed in it, I probably would have been, done surgical oncology, I suspect. But I decided I didn't like it enough to stay. So since I already had my radiology residency lined up at Mass General, I said to the OB people, really sorry, but I'm going to Boston. And they weren't very happy, but I went, and it worked out great. But I must say, when I got to Mass General and started doing radiology, I hated it. And I thought, oh my God, I've made this incredible mistake, because I started off on chest and, you just sat and looked at films and CTs and, talked to people when they came down. At least they came down in those days, so you at least got to talk to them. And then I did neuro, which was just the worst. And but then I went and did GI, and I like GI because I could do barium studies and make pictures and turn people around and, make things happen. And then Peter Mueller said to me one day, he said, have you have you ever done a biliary drainage? I go, I don't even know what a biliary drainage is. So he said, oh, come with me. So we took some needles and we started stabbing them into this patient, and it was like, oh, wow, this is cool. I like this. Because we didn't do it with ultrasound. We just stabbed them. And so until we hit a bile duct, you know, but it was great. And then we put wires in and stuff. And I said, oh, this is cool. I could do this. This is fun. And then, so actually he had sort of said, okay, you can come do a fellowship with us. But then the very last rotation of my first year, I did angio, because it was separated at that point. Angio, they did, you know, vascular system, and GI did their thing, and GU did their thing, and chest did their thing, that kind of thing. So anyway, so I walked in and I did, I think maybe one day, maybe two, and I walked into Chris Athanasoulis's office, and he was the section chief, and I said, I'm going to do a fellowship in this. He looked at me like, who is this woman and what is she talking about? And so he said, well, why don't you go off and think about it for a while and come back and talk to me. So at the end of the rotation, he called me in and said, well, what do you think? What do you want to do? And I said, oh, I want to do this. He said, that's great. You got a fellowship. Just go off and do radiology and then come back and we'll train you. So that was the end of that.
That's great. Thank you both for sharing your stories there. Our next question is for Dr. Vu. How have you set, prioritized, and balanced goals for both your personal and professional lives?
Thanks, Terry. I just want to start off for thanking this panel for inviting me and being in the presence of Dr. Marks and Dr. Roberts grouped into this panel. That's amazing, because there are many amazing women in IR. Currently, when I started off 10 years ago, there was, I think the statistics was like 2%. And it was cool to see Dr. Roshan's presentation that it's like, you know, closer to 10% now. So this is really wonderful. To answer your question, Terry, as far as balancing work and life, I think that's a challenge for everyone, whether you're a woman or a man. And I think there are many men in this, you know, on this panel and in IR who, you know, are facing the challenges of family life and just balancing, you know, having a really great work-life balance. And it really comes down to having the right support. I mean, just a support of your family, friends, neighbors. I have 2 young children, 10 and almost 8. And it doesn't get any easier. It's very difficult when they're really young, and then it doesn't get any easier as they age, because there's activities and things like that. And that's where relying on neighbors has been really critical. And then having a very supportive, like, you know, family in the background, it is, I mean, it's a challenge for both men and women. So I don't think that's unique just to women.
Yeah, that's great. I think I agree. Support network is incredibly important. Our next question is for all of our panelists. What challenges did you face in trying to enter such a male-dominated field and pursue leadership positions? And how can those challenges be mitigated for other women interested in this field?
Well, I guess I'll say, since I'm the oldest one here, is that, you know, it wasn't an issue for me. I mean, you know, I'm not saying that's true for all women, but it wasn't an issue for me. I had a great support system at Mass General. I mean, they trained Irina Van Breda, who was the first woman president of SIR. They trained a whole bunch of other women. I was just one in a bunch. I mean, you know, I wasn't anything special. I was just one more of the ones that they trained. And, you know, Art Waltman and Chris Athanasoulis were just incredible, supportive kind of people. So, you know, and they just, you know, said, oh, here, do this. And so I went and did it. And then somebody else asked me to do something else, and I went and did that. And, you know, after a while, they sort of said, well, here, why don't you be in charge for a while? And I said, okay, I'll do that for a year. And that's the way it went. So, I mean, I was very supported by men. Yeah, there weren't a lot of women, you know, it was, you know, you never had to wait in line for the bathroom at the meeting. So that part was great. But it was fun. And, you know, I think the women that were there were supportive of one another, and the men were totally supportive. So for me, it wasn't, I don't know, it wasn't an issue. I'm sure that's not true for everybody.
So it's interesting, the entire world of medicine, being a physician, was completely male dominated when I went to medical school. So women were 10% of my medical school class, which was no different. So I was used to it. It just wasn't any big deal. I also found allies and professional mentors who were men throughout my career. And I would say that the main challenge I had was the first time I applied to be secretary and kind of rise up as an officer in SIR. I was turned down. You know, they chose somebody else, and then they chose somebody else, and then they chose somebody else. And what I did was I tried again. I'm not, so I was raised by my grandparents. My grandmother was a piano teacher. So why does this matter? I spent my entire growing up trying to just close out the sound of bad piano music. So I tend to be oblivious to things that I don't want to hear. So my guess is that there was, just things that happened to me that were discriminatory that I was just oblivious to and kept on going. But I did find that the male people in the radiology and in interventional radiology were not discriminatory at all. The first ever said he wouldn't let me treat him was about 2 years ago. I go on a consult for a man with hemoptysis with my senior resident at the time, and the patient would not talk to me. And he only talked to the senior resident. And we were talking about doing, a bronchial artery embolization and the potential complications and all this really serious stuff. And my senior resident was doing fine. And I finally said to the gentleman, I said, that if we do this procedure, he's just going to do what I tell him to. I'm his boss. And he goes, yes, I know. And then he kept talking to the fellow. So I said, it's fine. He can talk to the fellow. I don't care. He's got a medical problem. He doesn't need to worry about my professional my professional self-esteem. So anyway, but that happened 2 years ago. I never had anything like that happen at all. All the time when I was young, people would say, are you the doctor? And I'd go, yes, I'm the doctor. And I thought it was just kind of fun because then they'd have to deal with it. And they almost did until 2 years ago.
Remember the first time a patient at the VA told me that, you're a woman, are you going to do this to me? I go, yep. He goes, oh, okay.
Yeah, that's just no big deal.
But I grew up with 3 brothers, and the fact that I survived my childhood is probably means gives you some toughness, I guess.
Catherine, what's your experience?
So I agree with both of you, Dr. Marks and Dr. Roberts. The men in this field are so supportive and just so, they promote women in general. So it's been a wonderful field to enter. And so the disparities, I don't think occur in our specialty. And I agree with you. I feel like it's more as a female physician in improving yourself to your patients. And because I get that, I feel like when a patient, so I treat prostates, and it's, I think it's dominated by men right now in IR doing that. And so when I'm in front of a man and talking about their urinary obstruction, it just comes down to being knowledgeable and being competent and displaying that and just recognizing that they may look at you with skepticism, but proceed with confidence that I'm skilled, I'm knowledgeable, and I'm here to take care of them. So I think that's really important in IR. And, for the women, the medical students going into IR, I think, you're all very amazing. You're very strong. I used to be a program director, so I interviewed so many medical students as well as, fellowship director interviewing residents. And I think the women who come into IR, it's self-selected. You're strong women, and you don't have to prove yourself. You just move through life with confidence and just knowing your limitations, your knowledge, your skills, your strengths. That's really important. Just be confident. I think that's the most important thing.
Those are really wonderful words of advice. At this point, I'd love to open up the floor to any attendees here today who want to ask some questions to our panelists. If not, I can answer some more. I can ask some more questions.
One thing I'd like to see more, just in general in radiology. So there's so many opportunities for women to lead in IR and in radiology, and I don't think that many of the women know about it. So in this past year, my chair asked me or sponsored me. So finding good sponsors and mentors are really important. She sponsored me to be a cohort this year in the SCARD. SCARD has aligned with GE to have this leadership program for women in radiology. And so I've been selected this year as a cohort. They're trying to promote leadership in radiology, women leadership in radiology, specifically to become chair. Not that I have much desire to be chair because I love clinical work so much, but I think it's, in IR, I'd like to see more. I mean, so in my current cohort, it's mainly breast imagers and abdominal radiologists, and I'm the only IR, but I'd like to see in the future. So just keep an eye out on, whoever's on this panel, to spread the word to your residents, female residents, when they do go out into practice. There's SCARD and GE has partnered up to have this, it's like an annual leadership course.
That's great. It's wonderful to hear about those kinds of initiatives. Monica asked in the chat, do you have any advice for how to skillfully navigate questions about family life or family planning during residency interviews?
Well, they're not supposed to ask you that.
Yeah, right. That's what I was going to say.
It's an awkward time to say you're not supposed to ask me that. I would say it's hard to plan a family. I don't know. Anne, Catherine, help me here.
Yeah, there's no good time. That's what I tell my residents. There's no good time to have a baby. You just have to do it, and you just deal, and things will fall into place as far as like managing it all. And that's where having that great support system in the background is really, really important. I mean, I was pregnant during my fellowship. I had a baby during my fellowship. I didn't lose any time. I just kind of worked through it. I was lucky I was healthy. And then my second child was second year as an attending. And again, having the right support. Okay, so I said family and friends, but your coworkers. And this kind of also reflects, going back to my comment of the men in IR are so supportive.
Yeah, it's too bad Isabel isn't on the call because she did sort of the same thing. She had, I think, the first baby in residency, the second baby in her fellowship, and the third baby when she was a junior attending. So, yeah. I mean, I don't know that there's a, right or wrong, but I they're really not supposed to ask you. And so if they do ask you, I would I would kind of chalk that up as one negative about that program, that they're not smarter about what people are asking. But I think it's just fair to say, don't know what I'm going to do about it, but I'll work it out, and it'll happen. I'll get help or whatever. It's not going to be a problem. It's like, well, what are you going to do with a guy who goes off skiing and breaks his leg and can't work because he can't be on his leg for that period of time. Yeah. Or as you get older, the guys that have the heart attacks and have to be out for a while or whatever. So it's, everybody has problems. And I think that's one of the things that's really important is that, when you go into practice, the important thing is to have not only your family there, but your coworkers who are really your family as well. I mean, in a lot of ways, you spend almost as much time with them as you do with your real family, and just have them, you want to be in a group that's supportive of everybody, whatever their problems are.
So, I do think one thing to do in the interview process is to find out what the program's family leave policy is, a maternity leave policy, because they have to have one. And if you don't feel comfortable asking an attending in a formal interview, that's certainly a topic to bring up with the residents, because there's always, sessions with residents. One thing I do want to I do think it's important for residents to know is that the American Board of Medical Specialties has announced a new leave policy that allows for a minimum, I'm reading, that's why my head is turned, that allows for a minimum of 6 weeks away during training for caregiver, medical, and parental leave without extending training. The policy applies to all trainees in programs of 2 or more years of duration. Now, the implication of that is that there's some language in this policy also says that not this policy, but the way the American Board of Radiology has interpreted it, that is very flexible, but you need to, if you're planning a maternity leave or a family leave, caregiver leave, and you want to take advantage of this policy, which basically the ABMS is saying, even if you have to take a family leave during your GME training period, it doesn't change your eligibility for certification. And you can graduate on time with that. Now, obviously you have to be ready to graduate on time. And in IR, there's, case numbers you have to fulfill to be, to qualify for certification. But this is a huge change in the ABMS oversight of the certification process that is acknowledging that parenthood and early parenthood takes time. So I think that's something that everybody should be aware of.
Well, and of note, it's not just for mothers, it's also for fathers.
Right.
So
right.
They're going to be out too. So that, that makes it a little more even, I guess.
Yeah. No, it's designed to be egalitarian. And I had a similar, it's a long time ago now, but I was an attending when I had my children. But midway through my first pregnancy, I had really activity related premature labor. And I had to be on bed rest for a few days. And then when I came back to work, I basically said, look, I need to, and I was an attending, I wasn't a resident, so I was in a position of some authority. I could just decide, and people just went, okay. I said, I'm not gonna take call for the rest of my pregnancy. And I'm not gonna learn, this was when TIPS was just coming in, and TIPS was taking hours because we didn't use ultrasound for vascular access at that time, and we would be standing up for a long time. And so I said, I'm not gonna learn new procedures until I'm done with this pregnancy. But then in exchange, I'm going to take care of making the schedule, and I'm going to take care of doing resident conferences so that there was stuff that I could do that accommodated my need for less physical work, but still be a full contributing member of the division, And then basically with my next pregnancy, I said, look, halfway through, I'm going to stop taking call and we'll do the same thing, So I said what I needed and everybody said, okay.
That's really wonderful. I want to thank all of our panelists for sharing their time and their knowledge, their expertise with us. I think we can all agree that the future for women in our field is really bright, thanks to their mentorship and their contributions. At this point, I want to introduce our next moderator, Helena Rockwell, third-year med student at UC San Diego. Thanks, everyone.
Thanks for the opportunity to participate. It's great.
Thanks very much.
Thank you to our panelists for that, and thank you to Terry also for handing it over. So this is going to be the program director panel portion of our event. And just before I begin, I just want to give everyone a quick rundown of how the session is going to go. Since there is a bit of a limited time, I have some questions that are prepared for a few of our panelists to speak on at a time. But any panelists who are not speaking on that question are welcome to type their answers in the chat. And then if we have any time left over after those prepared questions, then I'll open it up to the audience and see if you all have any questions. And so you can submit those either through the chat or you can submit them through the Q&A feature if you prefer to do that. So with that, here are the introductions. So we have Dr. Vatican-Cherry, who you all have heard from earlier in the day today. So he is coming from Kaiser, LA. We also have Dr. Quinn Meisinger from UC San Diego. Dr. Woodhead, who was also in one of the earlier sessions from University of Arizona. And then we also have Dr. Fujimoto from Loma Linda University. And so we're really lucky to have all of them joining us today. We had a couple of others who unfortunately weren't able to attend, but I'm really happy that we still get to have a really good group of program directors here. So with that, the first question is, what is one character or personality trait that you often see demonstrated in successful IR applicants? And then sort of a follow-up question would be, what are some ways that applicants can also demonstrate those traits? And so I invite everyone to answer on this question.
Do you want me to lead off, Helena? It's quick.
Sure.
So, hi everyone. Sorry, I'm on vacation right now, but happy to participate. But it looks like Helena put together a great question and answer. So, I personally, for this question, I find that probably the best quality for most applicants is affability and kind of how well you get along. I usually look at the dean's letter to figure out how well you've worked in groups. And I tend to find that the best residents for our residency tend to be the one that are most affable and easygoing with everybody.
Yeah, definitely agree with that. I'll also say that somebody with a lot of grit and perseverance I'm really looking for. And I like the second part of your question really is, you know, how can we demonstrate this? Because you may be a gritty person, but how can you demonstrate this in an application? So I encourage medical students to really think about what traits that they have, because there's a lot of great traits, affability, grit and perseverance, other ones that will be mentioned, but think about how you can demonstrate that. Like say you're, you know, in your personal statement, in other things that you can do if you're a compassionate person, you know, make sure that's highlighted in your, you know, your clinical rotations, make sure that's highlighted in your volunteer experience. I think when it's scattered in multiple parts of your application, it really hits home that, wow, this person is truly this type of person, and it makes it a lot more impactful.
Hey, this is Greg Woodhead. I jump in really quickly, and look, I think I echo the things that Quinn and Scott just said. Really outstanding, you know, examples of traits we're looking for. I think, you know, residency is a long haul. It's a marathon, especially the integrated, you know, side of things. So we're looking for somebody who's got underlying enthusiasm and energy, but then also a lot of humility. I would say, you know, this process has been, you know, profoundly humbling, you know, all the way from med school through residency into being a, you know, young, you know, early career attending, and, you know, having that humility is something that we're, you know, we kind of look for, and I think it's a really great trait that's going to get you a long way. And then, you know, how do we find that? I think, echoing what Scott said, I think and Quinn said, we're looking in your letters of recommendation. I think we're, you know, that's a great place. You know, I care less about where you come from, maybe in some of the, you know, and less about some of the scores, for example, and more just about, gosh, have you done what you can to make a good impression with the folks you've worked with? And that really shows through in the letters of recommendation. So that's it. Yeah, thanks, guys.
Yeah, for me, it's, I think you have to showcase a passion for interventional surgery or interventional medicine. You know, so you know what you're getting yourself into, kind of busy interventional sub-Is, kind of surgically driven, kind of fourth year, to just know that, you know, what you're getting into. So I think that's kind of the key thing from my standpoint. I'm gonna put some information in the chat.
Excellent, thank you. With that, I'm going to go on to the next question. And so this one will just be for Dr. Fujimoto and Dr. Vatican-Sherry. So this is probably a hot topic and especially applicable to the class of 2023 and beyond. But so with the recent changes in the USMLE, so step 1 is pass-fail, there's also no more step 2 CS. How do you see the selection of applicants for interviews in residency changing?
Yeah, that's the elephant in the room for a lot of us. I don't know how I'm going to select applicants without step 2 CS. No, just kidding. I mean, I think the vast majority of us, I can't speak for everyone, but there have been surveys gone out to several program directors, and there will be an emphasis on step 2 CK. I mean, the long and short of it is a lot of us get hundreds of applications, And it is a way to kind of cull through that. It is impossible to go through 400 applications. And that's just the hard part of it. But I think we do need to recruit more attendings to look through them, because I don't think that it really is the best way to cut off. But I think I will say my program will probably have a cutoff. It'll probably be higher than the step 1 cutoff, because the truth of the matter is step 2, the mean for step 2 is about 10 to 12 points higher than step 1. So definitely for medical students, you know, it's unfortunately the truth that a lot of programs are going to heavily weigh step 2, because it's a quantitative aspect of their application. But we are moving more towards holistically reviewing applications, looking through as many as we can. I personally will look, you know, at least look through every single one, even the ones that are cut off, and I'll if people do email me and say, hey, you know, or if people I know say, hey, I have a student that, you know, they didn't do so well as they hoped on step 2, could you take a look at him? He's awesome. I mean, that goes a long way too.
Yeah, I mean, definitely the step scores matter, regardless of what we say at this stage. There's, you know, countless number of applicants, and you have to figure out ways to kind of adjust it. Right now, we're talking about the supplemental packet where we can identify, you get signals, and perhaps we'll talk about that more in the upcoming months at the AURD PDIR meeting. We'll have a med-student outreach soon about that. But basically, it limits, because right now it's a virtual world, a lot of people are applying to a lot of programs. So it's become even more challenging for us to kind of shift through all the applicants. And it's even harder for the radiology applicants than even IR, because there's more number. So certainly anything we can do, either geographic, step scores, letters of interest, will be utilized in that fashion. But also for me, I think third year scores are important, especially surgery and medicine, kind of just the crutch of what we do.
All right, thank you both for that. And then the next question that I have is, since the IR residency is still fairly new, what curriculum changes do you anticipate in the upcoming years? And so I invite Dr. Meisinger and Dr. Woodhead to comment on this.
I think one of the things that we've done at UCSD is originally we were very, very diagnostic heavy in the first 3 years, with really limited diagnostic rotations towards the end of residency. But we've kind of shifted that a little bit, because I think the reality is a lot of us in IR who are not in academics are doing at least a little bit of DR in their groups. So we want to at least have them some refreshers. So we've just kind of shifted around the diagnostic rotations a little bit for specifically our program at UCSD. And then a little bit, we've added some more sites to try to get more variety in IR procedures. I think that's kind of our main thing at UCSD.
Yeah, I would echo what Quinn said. The second component, you know, one thing we're really offering a lot at Arizona, we have PLAs, which are these kind of education or outreach agreements with different services or even community programs to get people the exposure they need doing PAD and then, you know, interventional nephrology, sort of, you know, access type work, you know, declots and those kinds of things, as well as the opportunity to scrub AAAs with our vascular surgeons as part of our program. I think Joji's got the benefit of having a lot of that kind of as part of his existing curriculum, and we just have to make sure we offer the complete array of what IR does, you know, as part of our training program. So.
Yeah, I definitely agree too. I mean, we're always trying to fill holes. I think the structure is there for almost all of our programs in terms of the rotations, but we always are identifying weaknesses, in particular procedurally, and trying to fill it in. Sorry, the water guy just walked by me on the beach.
All right, well, thank you all. I do see that we had a couple of questions coming through the audience through the Q&A function, and I think that we have about 15 minutes left, which is actually a good amount of time. So the first question that I see that's unanswered is, do your programs consider international applications? And what can an IMG do to try to get their application looked at by the program? And so anyone can answer, and if you just want to type in answer instead, that's fine as well.
You know, we definitely consider them strongly for the independent residency. You know, I know at Arizona we have integrated ESIR and independent. And one of our favorite fellows of all time is actually in her second of 2 years of fellowship. She's a woman who is from Italy, but did residency in Switzerland. And she's now, 18 months into her 2-year independent training. And she's just, been outstanding, incredible addition to the training program. So I'll say that for integrated, it's tough. There are so many outstanding kind of homegrown candidates that it can be difficult to kind of sort through, as we discussed earlier, all of the the quality applicants. So, but I wouldn't be deterred if you're somebody who's really high quality. I guess reaching out directly, via email to our admins, to our program coordinators. We'll always take a look.
I think
go ahead.
I think one thing that works really well is make sure that you get either clinical or research experience with some mentors that are US based. You can make a lot of connections and networking and have them reach out to your mentor reach out to specific programs that you are focusing on. That does go a long way. When I get an email saying I have an awesome research fellow that is always on top of things, is extremely bright. I know that it's a tough world for IMGs. Could you take a look at their application? And I definitely do that.
You can also look at prior match classes too. I mean, now pretty much every program now posts their match classes on Twitter and Instagram, so you can see, who they've had in the past. And a lot of those programs obviously will show you if they're friendly to IMGs and stuff.
All right, thank you for that. Another question that we have, and I had another one that I had prepared that could be asked and is related. So what recommendations do you have to show dedication to IR if there's not a home program at the student's institution? So kind of relatedly, aside from pursuing away rotations at other institutions that have a dedicated IR program, how can these students basically best prepare for applying to IR and successfully matching?
I think the number one thing is join SIR and get involved with the RFS MSc. I mean, I just interviewed an applicant who is from a DO school, obviously has no home program of their own, but had done, research months at Stanford, at Minnesota, like several different places. And I was just astounded. I'm like, oh, how did you get these connections? And they said through the MSc, through their the committee. So some of the committee heads that they got in touch with and were able to set up these electives for them. And I see that Dr. Cherry is writing definitely some great things.
It's all in the chat.
To check out the chat.
No, that's great. That's great. If no one else has other comments, I have another question. There are several questions actually coming through. But this one, especially with COVID, obviously things became virtual in terms of interviews. I'm not sure if you all are sure yet for the upcoming year if things will continue to be virtual, but if they do, are there going to be efforts by the programs to show candidates what the facilities are like and what the cities are like? Like, for example, will there be a sort of second look type of event for those who are able to come visit at some point, even if it's separate from the interview? Perhaps it's too early to say.
Yeah, I mean, I don't think anyone fully knows, but it's probably going to be virtual for various reasons, cost, kind of balancing out the disparities, etc. The second look is an interesting, intriguing idea. I think people have mentioned it. Obviously, we'll have to kind of see where COVID takes us, etc. But these are things that are still in flux. I think in the March, April time, we'll have a lot more information as kind of the APDR, the Associate Program Directors of Radiology, and Associate Program Directors in Interventional Radiology all meet. And so we'll have more information then.
I think we'd all love to do a second look type in-person thing. It's just the logistics and how to make it fair, as Dr. Cherry said too, is what our goal is.
Yeah, that's a
yeah. Yep.
Great.
All right, well, thank you. Another question that I have is, how do you view taking a gap year, either during or after medical school? For example, if people do a research year or if they have a master's year, do you recommend that students sort of take these years off to do these things? What are your perceptions and opinions about that?
I think if the gap year is you're doing something useful with the gap year, such as research or doing something that's a passion, such as international health or something, it's all great. It only adds to your CV and it adds to your competitiveness. But I mean, if you're just going to be a ski patrol out in Steamboat, then I don't think it's useful. It's probably pretty self-explanatory from that point of view.
Yeah, I agree. And I think what we are seeing, at least in interventional, is a lot more people doing a research year, right? That's becoming more and more apparent. Now, the timing is critical. So, maybe more, because if you take that gap year between third and fourth year, I mean, people have done it, succeeded, but others have struggled. So just have to be cognizant of that before you're away is when you take it. But I do think, it does help, and you have to know yourself.
I think it's important if IR isn't, it's also good for an exploratory year. What I'm fearful of, and I don't like some of the more competitive programs like DERM or something like that, where research years become de facto unwritten requirements. I really don't want IR to go that way. So it's more, I mean, if you're still exploring and not sure if you're fully 100% committed to IR, and a research year is something that'll get you there, I think that's a positive. But
100%. Totally agree with you, Scott.
Yeah, they can be great opportunities to go somewhere strong, network, also get excellent letters of recommendation. So when used correctly, it's a great way to improve your chances for sure.
Okay, another question is, what is your perspective on the different types of intern year options that there are? And at your program, do you require that students do surgery or medicine, or is a transitional year acceptable? And how do you view each of those?
For me, it's surgery. Even though I did medicine, I trained that way. If I could go back, I think I would have done surgery. And now I go to the OR, I work with the surgeons a lot more now. And I've realized how similar we are. I didn't understand that early on. And because I was biased to my early training, it made sense. But I think you do surgery and then you do ICU during your residency training. That seems to be the best mix, because you kind of need to get the day flow down. Like I've looked at my surgical rotators and the internal medicine rotators, and surgical rotators are just able to get the work done fast and efficient and move to the surgeries. Whereas the medicine people are a little bit, they're a little sluggish. Even in the clinic, I was surprised by this, that I would assume the medicine doctor residents would be stronger in clinic, but it's actually the polar opposite, because our surgical residents do a ton of clinic, or prelims do a lot of clinic.
I can echo that and say usually the surgical interns start out probably the strongest, but I think that for me, I don't really care what the residents do with their internship. We don't have a dedicated or comboed internship with our program, but I just want everybody to learn as much as they can and do what's right for them. And obviously, usually residents are usually most interested in location-based internships. So I'm happy to work for whatever they want to do. But as Dr. Vatican-Cherry said, I think that the surgical interns tend to have a quicker head start on everybody else.
Yes, likewise, guys. No requirements one way or the other. I do, I echo exactly what Dr. Vatican-Cherry said, and Quinn. I think people who do a surgery internship seem to have a certain resilience later on, and I think part of it's because they get it's harder. It's maybe a little bit more of a beatdown, so they appreciate radiology a little bit more. That's maybe also part of it, but I think they view patients in the way that a proceduralist does. So they are better at focused note writing and focused histories, focused physical exams. So, that's my gut feeling. But obviously no requirements.
Any comments, Dr. Fujimoto, or kind of echo the same?
Oh, yeah, I echo the same. I mean, one thing, the only way we can mandate what they do is to link our the internship, and otherwise there's no way for us to know what you're going, what you end up ranking. A lot of times it's location based. There's a lot of factors that go into it. Another thing, however, though, when you're looking at independent candidates, I don't know the answer to this, and I wonder if there are those who are more biased or less so towards people who have completed surgical internship versus medicine. However, it's, you know, I can't really hold that against somebody who wasn't really 100% sure that they're going to go into IR from the beginning, just because they went into ESIR, they wanted to explore all options and then ended up loving IR. So I can't hold that against somebody. It just kind of depends on a lot of different factors.
Well, thank you all for all of your responses. I'm glad that we got to ask some extra questions. Since we are still running a bit behind overall in the conference, I'm going to go ahead and close off at this point, but there are still some questions in the Q&A if our panelists can hang out for a second and continue to answer those. If not, we totally understand that you have other things to do on Saturday. But I just want to say a big thank you from all of us for giving us some of your time, and we really appreciate it. And then with that, up next, and I think the last thing that we have today before the Angio Club later today is our resident panel. And so Michael, who is an MS3/4 or MS3.5 from the University of Southern California, is going to be leading that panel for us. Thank you again.
Actually, in the interest of time for the vendor device breakout session, we're going to be skipping the resident panel for now, so we can get over to that in a timely fashion.
All right.
Absolutely. Yeah. So thank you all for joining. You know, we hope you really took away, you know, some educational pearls. I know I did. Lots of learning points. I really want to thank all of the organizers, presenters, panelists for taking time out of your Saturday for joining us. Right now in the chat, what I'm doing is I'm posting our vendor device breakout session. This is actually something that Lindsay and David have spent an incredible amount of work putting together, and we really hope you're going to be able to join it. Basically, it's using breakout rooms in order for all of the attendees to, you know, talk to these representatives in a one-on-one fashion. And, you know, that's honestly one of the best ways to learn. You know, the device reps work with these tools day in and day out, and, you know, they see how different physicians use them. And so it's a great way to, you know, pick their brain. And especially if you're young and getting involved in, you know, if you have a budding interest in interventional radiology, this is a great way to kind of see some of the tools that we use, some of the tools that you saw in the presentations today. I also hope that you're going to be able to join us tomorrow. We're really excited for what we have planned. We're going to be starting off with a international VIR panel. We're also going to be having, Dr. V is going to be giving us a presentation on how to succeed as a trainee, you know, a medical student trainee who's interested in VIR. He'll give you some information on, you know, what to do early on, your early clinical years, how to, you know, for example, find opportunities to get exposure to VIR, as well as how to structure your fourth year rotations in order to basically make you a really strong intern and really strong vascular and interventional radiologist. We also will be having our Angio Club later today. The registration link is on our website, so we hope to see you all there. And with that, I think we can conclude today. Again, I'm posting the vendor device breakout room in the chat, so be sure to check that out, and we hope to see you there.